Good evening, everyone. I hope I am audible and the screen is clearly visible. Please let me know if the audio visuals are clear. Let me know in the chat box once. Okay, great. Great. Hope all of you are doing really well. For those who don't know me, myself, Dr. Omkar Sangita Dileprasonone, and today we will be starting with our ENT revision session. Hopefully, those who are not aware that we have already conducted a surgery revision session. There are 3 videos of surgery revision. So hopefully, whenever you get time, you go through that as well. Now, today we'll be starting with ENT revision. Okay. Now, if I talk about ENT as a subject, please remember this ENT or Otolaryngology. This is a subject of paper 2. Okay, this is a subject from paper 2, which is highly scoring subject, guys. It is highly scoring subject. Please remember that because it will have the shortest notes possible and the strike rate can be as close as 90 to 100% as well in the subject. So please focus on this subject properly for your examination. Okay, whether it is your fmge exam or neetpg exam, for both these examinations, definitely it is a very highly scoring subject. Okay, so this is the revision session, guys. So definitely if you have studied ENT once, it will become much easier. Okay, and I hope all of you will keep on answering. Don't worry about the language. I'll be covering in Hindi as well as English. Don't worry about that. Okay, chalo. Let's start without any further delay now. Starting with in ENT, first of all, I'll be starting with the most easiest topic, and that is what is your larynx. Okay, so ear, nose, and throat. There are 3 subtopics in ENT. The first we are going to start is with your throat. In throat, definitely, please remember there are 2 cylinders. Okay, you need to remember in throat you have 2 cylinders. The anterior cylinder, which is there now, the anterior cylinder, that is what is called as your larynx, and the posterior cylinder which is there na, it is known as your pharynx. Okay, तो 2 cylinder होते हैं, आगे वाले को बोला जाता है larynx, पीछे वाले को बोला जाता है pharynx. The larynx will further continue into the trachea and the trachea will further continue into the airway. Whereas जो पीछे वाला पाइप होता है, पीछे वाला cylinder होता है, the posterior cylinder known as your pharynx, it will further continue into your esophagus and then further into your gastrointestinal tract. ठीक है? So anteriorly we have the larynx, then the trachea and the airway. Posteriorly, we have the pharynx, the esophagus, and the GIT. Okay? So that is how you need to remember. First of all, if I talk about larynx, guys, as I've told you, larynx is nothing but a cylinder or a tube which is present inside the throat, and it is present anteriorly. Now, if I talk about this larynx, this tube which is there, from where it extends, nowadays they are very fond of asking levels, vertebral levels. So you need to remember, please remember, the extension of the larynx. Larynx extends from C3 to the C6 cervical vertebra. Larynx generally extends from the 3rd cervical vertebra till the 6th cervical vertebra. So the extension of larynx is from C3 to C6. That you need to remember properly. Then if I talk about the larynx, please remember this larynx usually it is made up of some cartilages. The outline or the framework of the larynx jo hota hai na, it is made up of cartilages, whereas in between the cartilages we also have some muscles. So cartilages and muscles will make up the larynx. Okay, if I talk about the cartilages, how many cartilages make up the larynx? So please remember there are total 6 cartilages which will make up the larynx. Okay, total kitne cartilages banate larynx? There are total 6 cartilages which makes up a larynx. Out of these 6 cartilages, 3 of them are unpaired. That means single cartilage होता है. इनका कोई pair नहीं होता, ये अकेले अकेले होता है. 3 of them are unpaired cartilages, whereas the other 3 are paired cartilages. Okay, so out of the total 6 cartilages which makes up the larynx, 3 are unpaired and 3 are paired cartilages. Now, if I talk about the 3 unpaired cartilages, what are these? The first and the largest laryngeal cartilage is known as thyroid cartilage. So if they ask you which is the largest laryngeal cartilage, answer is thyroid cartilage. Next is important. Yes, ETC is the mnemonic to be remembered. Next is the ring-like cartilage beneath the thyroid cartilage. This is your thyroid cartilage. Beneath this thyroid cartilage, we have another ring-like cartilage, and that is what is called as the cricoid cartilage. That is what is known as your cricoid cartilage. And then apart from this, now these are 2 external cartilages जो बाहर से देख पा रहे हो. One is the thyroid, other is the cricoid. But one unpaired cartilage is present inside the larynx. And that unpaired cartilage is the leaf-like cartilage. Okay, that is the leaf-like cartilage, and which opens or closes the larynx. Okay, it can open or it can close the larynx. That is important, and that lies above the vocal cord. What are true vocal cords known as? True vocal cords are known as glottis. Therefore, a cartilage which lie above the true vocal cords will be called as epiglottis. That is above the glottis. Okay, so the third one is known as epiglottis. Please remember that. Now, important is if they ask you about the three paired cartilages of larynx. The most important out of them, the three paired cartilages, are definitely the arytenoid cartilages. These are definitely the arytenoid cartilages. The other ones that you need to remember are cuneiform and corniculate cartilages. The other two are cuneiform and corniculate cartilages. Please remember that, okay? Cuneiform and corniculate cartilages. No issues till anybody? So these are the important things you need to remember. Now, if I talk about the important one-liners or important questions which have come from this topic, yes, anatomy is very important from larynx. There have been multiple number of questions, okay, from anatomy of larynx. So please remember that. Which cartilage does not ossify with age? Which cartilage does not ossify with age? Now, what is ossification? Ossification is nothing when the cartilage becomes hard. Cartilage becomes like a bone. Why the cartilage will become like a bone? Due to deposition of calcium inside it. Okay, and this calcification or this ossification generally begins at around 25 years of age. Most of the cartilages in the body will ossify with age. Okay, so please remember in larynx also. Okay, in larynx also we have certain cartilages which will ossify. Okay, in larynx also the cartilages which will ossify, these are hyaline cartilages. Okay, so yes, the hyaline cartilages are the ones which will ossify with age. Okay, and these are nothing but your thyroid cartilage. Next is your arytenoid cartilage, the majority of the arytenoid cartilage, and the third one is the cricoid cartilage. So the three hyaline cartilages which will ossify with age are definitely thyroid, arytenoid, and cricoid cartilage. But the ones which will not ossify with age, please remember they are epiglottis, cuneiform, and corniculate. But the important thing is this cuneiform and corniculate are very small cartilages, and they are rudimentary in nature. What do I mean by rudimentary? That means the structure which have no functional value. इनका कोई काम नहीं होता है. Okay, so cuneiform and corniculate are rudimentary in nature. They have no functional value. Okay, so they are also elastic cartilages. Okay, and the elastic cartilages are the one which will not ossify with age. So the elastic cartilages are the one which will not ossify with age. Two of them are definitely cuneiform and corniculate, but they are not so important that we know. Therefore, the one question that had come earlier was epiglottis. So please remember E for epiglottis, E for elastic. So please remember the elastic cartilage will never ossify with age. Okay, and the elastic cartilages in the larynx, the most important to be remembered is definitely your epiglottis. The other two to be remembered are the cuneiform and the corniculate. Okay, so these are the cartilages which will not ossify with age. The next important question is which cartilage makes the posterior 1/3 of the vocal cords? Now the true vocal cords that we know, definitely these true vocal cords which are there, the anterior 1/3 of these true vocal cords is membranous, but the posterior 1/3, okay, the posterior 1/3 of these true vocal cord which is there, it is definitely cartilaginous. So this anterior 2/3 is membranous, but the posterior 1/3 is cartilaginous. And please let me know which are the cartilages which will make up the posterior 1/3 of this vocal cord. So the posterior 1/3 of your vocal cord is made up by which cartilages? So please remember the posterior 1/3 of your vocal cord is made up by the arytenoids. Very good. Okay, so the arytenoid cartilages are the ones which will make the posterior 1/3 of the vocal cord. So ये जो मैंने दो निकाले हैं ना, these are nothing but your arytenoid cartilages. Okay, so the arytenoid cartilages, they will make up the posterior 1/3 of vocal cord. Therefore, the anterior 2/3 of vocal cord is membranous, whereas the posterior 1/3 of the vocal cord is cartilaginous. That you need to remember properly. Very good. Now, if I talk about the embryology of this, okay, embryology of the larynx, definitely. If I talk about the embryology of larynx or pharynx, please remember the larynx as well as the pharynx, both of them are derived from the 4th and the 6th pharyngeal arc. Yes, I hope all of you are quite aware. During the fetal development or during the embryological development, at the level of the neck, we have these pharyngeal arcs or the branchial arcs which are formed. They are 1, 2, 3, 4 and 6. Why? Because the 5th pharyngeal arc or the 5th branchial arc, it usually obliterates, it usually disappears. जो पांचवी arc होती है ना, वो आगे जाके develop नहीं होती है. Only 5 arcs will develop, 1, 2, 3, 4 and 6. Out of them, the 4th and the 6th arc which are there, they will form the larynx as well as the pharynx. Now, if I talk about the fourth pharyngeal arc first. This fourth pharyngeal arc or the sixth pharyngeal arc, we know these branchial arcs which are there, they are made up of mesoderm. Yes, they are made up of which germ layer? They are made up of mesoderm usually. So the fourth pharyngeal arc which is there, it will develop into the three laryngeal cartilages. And these three laryngeal cartilages are remembered by the mnemonic CUTE. Okay, they are remembered by the mnemonic CUTE, where CU goes for cuneiform. CU goes for cuneiform, T goes for thyroid, T goes for thyroid, and E goes for epiglottis. Okay, E goes for epiglottis. So these are the three important laryngeal cartilages which will develop from the fourth pharyngeal arc. That's the important thing. Next important thing you need to remember is the muscles. So please remember all pharyngeal muscles which are there. Yes, all pharyngeal muscles are developed from the fourth pharyngeal arc except one. All pharyngeal muscles develop from the fourth pharyngeal arc except one. And that is what is called as stylopharyngeus. Can anybody tell me that stylopharyngeus develops from which pharyngeal arc? Stylopharyngeus muscle develops from which pharyngeal arc? That is a very important question. That is a very important question. Please let me know jaldi se. So all pharyngeal muscles which will develop from the fourth pharyngeal arc except the stylopharyngeus. So stylopharyngeus develops from which pharyngeal arc then? Please let me know that. Okay? So till that time I'll tell you, please remember, apart from this, in larynx we have two groups of muscle. The one group of muscle which are usually present outside the larynx, these are called as extrinsic muscles. And the muscles which are present inside the larynx will be called as intrinsic muscles. So please remember all the extrinsic muscles, जो बाहर present होते हैं ना externally, all the extrinsic muscles of larynx also develop from the fourth pharyngeal arc. All the extrinsic muscles of larynx also develop from the fourth pharyngeal arc. It is not the second, it is the third. Please remember, yes, all the pharyngeal muscles develop from the fourth pharyngeal arc except stylopharyngeus, and stylopharyngeus develops from the third pharyngeal arc, and this was a previous year question. Okay, so that's important to be remembered. Okay, no issues till anybody. It is the third pharyngeal arc. Third pharyngeal arc. Please remember that. Then if I talk about the superior laryngeal nerve. Okay, so please remember the superior laryngeal nerve also develops from the fourth pharyngeal arc. Yes, there are two nerves which will supply the larynx. One is called as the superior laryngeal nerve, SLN, and the other is called as the recurrent laryngeal nerve, known as RLN. So the superior laryngeal nerve will develop from the fourth pharyngeal arc. Then if I talk about the sixth pharyngeal arc, guys. Now sixth pharyngeal arc se बच्चे कुछ laryngeal cartilages develop होंगे, and what were those? They were definitely CAC cartilages. Okay, so the CAC cartilages develop from the sixth pharyngeal arc. The CAC stands for C goes for cricoid, A goes for arytenoids. Okay, so C goes for cricoid, A goes for arytenoids, and the next C goes for corniculate. The next C goes for corniculate. So the CAC cartilages usually develop from the sixth pharyngeal arc. Okay, these are cricoid, arytenoids, and corniculate. Now, which muscles are left? Definitely, extrinsic muscles of larynx develop from the fourth pharyngeal arc. Therefore, all the intrinsic muscles will develop from the sixth pharyngeal arc. So please remember all the intrinsic muscles of larynx which lie inside the larynx, जो अंदर present होते हैं. All intrinsic muscles of larynx will develop from the sixth pharyngeal arc. Here also there is an exception, and this exception you always need to remember, because ये जो muscle होती है ये always exception में आती है. All intrinsic muscles develop from the sixth pharyngeal arc except, and that exception is what is cricothyroid. That exception is what is cricothyroid muscle. Now please let me know, cricothyroid develops from which arc then? Please remember all intrinsic muscles of larynx develop from the sixth pharyngeal arc except the cricothyroid, and cricothyroid muscle develops from which arc then? Along with that, the nerve that you need to remember is RLN over here. Yes, superior laryngeal nerve was developing from fourth pharyngeal arc. Likewise, the recurrent laryngeal nerve or the RLN will develop from the sixth pharyngeal arc. So these are the important things about embryology you need to remember. Okay? So cricothyroid generally develops from the fourth pharyngeal arc. Cricothyroid develops from the fourth pharyngeal arc. Okay, cricothyroid generally develops from the fourth pharyngeal arc, and this has been previous year questions, guys. Don't make a mistake. Okay, remember the exceptions, those are very important. Okay, chalo. Once we are done with the embryology, now you know all the structures of the larynx and pharynx, where they come from, where they are derived from. You know the embryology now. Okay, so it becomes much easier now. Now let's talk about the vocal disorders, guys. Now, first of all, if I ask you what is the main function of the larynx, please let me know what is the primary function of larynx. Please let me know in the chat box what is the primary function of larynx. What do you think is the primary function of larynx, guys? What is the primary function of larynx? What is the primary function of larynx? Anybody? Please let me know once. So it's not phonation. I know a lot of people will answer it at phonation, but please remember phonation or sound production or voice production which is there, it is not the primary function of larynx. It's one of the secondary functions. If they ask you what is the primary function of larynx, your answer should be protection of the lower airway. Yes. Okay, the main function of larynx is nothing else but the protection of lower airway. What is your lower airway? It is nothing but your lungs. Okay, so definitely protection of lower airway is the primary function of larynx. That is clearly written in every textbook. Okay, so it is definitely the protection of lower airways which is the primary function of larynx, because anything can enter into the airway na? And if anything can enter into the airway, it will directly go to the lungs and that can lead to infection. The patient can land up into pneumonia and that can progress further into lung abscess also. So therefore the lower airways or the lungs have to be prevented, and that is what is done by larynx. Yes, one of the secondary functions is definitely phonation, as I've told you, and phonation is nothing but voice production. Now there are two vocal cords which are present in the larynx. All of you might be quite aware. There is also a false vocal cord which is nothing but a mucosal fold or ventricular bands, whereas there is a true vocal cords also, and the true vocal cords are known as glottis. So the voice production which is there, or the phonation function which is there, it is done by the true vocal cords. In which position? In closed position. Yes, true vocal cords in closed or adducted position will lead to voice production. And when which phase of respiration? In the expiratory phase of respiration. जब तुम हवा बाहर फेंकते हो तब vocal cords vibrate होगे और तब sound produce होता है. ठीक है? So the phonation or voice production is the function of the true vocal cords or glottis in closed position or in adducted position during the expiratory phase of respiration. Now if I talk about phonation or voice, usually in an adult male, please remember, in an adult male, the normal voice which is there now, it is a low pitch voice or a low frequency voice, or we can call it as the dull voice. Okay, so low pitch, low frequency or a dull voice is there in an adult male. If I talk about the adult female on the other hand, adult females may, please remember, the voice which is there in an adult female is definitely a high pitch voice, a high frequency voice, also known as a sharp voice. Okay, there's a reason behind this as well. You don't need to तुम्हें रट्टा लगाने की जरूरत नहीं है. Please remember, adult male में why there is a low pitch or a dull voice? Because the vocal cords are longer, and as the vocal cords are longer, definitely, therefore they are loose as well. Okay, therefore they are loose. As the vocal cords are loose, if you consider a instrument, musical instrument like a drum or a dhol. Okay, so if you have a musical instrument like a dhol or a drum, now if the membrane of this musical instrument is loose, what kind of voice it will produce? The sound it will produce will be a very dull sound or a low pitch sound, right? The same is applied for male vocal cords as well. The male vocal cords are longer and therefore they are loosely attached, and that is the reason why a low pitch or a dull voice is produced. On the other hand, the female vocal cords are shorter in length. As the female vocal cords are shorter in length, they are tightly attached. And as they are tightly attached, therefore the quality of sound which is produced is a high frequency, high pitch or a sharp voice. But what if it gets vice versa? उल्टा हो जाता है. अब क्या हो जाएगा? So definitely, then the patient will suffer from vocal disorders. If I talk about the vocal disorders, if an adult male is having a high pitch voice, normally which kind of voice is present in an adult male? Normally there is a low pitch voice. But if an adult male is having a high pitch or a feminine voice, if an adult male is having a high pitch or a feminine voice, that condition is what is called as puberphonia. That condition is what is known as puberphonia. Whereas on the other hand, if adult female, normally adult female has which kind of a voice? Adult female normally has a high pitch voice. But if a adult female has a low pitch or a dull voice, if a adult female has a low pitch or a dull voice, that condition is what is called as androphonia. That condition is what is known as androphonia. No issues with this, anybody? That's the important thing. Now, if they ask you about the treatment of choice, usually they will mention that there is a college going guy who comes to you with a feminine kind of a voice. His friends have started teasing him. Now, what is the treatment in this condition? So now we know if there is a feminine voice in an adult male, it is suggestive of puberphonia, and the treatment of choice. Initially, we will go for a speech therapy. Initially, we will go for a speech therapy. Okay. So here we will ask the patient to press this thyroid cartilage backwards and then try to speak. As the patient pushes this thyroid cartilage backwards, the vocal cords become loose and therefore the voice which is produced now will be a low pitch or a dull voice. Okay? And this speech therapy, very good. It is known as the Gutsman's maneuver. Very good. This speech therapy which is there is known as the Gutsman's maneuver. Very good, all of you. Okay, so you need to remember, if a male is having a female-like voice, ask him that, hey man, have guts and speak like a male. Okay, so that's how you can remember it. The speech therapy which is used in puberphonia is known as the Gutsman's maneuver. And Gutsman's maneuver is usually tried for how much time? It is usually tried for a span of 3 to 6 months. But even after 3 to 6 months, the patient is having no improvement. Then definitely we need to go for a surgical management, and that is what is called as type 3 thyroplasty. That is what is known as type 3 thyroplasty. I've always told you, what do we mean by plasty? Plasty का मतलब होता है repair or reconstruction. Okay, plasty means repair or reconstruction, definitely. Okay, so thyroplasty is nothing but repair or reconstruction of the vocal cords. Repair or reconstruction of vocal cords will be called as thyroplasty. And type 3 thyroplasty mein we will do nothing. We will go for a surgical shortening. We will go for surgical shortening and loosening of the vocal cord. We will go for surgical shortening and loosening of the vocal cords. Okay? That is what is done in type 3 thyroplasty, which is the definitive management if Gutsman's maneuver fails in cases of puberphonia. Next, if I talk about androphonia, what is the treatment of choice in androphonia? In androphonia, we cannot ask the patient to pull the thyroid cartilage in front. Na? Therefore, here there is no speech therapy which will work. Here we will directly go for a surgery, and that surgery is what is called as a type 4 thyroplasty. In androphonia, the treatment of choice which is there is a type 4 thyroplasty, and vice versa will be done over here. What we will do over here in type 4 thyroplasty? We will go for surgical lengthening and tightening of the vocal cord. We will go for surgical lengthening and tightening of the vocal cord. Okay, surgical lengthening and tightening of the vocal cord. Now, how you need to remember if you are getting confused, please remember, okay, so if it is in your papa, okay, if there is a female like voice, I'm not referring, I'm just making you understand, okay, don't take it personally, okay, if there's a female like voice in papa, definitely that condition is known as puberphonia. But if there is a male like voice in amma, then that condition is what is called as androphonia. That's how it becomes simple. Okay, you will not get confused at all. Okay? Sure. Moving further, that was about your vocal disorders you need to remember. Next, if I talk about is this. What is this investigation? Now, please let me know, what is this investigation? Is it a indirect laryngoscopy, direct laryngoscopy, flexible laryngoscopy, or rigid laryngoscopy? You have 4 options with you. Please answer in the chat box. Which kind of laryngoscopy is it? What is scopy? Scopy is nothing but examination. And what are we trying to examine? We are trying to check or examine the larynx. Therefore, this investigation will be called as laryngoscopy. But which type of laryngoscopy is it? Please let me know that. Please let me know that in the chat box. Which type of laryngoscopy is it? Very good. As you can see, here we are using a straight mirror. Okay, yes, this mirror does not have a curvature. It is not turned anywhere. So definitely we are using a straight mirror. And this straight mirror is generally used in a procedure which is done in the OPD itself. Yes, it is a OPD procedure. And this is done to examine the larynx. And this, you can see, this straight mirror is inserted along the palate. And we go till the posterior pharyngeal wall. And then you can see in this mirror the reflection of the larynx. As you are not seeing the larynx directly, you are seeing it, you are actually able to see the reflection of the larynx. Definitely, therefore, this procedure is known as a indirect laryngoscopy. This one is known as the indirect laryngoscopy, done in OPD just for examination of the larynx. And here you will be able to see the reflection of the larynx. That is what is the indirect laryngoscopy. No issues with this, anybody? On the other hand, if I talk about this one, what is this definitely? This one is a direct laryngoscopy now. This one is what is called as a direct laryngoscopy. Please remember, here what are you able to see? That this procedure, here we have having this instrument in hand. And what is this instrument? This instrument is nothing but your direct laryngoscope. Now, this direct laryngoscope can be of 2 types. You might have studied this in anesthesiology as well. So this direct laryngoscope can be either a curved blade laryngoscope or it can be a straight blade laryngoscope. Okay, so it can be either a curved blade laryngoscope or it can be a straight blade laryngoscope. This is the handle of the laryngoscope and these 2 are the blades. If it is a curved blade laryngoscope, you need to remember it as Macintosh laryngoscope. Okay, always highlight this C over here. Okay, curved blade laryngoscope, you need to remember it is a Macintosh laryngoscope, and very good, it is used for direct laryngoscopy in adults. Very good. Okay, so the curved blade or the Macintosh laryngoscope is used for direct laryngoscopy in adults. Whereas if it is a straight blade laryngoscope, always highlight this else over here. Okay, so the straight blade laryngoscope which is there, definitely you need to highlight these L, and remember it is a straight blade laryngoscope, and this is generally used in pediatric patients. To be specific, in the infants. Okay, to be specific in the infants, please remember usually, but we can just remember in pediatric patients as well, we can use the straight blade or the Miller's laryngoscope. Now usually during direct laryngoscopy, as you are inserting this huge blade inside the patient's throat, okay, therefore the patient should be sedated, and if a patient is sedated, definitely the patient has to be taken to the OT. Okay, so direct laryngoscopy could not be performed in OPD. It is always a OT, operation theater procedure. Please remember that. And please remember, direct laryngoscope is always to be held in the non-dominant hand. What do I mean by this? If you are a right-handed person, always hold the direct laryngoscope in your left hand. Okay, why? So that your dominant hand is free for procedures. So that your dominant hand, whichever is there, okay, so the dominant hand is free, and free for what? Free for performing procedures. What are the two procedures that we can perform with direct laryngoscopy? What are the two important procedures that can be performed with direct laryngoscopy? One is definitely, as you can see here, we are trying to intubate the patient, as we have discussed in surgery and anesthesia also. Please remember, if you want to intubate a patient, if you want to insert an endotracheal tube into the throat of the patient, you need to perform a direct laryngoscopy. So first indication is intubation, and second, if there is some mass, okay, in the throat of this patient or in the larynx of this patient, and you need to take a biopsy from that mass, for that also you need to perform a direct laryngoscopy. So the second indication is a biopsy. The first indication is intubation, second indication is a biopsy. Okay, that's important. And the next image that we have, it is also done for examination of the larynx. So this is also a laryngoscopy, but here you can see it is a wire which is there. Okay, here it is a wire which is there. So this wire can move in any direction. So this is what is called as a flexible laryngoscopy. Okay, this is what is known as your flexible laryngoscope. Okay, and this flexible laryngoscope which is there, it is generally used to perform examination of the larynx nowadays more commonly than indirect laryngoscopy. Okay, because indirect laryngoscopy cannot show you all the structures. Okay, there are some limitations of indirect laryngoscopy. Therefore, a lot of times we are using this flexible laryngoscope nowadays for examination of the larynx in the OPD itself. Okay, you will just insert this laryngoscope via the nose. Yes, so that you can also examine the nose of the patient with this flexible laryngoscope. Okay, no issues with this, anybody? That's important. Now, please answer this question. Please answer this question. We have, is it stuck? I hope now it is not stuck anymore. So now we have this question. So please remember, if there is a wire which is there, okay, to the laryngoscope, it is a flexible laryngoscope which was given in the image, and flexible laryngoscope is generally used for examination of the larynx nowadays in OPD, because indirect laryngoscopy has some limitations, and therefore we will use a flexible laryngoscope nowadays. Okay, so that's the important thing what I've told. Now please answer this question. A male smoker presents with hoarseness of voice. Important is, please remember one thing. If they mention hoarseness of voice, you need to think that there is some problem with the vocal cords. Okay, or if I say, if there is any problem with the vocal cords, what will be your complaint? Definitely you need to answer it as hoarseness of voice. Please remember that. You need to answer it as hoarseness of voice. Please remember this. No issues with this, anybody? So a male smoker presents with hoarseness of voice and diagnosed with keratosis larynx. Okay, what is keratosis larynx, guys? Please remember. Yeah, there can be two conditions. Please remember, there are two conditions which are possible in a smoker, and the patient presents to you with hoarseness of voice. One is definitely keratosis larynx. The other one we will discuss later is known as Ranke's edema. But here they have given a case of keratosis larynx. Now what is keratosis larynx? Now, what is the normal lining of your larynx? Please remember, the normal lining of your larynx is definitely the pseudostratified ciliated columnar epithelium. The normal lining or the normal epithelium of your larynx is pseudostratified ciliated columnar epithelium, except the vocal cords. Yes, All the larynx is lined by pseudo-stratified ciliated columnar epithelium except the vocal cords. Please tell me the lining of the vocal cords. Please tell me the lining of the vocal cord. What is the lining of the vocal cords? What is the lining of the vocal cords? Now, if I talk about if a patient is a chronic smoker, not in all smokers, but in few smokers, what will happen? The vocal cord epithelium which is there, now, due to the stress of smoking, this vocal cord epithelium starts to shed at a faster rate. क्या होता है? वो निकलने लगता है. Vocal cord को जो epithelium है ना, वो shed off होने लगता है. There is shedding of the vocal cord epithelium at a faster rate. Okay. And therefore, the patient develops hoarseness of voice. And that condition is what is known as keratosis larynx. The treatment will be what? Okay, yeah, you will get the notes, don't worry about that. Okay, so definitely the treatment for this condition, keratosis larynx, is decortication. Okay, the treatment is definitely decortication. And what is decortication? Most of you are right, definitely stripping off the mucosa of vocal cord. The mucosa or the epithelium of the vocal cord which is there now, we will remove that mucosa of the vocal cord. So you will say, sir, how are we removing it? Don't worry, it will regenerate. अपने आप बन जाएगा वो वापस. Okay, but please remember, decortication is nothing but stripping off the mucosa of the vocal cord. That is what is the treatment of choice in case of keratosis larynx. And along with that, definitely, if the patient does not want it to develop again, so definitely the patient has to quit smoking as well. Definitely the patient has to quit smoking along with it. Now, please let me know, what is the normal lining of vocal cord? Nobody has answered the question yet. So please remember, as I've told you, all the larynx is lined by pseudo-stratified ciliated columnar epithelium except the vocal cords, because the vocal cords usually are lined by stratified squamous epithelium. The vocal cords which are there, they are lined by stratified squamous epithelium. That you need to remember. Okay, so this is important. Moving further now. Next question, if I talk about, here we have a patient who complains. Okay, we have a patient who complains of weak and a breathy voice. Patient has this kind of a voice. Okay, there is a breathy voice, a lot of so there's a weak and a breathy voice which is there in the patient. Laryngoscopic examination is given below. What is the diagnosis? Okay, so a patient coming to you with weak and a breathy voice, and the laryngoscopic examination is showing what? You can see that the vocal cords are trying to close, but are they closed completely? No. The vocal cords are not able to close completely even after complete adduction. I hope all of you are quite aware about adduction and abduction. Adduction is towards the midline. Abduction is away from the midline. Okay? So here the vocal cords are trying to adduct. They are trying to close. Even after complete adduction, what you can see? A gap is left in behind. This gap which is there is an elliptical gap. Okay? This gap which is there is an elliptical gap. Okay? Sometimes we are also able to see such kind of a gap. There is an elliptical gap also, and there is a triangular gap also. So if we are able to see such kind of a gap, a elliptical as well as a triangular gap, then this is what is called as a keyhole glottis. Then this is what is called as the keyhole glottis. Okay? That is what is known as keyhole glottis. So now please let me know, if a patient is having weak breathy voice and laryngoscopy shows you a gap in between the vocal cords, either a elliptical or a keyhole glottis, then what is your diagnosis? The diagnosis of this condition is what is called as phonesthenia. Please remember, the diagnosis in this condition is what is known as phonesthenia. Please remember this. Okay, so what is phonesthenia? Now please remember, usually in the vocal cords, okay, in the vocal cords we have two types of muscles in the body of the vocal cords. One is called as the thyroarytenoid muscle. The red one that I am drawing is known as thyroarytenoid, and the second one that I am drawing between the arytenoid cartilages posteriorly, this is interarytenoid muscle. Now if the thyroarytenoid or the interarytenoid muscles are weak, what will happen? Please remember, what is the normal function of thyroarytenoid and interarytenoid muscle? Both of them when contract, they will be responsible for closing the vocal cord. जब दोनों की दोनों मसल कॉन्ट्रैक्ट होगी तो vocal cords क्या हो जाएंगे? क्लोज हो जाते हैं. ठीक है? So their function is closing the vocal cord or nothing else but adduction of the vocal cord. Okay, so both of these are adductor muscles of vocal cord. Thyroarytenoid as well as interarytenoid are adductor muscles or closure muscles of vocal cord. So if these muscles are weak, will they be able to close completely? No. As these muscles are paralyzed or these muscles are weak, definitely they are not able to close completely, and therefore even after complete adduction, some gap is left in between. So if the thyroarytenoid is weak, elliptical gap is left in between. And if both the muscles are weak, then a keyhole glottis is left in between. Then a keyhole like gap is left in between. That condition is what is called as phonesthenia. Okay, so please remember, what is phonesthenia? It is nothing It is due to weakness. Okay, it is nothing but weakness of the adductor muscles. And which two adductor muscles? I've already told you. It is thyroarytenoid and interarytenoid muscle. So weakness of the thyroarytenoid and interarytenoid muscle. This leads to a gap even after complete adduction of vocal cords, and that is what is known as phonesthesia. And due to this gap, what will happen? A lot of breath will be there. Okay, a lot of air will be there when you try to speak, and therefore you will get a weak or a breathy voice. What is the treatment for this condition? The treatment for this condition is just speech therapy. So the treatment for phonesthesia is nothing else but speech therapy. Okay? Moving further now. Next condition. This image was a previous year question. Please let me know. Here I am giving you a history that this person is a chronic smoker. This person is a chronic smoker, and that person who has come to me with a complaint of hoarseness of voice. That person has come to me with a complaint of hoarseness of voice. And when I do a laryngoscopic examination of this patient, on laryngoscopic examination, I am able to see such type of vocal cords. What are you able to see in this vocal cords? Normally, vocal cords are like strings, right? We have drawn that the vocal cords are always like strings. But here you can see that the vocal cords are not like strings. Mote ho chuke hai vocal cord, okay? The vocal cords are swollen. So what is this condition known as? Anybody? What is this condition known as? Please let me know in the chat box. This condition is what is called as, very good, Larynx edema. Okay, so this condition is what is known as Larynx edema. Very good. All of you, diagnosis is right. That is called as Larynx edema. We know what is edema. Edema is nothing but swelling. In literal terms, edema का मतलब होता है swelling. And why there is swelling? Swelling is due to collection of fluid. पानी भरने की वजह से, okay? So there is collection of fluid inside the vocal cords, and that causes this Larynx edema in the patient. Now important is, where is this Larynx edema? I hope all of you are quite aware. If I draw this vocal cord, the outer surface of the vocal cord is made up of the mucosa. The outermost layer of the vocal cord is the mucosa. And mucosa is lined by epithelium. And what was the epithelium of vocal cord? I've already told you. It is stratified squamous epithelium. Then we have the vocal ligament over here. The purple color that I'm drawing is what is your vocal ligament. Okay. So the space that you can see over here, the space between the mucosa and the vocal ligament, the space between the mucosa and the vocal ligament is what is called as your Larynx space. And if there is edema or collection of fluid inside this Larynx space, then that is what is called as Larynx edema. What is the most important risk factor for Larynx edema? Please remember, the most important risk factor for Larynx edema is smoking, as we know. And what is the most important complaint? We know that it is hoarseness of voice as well. Okay, so here you can see that these are the actual vocal cord and this is the mucosa. Okay, so in between the layers of the vocal cord, you can see there is collection of fluid over here. The purple one that you can see, it is the collection of fluid. Very good. Yes. So Larynx edema is actually a submucosal or a subepithelial space which contains high amounts of loose areolar tissue. And if the cells are loosely arranged, if it is a loose areolar tissue, then there are high chances of edema. So याद रखना है ये बात कि जहां भी ज्यादा loose areolar tissue होगा वहां edema के chances ज्यादा होते हैं. Wherever there is more amount of loose areolar tissue in the body, more chances of edema will be seen at that place. Okay, so definitely this is what is the case of Larynx edema that you need to remember properly. What is the treatment for this condition now? What is the treatment of choice for Larynx edema? What is the treatment of choice for Larynx edema? So two conditions I've told you which are seen in smokers, and both the patients will come to you with complaints of hoarseness of voice. The treatment for both of them is also same. The treatment for both of them is also same. What should be done? Just remove the mucosa. If you remove the mucosa, what will happen? All the fluid which has been collected beneath the mucosa will drain. जितना भी fluid mucosa के नीचे जमा है वो सब निकल जाएगा. So just strip off the mucosa. And stripping of vocal cord mucosa is what is called as decortication. Very good. So stripping of vocal cord mucosa is what is known as decortication. And along with that, definitely the advice that you need to give is quit smoking. Otherwise the patient will have recurrence again. वापस से patient complaint लेके आएगा ये तुम्हारे पास. ठीक है? So that's important. So keratosis larynx and Larynx edema, दोनों के लिए the treatment of choice is decortication and quit smoking. ठीक है? That's important. चलो. Now important is, what is this? Make a spot diagnosis of this condition. Make a spot diagnosis of this condition. I'm telling you this is a congenital anomaly. I'm telling you this is a congenital anomaly of the vocal cords or congenital anomaly of the larynx. Okay, congenital, that means which is present since birth. And it is due to inadequate or incomplete recanalization of the vocal cord. Okay, जो canalization होना चाहिए था वो properly नहीं हुआ है. The canalization was not complete. Therefore, some amount of tissue, some amount of cells were left in between the vocal cords. What is this condition? Make a spot diagnosis for this. Spot diagnosis. Just tell me the diagnosis. That's it. What is the spot diagnosis for this condition, guys? I'll come to that. Complication kya hai na? I'll tell that. It is not laryngomalacia. It is not laryngomalacia. Laryngomalacia mein to it is an anomaly of the larynx, definitely. Congenital, that too. But over there you are able to see the epiglottis, which is omega shape. Here you are not able to see any epiglottis. Here you are able to see the glottis. These are the vocal cords. And in between the vocal cords, we have this extra tissue which is present. We have this extra tissue. Very good, strange. Very good. The first one to answer. It is laryngeal web. Very good. So it is nothing but a laryngeal web. Please remember. It is nothing else but a laryngeal web. Please remember. Okay. So web is nothing but a tissue which is present inside the larynx since birth. And it is usually present between the vocal cords. So yaad rakhna hai, the most common site for laryngeal web. The most common site for laryngeal web is actually the glottic web. The most common site for the laryngeal web is usually the glottic web. Please remember that. What is the treatment of choice for laryngeal web? What is the treatment for laryngeal web? Anybody? Here the patient will have, the child will be brought to you and the child usually has a hoarse cry. Okay, the child usually has a hoarse cry. That is the complaint of the child. I told you, anything related to vocal cords, complaint will be hoarseness. So here the child has hoarse cry. Very good, very good. Yes, it is the glottic web. Okay, what is the treatment? So please remember, we will use a laser and with the help of that laser, we will burn this extra amount of tissue which is there. Okay, we will burn this extra amount of tissue which is there, and that is what is called as CO2 laser excision. That is what is known as CO2 laser excision. Okay, so for laryngeal web which is there, definitely we will go for CO2 laser excision. Okay, so that's the important thing. Very good. Now somebody was asking what can be a complication of removal of mucosa, or what can be a complication of decortication. So yaad rakhna, if you remove the vocal cord mucosa, if you remove the vocal cord mucosa from this vocal cord also and this vocal cord also, दोनों का एक साथ निकाल दोगे तो क्या हो जाएगा? Both of them will start regenerating, and regeneration is done by fibroblast. Now when the fibroblasts are coming, usually they will form the vocal cord mucosa again. But due to this fibroblastic action, there can be adhesions which can be formed. Okay, there can be adhesions, or they are also known as synechiae, which can be formed in between the two vocal cords. क्या होगा? In simple terms, दोनों vocal cords regeneration के time एक दूसरे से चिपक जाते हैं. That is what is adhesions or synechiae. ठीक है? So that is the reason why when we are performing decortication, we will do it one by one, not both of them at the same time. ठीक है? So that's the important thing. Sure. Moving further now. Talking about this condition, and what is this? Here you are able to see, guys, there are various grades, and in each grade you can see that the laryngeal diameter which is there, or the lumen which is there na, it is decreasing in size. So जो laryngeal lumen है या laryngeal opening है ना, उसकी size कम होती जा रही है. Okay, the laryngeal lumen is decreasing in size. Okay, and if the laryngeal lumen decreases or it narrows down in size, narrowing is what is called as stenosis. Okay, so this is a case of subglottic stenosis. This is a case of subglottic stenosis. Stenosis का मतलब होता है narrowing, nothing else but narrowing. Okay, so subglottic stenosis is seen over here. And the question was, what is the grading used for subglottic stenosis? Please let me know that. What is the grading used for subglottic stenosis? I just need to know the grading. Okay, I just need to know the grading. What is the grading used for subglottic stenosis? Now, subglottic stenosis can be congenital. Yes, if the diameter of the larynx is small since birth. उसका बचपन से, जन्म से क्या है, larynx का जो diameter है वो बहुत छोटू सा है, तो क्या होगा, इसमें narrowing के chances ज्यादा होंगे, stenosis के chances ज्यादा होंगे. So if the laryngeal diameter is very small since birth, there will be high chances of subglottic stenosis. Whereas it can be acquired as well. And why it can be acquired? Please remember, I hope all of you are quite aware. If there is infection of the airway, or if there is infection of the larynx, infection leads to inflammation. And one of the cardinal signs of inflammation, one of the important things about inflammation is it causes edema. It causes what? Edema, right? Swelling, tumor, edema pada hoga na inflammation mein. Definitely one of the cardinal signs is edema. And if there is edema, definitely what will happen? Due to the laryngeal edema, there will be narrowing of the larynx. That is what is subglottic stenosis. Okay? Chalo. Now please tell me, what is the grading name? So please remember, at least remember the name of the grading, that is called as Cotton-Mayor grading. Okay, so the grading which is used for subglottic stenosis is known as Cotton-Mayor grading. And according to the Cotton-Mayor, this was the question only. Okay, so Cotton-Mayor grading is used for which condition? Answer is subglottic stenosis. According to Cotton-Mayor grading, 0 to 50% narrowing or 0 to 50% obstruction is grade 1. And for grade 1, We don't need to go for any other treatment, just we will go for a conservative management. For grade 1, we will only go for a conservative management. Okay, then 51 to 70% obstruction is grade 2. 51 to 70% obstruction or narrowing is grade 2. Here we will go for laser or dilatation. This was a previous year question of NEET-PG. Here we will go for a laser dilatation. Laser or a dilatation. Either you will use a laser or you can use a balloon dilator. Okay, so that can be done. If it is 71 to 99% obstruction, it is grade 3. If it is 71 to 99% obstruction, it is grade 3. And finally, if it is 100% obstruction, if it is 100% obstruction, or if the lumen is not visible at all, if there is no detectable lumen, okay, if the lumen is not visible at all, or if there is no detectable lumen, that is grade 4. In grade 3 and grade 4, we need to go for a surgery. And what is that surgery called as? That surgery is known as LTR. That surgery is known as LTR. Definitely it is called as laryngotracheal reconstruction. Okay, LTR is nothing but laryngotracheal reconstruction, that you need to remember. Okay, so at least remember these important things about your, don't worry about that. So grade 1, 0 to 50% obstruction, conservative management. Grade 2, 51 to 70% obstruction, laser or dilatation. Grade 3, 71 to 99% obstruction, or grade 4, 100% obstruction. In grade 3 and grade 4, the treatment of choice is LTR, laryngotracheal reconstruction. I have repeated. No issues till here, anybody? That's the important thing. Chalo. Moving further. Now a Sarkari question of your exam. Yes. Okay. It was not present in FMG Jan 2023, but otherwise it is seen in almost every other examination from ENT. And what is this question? A trumpet player. Okay. So a trumpet player presents to the ENT OPD with complaints of neck swelling. On pressing the swelling, hissing sound is noted. As you press the swelling, what happens? The air escapes out of the swelling. And as the air goes out of the swelling, such kind of a hissing sound is heard. Okay, this is known as which sign? Please let me know that. What is this sign known as? When you press the swelling and a hissing sound comes, what is this sign called as? Workup has been given below. What is the diagnosis? Now in workup, as you can see over here, on workup, as you can see, this is what is the neck swelling. When you press the neck swelling, hissing sound is heard. Okay, then we will get a X-ray done in this patient. Why? Because we know in this swelling we have air, and if there is presence of air in the swelling, definitely air appears black on an X-ray or a CT scan. So therefore we will either go for an X-ray soft tissue neck. Okay, we will go for an X-ray soft tissue neck, or we can go for a CT neck. Okay, we can go for a CT neck. Important is, as you need to highlight the swelling, you will ask the patient to perform a Valsalva maneuver while performing a X-ray. जब तुम patient का X-ray निकाल रहे हो ना, ask the patient to perform the Valsalva maneuver. What is Valsalva maneuver? Ask the patient to inspire deeply and then expire, but expire with a closed nose and a closed mouth. बहुत डीप इंस्पायर करो, हवा भर लो अच्छे से, एंड देन बाद में जोर से एक्सपायर करो, बट वो एक्सपिरेशन कैसा होना चाहिए? विद अ क्लोज नोज एंड अ क्लोज माउथ. ओके, सो दैट इज व्हाट इज द Valsalva maneuver. That's the important thing. Very good, all of you. It is known as the Brice sign. Where did we discuss Boyce sign in surgery? Please let me know that. So when we press the neck swelling and air escapes out of it, making a hissing sound, this is known as the Brice sign. Where did we hear about the Boyce sign in surgery? Let me know that once. When there's a gurgling sound on pressing the neck swelling. So we know now, definitely here also on X-ray soft tissue neck, you're able to see a swelling, okay, which is full of air. On a CT also you are able to make out a swelling which is full of air. Okay? So this is nothing else but a laryngocele. Okay, so diagnosis is that nothing but a laryngocele. What is a seal? As I've always told you, seal is nothing but a cavity, and cavity contains anything. So it can be either a fluid or air. So this time it is air over here. Okay, it is air over here. Now I hope all of you are quite aware. These are your false vocal cords. Okay, and these are your false vocal cords, and these are your true vocal cords. Okay, so these are false vocal cords. These are your true vocal cords. The space between both of them is known as the ventricle. And a outpouching from this ventricle, a mucosal outpouching from this ventricle is known as saccule. Okay. Now, when there is abnormal dilatation of this vacuole, when there is an abnormal dilatation of this saccule and it is filled with air, that is what is called as a laryngocele. Now, have you understood? Please remember, जब saccule बहुत ज़्यादा dilate हो जाती है और उसमें air भर जाती है, that condition is what is known as a laryngocele. Okay, so that's important. You need to remember what is laryngocele. Laryngocele is nothing but abnormally dilated, abnormal dilatation of saccule. It is abnormal dilatation of the saccule is what is called as a laryngocele. Okay? What is the complaint of the patient? Usually the patient comes to you with a history of neck swelling. And it is usually seen in which profession? It is usually seen in wind instrument players. What are the wind instruments? Where you need to blow a lot of air, जहाँ बहुत ज़्यादा हवा फूकने की जरूरत पड़ती है. So these wind instruments are either a trumpet, a saxophone, or a shehnai. Okay, so trumpet, saxophone, or a shehnai player they can give you in the history on the question, or sometimes they can also say a weightlifter. Yes, weightlifter has also a high risk to develop a laryngoscele. Okay, now as I've told you, definitely you will clinically examine the patient and try to elicit the Brice sign, and definitely you will get a X-ray soft tissue neck or a CT neck, and then you will be confirmed. Then you will have a confirmed diagnosis of laryngoscele. What is the treatment? So the treatment over here is nothing but a surgical excision. The treatment for a laryngoscele is nothing but a surgical excision. That you need to remember properly. Okay? And all of you are right. Very good, all of you. Yes, Boise sign, gurgling sound is heard in cases of Zenker's diverticulum. Shabash. Moving further, talking about the next important one, and that is about the lymphatic drainage of larynx. What did I tell you? Nowadays, they are asking a lot of anatomy related questions of larynx. Okay, so you need to be aware of it. If I ask you what is the lymphatic drainage of larynx, so please remember at the level of the neck, usually we have 7 levels of lymph nodes. So just see that once. First is the submental lymph nodes and the submandibular lymph node. Okay, so level 1 is the submental and the submandibular group of lymph node. Level 2 is the upper deep cervical lymph node. Level 2 is upper deep cervical. Level 3 is middle deep cervical. Level 3 is middle deep cervical. Level 4 is lower deep cervical. Level 4 is lower deep cervical. Level 5, please remember, level 5 is the posterior triangle lymph nodes, also known as supraclavicular lymph node. Level 5 is posterior triangle or the supraclavicular lymph node. Level 6 is in front of the trachea or the larynx. These are known as prelaryngeal, pretracheal, or the Delphian group of lymph nodes. Okay, prelaryngeal, pretracheal, or the Delphian group of lymph nodes. And level 7 are the mediastinal lymph nodes. Level 7 are mediastinal lymph nodes. Now, important is, please remember the supraglottis which is there. I hope all of you are quite aware that the larynx is divided into 3 divisions. Okay, so the landmark to divide the larynx into 3 divisions is your vocal cords, and true vocal cords, as I've told you, are known as the glottis. So the true vocal cords are known as glottis. Anything above glottis will be called as supraglottis. Anything below glottis will be called as subglottis. Anything below glottis will be called as subglottis. So therefore, there are 3 divisions in the larynx: supraglottis, glottis, and subglottis. Okay. Talking about the lymphatic drainage of these 3 divisions, so supraglottis mainly drains into the level 2 and level 3 lymph nodes. So supraglottis mainly drains into the level 2 and level 3 lymph nodes. That is nothing but the upper and the middle deep cervical lymph nodes. So a lot of people will say, so in some of the books, we have seen that it is the jugulodigastric lymph node. Guys, these deep cervical lymph nodes are nothing else but your jugulodigastric lymph nodes itself. Okay, so it is the level 2 and level 3, or the upper and middle deep cervical lymph nodes. Okay, so that's you need to remember. Next is the glottis. Important is, glottis drains into which lymph nodes? That I want to answer from you. Glottis or the vocal cords will drain into which lymph nodes? Answer me in the chat box once. And lastly, if I talk about the subglottis, subglottis usually drains into the level 6 lymph nodes. And which were the level 6 lymph nodes we know? So the level 6 lymph nodes were the pretracheal, the prelaryngeal, or the Delphian group of lymph nodes. They were the pretracheal, prelaryngeal, or the Delphian group of lymph nodes. That's important to remember. Now, please let me know, where will the true vocal cords or the glottis drain into? In which group of lymph nodes? True vocal cords. So please remember, important is, glottis or the true vocal cords has no lymphatics. Yes, it does not drain into any lymphatics. It does not drain into any lymphatics. That's the reason why the glottic cancer, the carcinoma which arises from the true vocal cords, glottic carcinoma, will not spread to any lymph node. It will not spread to any lymph nodes, and that is the reason why it will have the best prognosis among all types of CA larynx. It will have the best prognosis among all types of CA larynx. Okay? So that's the important reason. Okay? No issues with that. Next, here I have a question to you. This was the image which came, and the question was, a person was having a meal. Okay, the person was intoxicated. That means he had drunk a lot of alcohol. So the person was intoxicated and he was having a meal definitely. While having a meal, he suddenly gets a choking sensation. While having a meal, he suddenly gets a choking sensation. There is respiratory distress in the patient. Okay, and the patient is having difficulty in swallowing. Okay, the patient is also having difficulty in swallowing. there is choking sensation, respiratory distress, and the patient could not speak anything. That is aphonia. What is this called as? Okay, then definitely, okay, what was the reason behind this? Because as the patient was having the meal, definitely, what happened? The meal or the food that get stuck or that got impacted into his larynx, atak gaya khana, kahan pe? Larynx mein uske. Okay, and therefore the patient is having all of these symptoms. Okay, what is the treatment? The one which is shown in the image, and that is what is called as Heimlich's manure. And as I've told you in surgery also, Heimlich's manure should not be answered for a foreign body. No. Okay, we don't perform a Heimlich's manure for a foreign body. We usually do it only for food. Okay, only for a food material if you are very sure of it. Okay, याद रखना, recent FMG Jan 2023 में there was a question where the patient had foreign body and a lot of patients marked Heimlich's manure. No, the foreign body, if you perform a Heimlich's manure, can cause damage or injury while coming out. Okay, therefore we cannot do that. Here you can see, as we are trying to apply backward and upward pressure on the epigastrium, backward and upward pressure on the epigastrium, so that the food material which is stuck, it will come out. And this is what is known as your Heimlich's manure, which is done for a impacted food material inside the larynx. Okay? Chalo. Now, if I talk about the basic differences between a pediatric larynx and between an adult larynx, between a pediatric and an adult larynx, definitely, if I talk about the basic difference. So, the pediatric larynx which is there now is high in position. What do I mean by high in position? It is at the level of C2 to C3. Yes, the pediatric larynx is high in position. It is at the level of C2 to C3. Whereas the adult larynx is low in position. Adult larynx is low in position, and I've already told you it is at the level of C3 to C6. It is at the level of C3 to C6. What is the shape? So shape of a pediatric larynx, you need to remember, it is a funnel shape. The shape of a pediatric larynx is usually funnel shape. Okay. Right? The shape of a pediatric larynx is usually funnel shaped, whereas the shape of adult larynx is cylindrical. The shape of adult larynx is usually cylindrical. Okay, that's important. Now please let me, okay, please let me know. Yes, in windpipe also we will go for food material. If you are sure, then definitely you can go for a Heimlich's manure. Okay, if not with the help of Heimlich's manure, then you can go for endoscope. Narrowest part, please answer me, the narrowest part of the pediatric larynx or the adult larynx. Okay, so the narrowest part of the pediatric and the adult larynx. So adult larynx, I'll tell you, the narrowest part of the adult larynx is glottis or the true vocal cords. Narrowest part of your adult larynx is glottis or the true vocal cord. Now let me know the narrowest part of the pediatric larynx, and this was a previous year question. The narrowest part of your pediatric larynx. Okay, edema के chances किस में ज़्यादा होंगे? I've told you, edema chances are more at places where there is high amount of loose areolar tissue. And which larynx contains more amount of loose areolar tissue? The pediatric larynx has high amount of loose areolar tissue, and that is the reason why there will be high chances of edema in a pediatric larynx. Okay, there will be high chances of edema in a pediatric larynx, and that is the reason why now you will understand why pediatric laryngeal infections are considered as an emergency. Why they are considered as an airway emergency? Because if a child is having a laryngeal infection, there will be high chances of inflammation, and due to that inflammation, there will be a lot of edema. Why? Because more loose areolar tissue, there will be a lot of edema, and due to that lot of edema, there will be narrowing, and then can be stenosis. Okay, there can be subglottic stenosis, and that will lead to what? That will lead to laryngospasm or severe respiratory distress in the child, and we can lose the child. That's the problem. Okay, so very good, all of you. The narrowest part of a pediatric larynx, very good, it is the subglottis. Narrowest part of a pediatric larynx is the subglottis. Shabash. Chalo. So these are the important differences that you need to be aware of. Now if I talk about the muscles of the larynx. I have told you there are two groups of muscle. One group which lies outside the larynx. These are called as extrinsic laryngeal muscles. Okay, they are responsible for external movement of larynx. They are not so important. More important are the ones which lie inside the larynx, and the muscles which will lie inside the larynx and are responsible for the movement of vocal cord. These are definitely known as the intrinsic muscles of larynx. If I talk about the intrinsic muscles of larynx are subdivided into three groups. Now you will be answering me one question, which is the abductor muscle of larynx. Yes, there is only a single abductor muscle in the larynx. There is only a single abductor muscle of the larynx. And what is the abduction means? Abduction means away from the midline. So the vocal cords are going away from the midline. That means the vocal cords are opening up. Okay. So opening of vocal cord or abduction of vocal cord is caused by this muscle known as the abductor muscle of larynx. What is this abductor muscle of larynx known as? Please let me know in the chat box. What is the abductor muscle of larynx known as? Okay, please let me know that. Till that time, if I talk about the adductor muscle of larynx, this was also a previous year question, abductor muscle. If you feel कि ऐसे questions नहीं आते, let me tell you, this was a previous year question. Only abductor muscle of larynx is, or only abductor muscle of vocal cord is. Very good, all of you. It is the PCA. What do I mean by PCA? PCA is nothing but posterior cricoarytenoid muscle. The only abductor muscle of larynx is the PCA, that is posterior cricoarytenoid muscle. Very good. Okay, so that was a previous year question. Then if I talk about adductor muscles, so usually adductor is what? Adductor. Adduction means towards the midline. Adduction means towards the midline. That means closing of the vocal cord. So the muscles which will help in closing the vocal cord or in adduction of the vocal cord, these are four. Okay, so the adductor group of muscles are four in number. One definitely is known as the thyroarytenoid, that we have already seen, which was present in the body of the vocal cord. Next was the interarytenoid. That was present in between the arytenoid cartilages. The third one you need to remember is lateral cricoarytenoid. The third one is LCA, lateral cricoarytenoid. And the fourth one is cricothyroid. Yes, this muscle is very important because this is always an exception. Okay, the fourth one that you need to remember is cricothyroid. Okay, so these are the four adductor muscles of vocal cords which will help close the vocal cord. Okay, so abductor opens the vocal cord, whereas adductor closes the vocal cord. Chalo. Now important is, what are the tensor group of muscle? What is tension? So tension, usually the vocal cords, they should be under tension. As I've told you now, the vocal cord should be under tension. Kyun? Because if the vocal cords are under tension, definitely the quality of voice which will be there, it will be much better. Okay, drum yaad karo. Okay, you just need to remember the dhol or the drum. I've told you, if the membrane is stretched out, if the membrane is tense, the quality of voice will be better. But if on the other hand the membrane is loose, so if the membrane is loose, the quality of voice will be poor. So that's the reason why our vocal cords, the membranes of our vocal cords needs to be stretched. They should be tensed. And the muscles which will help in tension of the vocal cord or stretching the vocal cord, these are called as tensor group of muscles. Okay. And these tensor group of muscles, the main tensor muscle is what? Answer me in the chat box, which is the main tensor muscle. Okay. So the tensor group of muscles, as I've told you, they stretch the vocal cord. And as they stretch the vocal cord, they are responsible for quality of voice. Okay, they will be responsible for better quality of voice. Okay, so which is the main tensor muscle? Okay, which is the main tensor muscle of vocal cord? Please answer me that. Which is the main tensor muscle of vocal cord? Answer the question, Fat say. The main tensor muscle of vocal cord. Answer it in the chat box. Very good, very good. Yes, the main tensor muscle of the vocal cords is definitely cricothyroid. The main tensor muscle is definitely cricothyroid. Okay, so that's important to be remembered. Yes, cricothyroid, as I've told you, it is always an exception. So here also you need to remember it is a main tensor muscle, as well as it also works as a adductor muscle as well. Okay, it also works as a adductor muscle. And the another muscle which helps in tension. Okay, the other muscle which helps in tension is what is called as vocalis. It is known as vocalis. Okay, now my question is, guys, my question to you is, which among the following is a tensor muscle of vocal cord? Which among the following is a tensor muscle of vocal cord? And your answer and your options are, I'm asking which among the following is a tensor muscle of vocal cord, and your options are thyroarytenoid, interarytenoid, lateral cricoarytenoid, and posterior cricoarytenoid. Answer the question now. Answer the question now. Which among the following is a tensor muscle of vocal cord? Yes, as it is lying outside the larynx, it can stretch the vocal cords properly. Answer the question. Which among the following is tensor muscle? The four options I've given to you. Answer that. Anybody? What is your likely answer? What do you think can be the answer? No, it is not posterior cricoarytenoid. Please remember, it is nothing else but your thyroarytenoid over here. Here the best answer will be thyroarytenoid. Why? Because if they have asked you about tensor muscles, definitely the best answer would have been cricothyroid. But we can see that cricothyroid is not an option. Then the second best answer could have been vocalis. But vocalis is also not an option. So how I have answered it as thyroarytenoid? Because please remember, this vocalis muscle which is there now, this vocalis muscle is nothing but, it is the internal part. Okay, it is nothing but the internal part of thyroarytenoid muscle. It is nothing but the internal part of thyroarytenoid muscle. Okay, so sometimes they can trick you with this as well. So please remember, it is nothing but the internal part of thyroarytenoid muscle itself. Chalo. Now one more question to all of you is, which is the only unpaired muscle of larynx? Which is the only unpaired muscle of larynx? All the muscles we have discussed are usually in pairs. The only unpaired muscle of larynx I want to answer. The only unpaired muscle. All of these are previous year questions that I'm asking to you, because muscles and cartilages are the most important topic from which they will ask you questions. They have even asked all of the following are paired cartilages of larynx except, and the answer was epiglottis for that question. Okay. Here I am trying to ask only unpaired muscle of larynx is only single muscle. बाकी सब pairs में होती है, only unpaired muscle of larynx is. Till the time I'll move further with the innervation. What do I mean by innervation? Innervation is nothing but nerve supply. Innervation का मतलब होता है nerve supply. Okay. So if I talk about the nerve supply of the larynx or the innervation of larynx, why this is important? Because there was a recent question in FMG Jan 2023 from innervation of larynx. Very good Mohit, very good Gaurav. Yes, your answer is right. It is the interarytenoid muscle, because it was present in the center now. It was present in between the two arytenoid cartilages. So the only unpaired muscle of the larynx is interarytenoid muscle, also called as transverse arytenoid muscle. Okay, it is also known as the transverse arytenoid muscle. That's the important thing. Okay, so just remember this important point. Chalo. So this was a previous year question. Moving further, if I talk about nerve supply or the innervation of the larynx, as I've told you, there can be two types of nerve supply to organ. And what are these? First is a motor nerve supply. What is motor nerve supply? The nerves which will supply the muscles is called as a motor nerve supply. The nerves which will supply muscle is known as motor nerve supply. And the nerves which will supply the mucosa, the nerves which will supply the mucosa is what is called as the sensory nerve supply. Okay? To understand the motor nerve supply, okay, to understand the motor nerve supply of larynx, you need to remember that all the intrinsic muscles of larynx are innervated by the recurrent laryngeal nerve. All the intrinsic muscles of larynx are innervated by the recurrent laryngeal nerve, except, and which muscle was always been an exception? The muscle of larynx which has always been an exception is cricothyroid. Yes. So all intrinsic muscles of larynx have been innervated or supplied by the recurrent laryngeal nerve, except, okay, so cricothyroid muscle is supplied by. So one statement I'll just make you remember: all intrinsic muscles of larynx lie inside the larynx. All intrinsic muscles of larynx lie inside the larynx except cricothyroid. Cricothyroid lies outside the larynx. Cricothyroid कहाँ होती है? Larynx के बाहर होती है. Okay, cricothyroid lies outside the larynx. So what can be the nerve supply of cricothyroid muscle? So please remember, all intrinsic muscles of larynx therefore are supplied by recurrent laryngeal nerve or RLN. Very good. Except cricothyroid, which is supplied by a branch of SLN. And which branch? Definitely, as cricothyroid is lying externally, it will be the external branch of superior laryngeal nerve. It will be the external branch of superior laryngeal nerve. A lot of people are confused. वो बोलते हैं सर SLN तो दिया ही नहीं था ऑप्शन में ELN था. So ELN is nothing बच्चों, ELN is nothing but another name for external branch of superior laryngeal nerve. ELN, external laryngeal nerve, is nothing but external branch of superior laryngeal nerve. That will supply your cricothyroid muscle. That's the important thing to be remembered now. Okay? So that's important. Next, if I talk about the sensory nerve supply. That means the nerve which will supply the mucosa of the larynx, and there was a question from this only. Okay, in this recent FMG Jan. Now, definitely, the nerves which will supply the glottis or the vocal cord. What did I tell you? The vocal cords or the glottis lie in center. They lie in the between. Therefore, they will be supplied by both the nerves. Yes, they will be supplied by both the nerves. That is, superiorly they will be supplied by superior laryngeal nerve, and inferiorly they will be supplied by recurrent laryngeal nerve. Yes, both the nerves will give supply to the glottis. It is the SLN as well as the RLN. Next, if I talk about the supraglottis, guys. Supraglottis. Supra is the area about the glottis or about the vocal cords. Okay. So supraglottis is supplied by, the internal branch. Please remember, this is very important because this was the question. They asked you the area above the vocal cords is supplied by which nerve? So the area above vocal cords, we know it is nothing else but the supraglottis, and supraglottis is supplied by the internal branch of superior laryngeal nerve. It is supplied by the internal branch of superior laryngeal nerve, and internal branch of superior laryngeal nerve can be called as ILN or the internal laryngeal nerve. It can be called as ILN or the internal laryngeal nerve as well. Please remember this. Okay? So supraglottis is supplied by ILN or internal branch of superior laryngeal nerve. Whereas the subglottis, the area below the vocal cords, is supplied by RLN, that is recurrent laryngeal nerve. Okay, the area below the glottis will be supplied by recurrent laryngeal nerve or your RLN. No issues with this, anybody? That's important. I'll talk about the palsies also, don't worry about that. Now the question is, let me know the answer. Here we have a question where they say a patient who underwent a thyroid surgery. A patient underwent a thyroid surgery. After surgery, he has poor quality of voice. After surgery, he is having poor quality of voice, and along with that, he is having recurrent aspiration. Okay. So usually, definitely, if something goes inside the airway or into the lungs, okay, the food, water, saliva, anything, that is what is called as aspiration. This patient is having recurrent aspiration. Why normally in a person we cannot have aspiration? Because the epiglottis will close, the vocal cords will close, and therefore nothing apart from the air will be allowed to enter into the airway. But here definitely as the nerves are injured, definitely the patient is having recurrent aspiration due to that. Why? Because the mucosa is not getting nerve supply, and if the mucosa is not getting nerve supply, definitely will the patient be able to produce cough reflex? No. So mucosa produces cough reflex, na? So if there is no sensory nerve supply, the mucosa will not be able to produce a cough reflex, and as there is no cough reflex, anything will enter into the lungs directly. That is aao jao ghar tumhara. Okay, so that means if the mucosa is not getting enough sensory nerve supply, definitely there will be loss of cough reflex. That will increase the chance of aspiration in the patient. Please let me know, what is the likely cause for this condition? What is the likely cause for this condition? What do you think? The patient is having two important symptoms. One is poor quality of voice and second is recurrent aspiration. So the likely cause for this condition is usually injury to which nerve? It is usually injury to, anybody? It is injury to the superior laryngeal nerve. It is injury to the superior laryngeal nerve. You will say, how, sir? How you have come to the diagnosis that there is injury to the superior laryngeal nerve? Important is, as we know, superior laryngeal nerve has two important branches. One is called as the external branch, known as external laryngeal nerve. Second is called as the internal branch, known as internal laryngeal nerve. External laryngeal nerve supplies which muscle? Cricothyroid. External laryngeal nerve supplies cricothyroid muscle. So if the superior laryngeal nerve is injured, external laryngeal nerve is injured, cricothyroid muscle will be paralyzed. And what was the cricothyroid muscle? Cricothyroid muscle was the main tensor muscle. And what was the function of a tensor muscle? To give better quality of voice. So if the cricothyroid muscle is paralyzed, will the vocal cords be stretched out? No, the vocal cords are not stretched out. Rather, they are bowed down. Dheele pad chuke hai. And therefore, the patient will have poor quality of voice. Right? The patient will have poor quality of voice. Second is, if the superior laryngeal nerve is injured, the internal laryngeal nerve will also be injured. And if the internal branch is injured, definitely internal laryngeal nerve was supplying, or it was giving sensory nerve supply to what? It was giving sensory nerve supply to the supraglottis. As you can see over here, it was giving sensory nerve supply to the supraglottis. So definitely the sensations from the supraglottis will be lost. Okay, the sensations from supraglottis will be lost. And if sensations from supraglottis are lost, definitely there will not be any cough reflex. Or agar cough reflex nahi hoga, so the patient will develop recurrent aspiration. And this was the question which was given in your recent FMG Jan 2023 examination. They gave that the patient underwent a surgery. After surgery, the patient is having recurrent aspiration. They did not mention anything about poor quality of voice. Okay, they only mentioned, okay, so they only mentioned that the patient is having recurrent aspiration. And if the patient is having recurrent aspiration, we know that the patient's internal laryngeal nerve would have been injured. Why? Because the internal laryngeal nerve gives sensory nerve supply. It gives nerve supply to the mucosa of the supraglottis. And if the nerve supply is not there to the supraglottis, cough reflexes will be absent. And if cough reflexes are absent, definitely there will be aao jao ghar tumhara. That means anything can enter into the airway and finally into the lungs. That is what is called as aspiration. Okay? No issues with this, anybody? So that's important. Please remember, if they give you these two symptoms, poor quality of voice and recurrent aspiration, answer is injury to the superior laryngeal nerve. But if they mention specifically, if they only mention that the patient is having poor quality of voice, answer it as external laryngeal nerve injury. But if they only mention that the patient is having recurrent aspiration, answer it as internal laryngeal nerve injury. Okay? So that's the important thing. Chalo. Moving further. talking about vocal cord palsy or vocal cord paralysis. If I talk about vocal cord paralysis, what okay, so please remember vocal cord paralysis can be either unilateral और it can be bilateral. That means एक ही तरफ का vocal cord paralyzed है या दोनों तरफ के vocal cords paralyzed है. ठीक है? So please remember, more commonly unilateral vocal cord palsy is seen on left side or right side. Please let me know that. More commonly vocal cord palsy is seen on left side or right side. If I ask you that which one is more common, left-sided vocal cord palsy or right-sided vocal cord palsy, answer me the question. Answer me in the chat box. Which one is more common, left-sided or right-sided vocal cord palsy, guys? It is the left-sided. Very good. So please remember, it is the left-sided vocal cord palsy which is more common than the right-sided. The ratio is almost around 4:1. Yes, the left-sided vocal cord palsy is 4 times more common as compared to the right one. Okay, and why so? Because we know that the left-sided recurrent laryngeal nerve which is there, because the left-sided recurrent laryngeal nerve which is there, it has a longer course. Okay, the left-sided recurrent laryngeal nerve which is there, it is having a longer course. That means लंबा रास्ता तय करती है left side की recurrent laryngeal nerve. The left-sided recurrent laryngeal nerve na, it goes a long way. Why it is called as recurrent? Because it is going down, then it is taking a turn, and then it is again coming upwards. That's the reason why it is called as a recurrent nerve. Okay? And it is taking turn. On the left side, it takes turn around what? It takes a turn around arc of aorta. That means it goes till the middle of the thorax. Yes. So therefore, you can see on the left side, it is going till the middle of the thorax. It is taking turn around the arc of aorta and then coming back. Okay. Whereas on right side, it goes till over here. Okay. It goes till the right subclavian artery. It takes a turn around the right subclavian artery and then again comes back. So definitely longer is the left-sided recurrent laryngeal nerve. Therefore, higher chances of injury is to the left-sided recurrent laryngeal nerve. जो घर से ज़्यादा बाहर निकलेगा, उसके accident के chances ज़्यादा होंगे. ठीक है? So that's how you need to remember it. Now, if I talk about most common cause, if they ask you what is the most common cause of unilateral vocal cord palsy, most common cause of unilateral vocal cord palsy, okay, it is idiopathic. Most common cause of unilateral vocal cord palsy is idiopathic. That means we don't know the cause, unknown cause. Followed by carcinoma bronchus. Followed by carcinoma bronchus. Yes, if there is a cancer inside the bronchus, okay, on the left side we know that, for example, this is your lung, this is the bronchus on the left side, and we know this is the recurrent laryngeal nerve which is coming on the left side. If there is a cancer over here, definitely it can press or it can compress or it can involve the recurrent laryngeal nerve, and that can lead to vocal cord palsy as well. Okay? So unilateral vocal cord palsy, the most common cause is idiopathic, followed by carcinoma bronchus. But what is the most common cause of bilateral vocal cord palsy? I need an answer from all of you now. What is the most common cause of bilateral vocal cord palsy? Please answer me that in the chat box. Most common cause of bilateral vocal cord palsy. Anybody? Most common cause of bilateral vocal cord palsy, guys? It is trauma, but which kind of a trauma? It is usually a iatrogenic trauma. What do I mean by iatrogenic trauma? That means while we were performing a surgery, by mistake, we have injured the recurrent laryngeal nerve or the superior laryngeal nerve. So usually it is during which surgery? It is usually during a thyroid surgery. So while we are performing a thyroid surgery, definitely by mistake we have injured. By mistake we have injured the RLN or the SLN nerves. Why? Because this is your thyroid gland. It is a butterfly shaped gland, we know. Okay. And at the superior pole of the thyroid gland, we have the superior laryngeal nerve. At the inferior pole of the thyroid gland, we have the recurrent laryngeal nerve. Okay. So therefore, if they are saying that there is a bilateral vocal cord palsy, the most common cause is iatrogenic, or it can be during a thyroid surgery. Please remember that. Okay. And during a thyroid surgery, which nerve injury is more common? Answer me that now. During a thyroid surgery or during a thyroidectomy surgery, which nerve injury is more common? Is it SLN or is it RLN? Please let me know that in the chat box. Which one is more common during a thyroid surgery? SLN injury or RLN injury? बता दो जल्दी से. SLN और RLN? So please remember, now it has changed. Now the answer has changed. Now the answer has changed. Okay, it has been changed since twice or thrice, almost 2 or 3 sessions now, na? 2 or 3 sessions it has been. Please remember, it is SLN now. Yes, it is SLN. Please remember, the most common nerve injury during thyroid surgery. The most common nerve injury during thyroid. Even books have changed their answer. Most common nerve injury during a thyroid surgery, definitely, is what is a SLN injury. Okay, most common nerve injury during a thyroid surgery is the SLN, superior laryngeal nerve injury. Please remember that. Okay, so just update yourselves. Question. Next question is important. It says a patient with complaints of hoarseness of voice, and it was found that left atriomegaly is causing compression of his left recurrent laryngeal nerve. What is the diagnosis in this condition? Identify the condition. Just identify the condition. SLN injury is more common. Books have changed their answer. Practically also, SLN injury is more common. Because while you are retracting the thyroid gland now, while you are removing the thyroid gland, you need to retract the skin flap. And when you retract the skin flap, definitely, both injuries can be there. What I'm asking you is more common. What I'm asking you is more common. Both injuries can be there. Definitely, it can be SLN or RLN. What I'm asking you is more common. Which one is it? Previously, it was RLN. But you need to update your notes. It is SLN nowadays. Okay? So that's the important thing. This was a previous year question. A lot of people have made mistakes. So a patient complains of hoarseness of voice, and it was found that left atriomegaly is causing compression of his left recurrent laryngeal nerve. What is the diagnosis? Definitely it is a RLN palsy, but what is this diagnosis known as? What is this diagnosis known as? Anybody? What is this diagnosis called as? No one? So please remember, it is what is called as the Otner's syndrome. Please remember, this is what is called as your Otner's syndrome. So if there is a left atrial enlargement or left atriomegaly which compresses the left-sided recurrent laryngeal nerve, causing its palsy, is what is called as Otner's syndrome. That's the important thing you need to remember. Chalo, okay? Now if I talk about this condition, here, okay, here after a surgery, definitely, okay, here after a thyroid surgery, definitely, okay, the patient is complaining, the patient is having respiratory distress, okay, along with that the patient is able to produce voice, he is able to speak properly, but he is having respiratory distress, definitely, okay, a lot of severe respiratory distress is there in this patient, and along with that there is noisy breathing. What is noisy breathing called as? Noisy breathing is nothing but stridor. And why there is a stridor? If there is obstruction of the upper respiratory tract, the noise which is produced during breathing is what is called as a stridor. Okay? Obstruction of the upper respiratory tract causes stridor. So the patient is having respiratory distress and stridor after thyroid surgery. What is the likely cause? What is the likely cause in this condition? What is your diagnosis, anybody? What is your diagnosis? When the patient will have respiratory distress, we know the patient will have respiratory distress if the vocal cords are closed. Okay, the patient will have respiratory distress or stridor when the vocal cords are closed. On the laryngoscopy also you can see beside that the vocal cords are in closed position. Okay, the vocal cords are in closed position. Okay, so the vocal cords are in closed position, definitely, or we can say they are in adducted position. So if the vocal cords are in adducted position, why they are in adducted position? Because during thyroid surgery, maybe there was injury to some nerve, and due to injury to this nerve, what has happened? Definitely, okay, there was paralysis of a muscle, and that muscle is responsible for abduction of the vocal cord. Which is the only muscle responsible for abduction of vocal cord? The only abductor muscle of larynx is posterior cricoarytenoid. So that means if the patient is not able to perform abduction of the vocal cord, which muscle has been paralyzed? His posterior cricoarytenoid muscles have been paralyzed. And if his PCA muscle have been paralyzed, what is the nerve supply to the PCA? Which nerve has been injured over here? Which nerve has been injured over here? Very good, Prabha. Very good. It is a diagnosis of bilateral RLN injury. It is a case of bilateral RLN injury. Why? Because we know, definitely, because we know like all the intrinsic muscles of larynx are innervated by your recurrent laryngeal nerve except cricothyroid. And cricothyroid is not an abductor muscle, it is an adductor muscle. So here the cause is bilateral RLN injury, and due to this bilateral RLN injury, the patient is having paralysis of the abductor muscle, and the only abductor muscle is known as PCA, posterior cricoarytenoid muscle. इसकी palsy हो गई है, and if there is a abductor muscle palsy, that is what is called as bilateral abductor palsy. So here the diagnosis of this patient is a bilateral abductor palsy. Yes. So in cases of bilateral abductor palsy, abduction is not possible. So vocal cords are closed. That causes respiratory distress and stridor in the patient, and that is usually during a thyroid surgery due to the bilateral RLN injury. So now you have understood, Faisal. See, RLN injury is also possible, but more commonly if they ask you, please remember it is the SLN one. ठीक है? चलो. So that's the important thing. Please remember over here. ठीक है? तो bilateral abductor palsy. Yes, it is an emergency condition. Why? Because the patient is having respiratory distress. So what is the emergency management and what is the definitive management? Let me know that once. Jaldi se. What is the emergency management in this patient and what is the definitive management? Emergency and definitive management. Let me know that first. Emergency management. If a patient is having respiratory distress, what are you going to do? What are you going to do? Very good, Gaurav. It is tracheostomy. Please remember, you are not going to intubate this patient. The reason is his vocal cords are closed. You will not be able to insert an endotracheal tube. Therefore, if we have studied it in surgery that if endotracheal intubation is not possible, we need to go for tracheostomy in the patient. And what is the definitive management? Now the patient is stable somewhat. So the definitive management is type 2 thyroplasty. The definitive management is type 2 thyroplasty. Okay. And what is done in type 2 thyroplasty? We can see that the vocal cords are medial. So we need to take away the vocal cords. We need to lateralize the vocal cord. That's the thing. Type 2 thyroplasty mein we will go for lateralization of vocal cord. We will go for lateralization of vocal cords. Okay? Next condition is over here. Next condition mein kya dikh raha hai? Here the patient is having loss of voice. The complaint of the patient is aphonia. The patient is not able to speak anything. He's having aphonia, loss of voice. And the second complaint, the patient has developed aspiration pneumonia. The patient is also having aspiration pneumonia. Why both of these conditions are seen in the patient? Why both of these complaints are seen? Because as the vocal cords are not closed, the patient is not able to speak anything. He is not able to produce any sound. And as I've told you, vocal cords, if they are closed, then only sound production will occur. But here the vocal cords are open. That's the reason why definitely the patient is having loss of voice or there is aphonia in the patient. Along with that, the patient is also having aspiration pneumonia. Why? Because the vocal cords are in open position, okay, or in abducted position, okay. So the vocal cords are in open position. But are they completely open? No, they're not completely open. They are usually in intermediate position. And this intermediate position of vocal cords is usually seen when a patient will die. That is in a cadaveric state. So this is nothing but an open, intermediate or a cadaveric position of the vocal cord. And when there will be a cadaveric position, when there will be injury of the both the nerves, that is RLN as well as SLN. So if दोनों के दोनों nerves injured है, क्या हो जाएगा? सबकी सब मसल जितनी भी तुम्हारे larynx में है, सबकी सब क्या हो जाएगी? पैरालाइज हो जाएगी. और सबकी सब मसल्स अगर पैरालाइज हो जाती है, that looks like a dead body itself, and therefore the patient will have the vocal cords in the cadaveric or the intermediate position. Very good. So if the vocal cords are in open, intermediate or cadaveric position, along with complaints of aphonia or aspiration pneumonia, you need to suspect bilateral RLN plus SLN injury. And RLN and SLN are branches of which cranial nerve? RLN and SLN, I hope all of you are quite aware, these both are branches of the vagus nerve. That means here they are talking about bilateral vagal paralysis. They are talking about bilateral vagal paralysis. That means the main vagus nerve is only injured. Okay? Due to this, what has happened? No muscle is working. The vocal cords are in cadaveric position. Okay, so this is a case of bilateral adductor palsy. The vocal cords are not able to close. That means adduction function is not there. This is a case of bilateral adductor palsy. Now here the patient is not having any respiratory distress. So do we need any emergency management? No, we don't need any emergency management. We only go for a definitive management. And what is left now? It is only a type 1 thyroplasty which has been left now. So in bilateral adductor palsy, definitely we'll go for a type 1 thyroplasty. We will go for a type 1 thyroplasty. Okay? And type 1 thyroplasty is what? Type 1 thyroplasty is nothing but here the vocal cords are in lateral position. Bring them in the center. That is what is called as medialization of vocal cord. That is what is called as medialization of vocal cord. Okay? So that has to be remembered. Important. Okay? Chalo. These are the important things about your vocal cord paralysis now. Next condition, I hope all of you are quite aware of this slide now. ये slide सबसे ज़्यादा ज़रूरी because highest number of questions have come from this slide from larynx. ठीक है? So let's discuss this slide now. Okay, it says a neonate was brought to you with complaints of noisy breathing, which increases when the child cries or when he lies supine. On examination, the following picture is seen. What is the treatment? Now, important is here we have a neonate. That means a child who is still in the first 28 days of life. He has been brought to us with noisy breathing. And what I told you, noisy breathing is nothing but stridor. So definitely the child is having stridor since birth itself. That means it is a case of congenital stridor. Okay, and this stridor has a peculiar feature. What is a peculiar feature? You can see when the child will lie supine. Okay, when the child will lie supine, the stridor will increase, or the child starts crying, the stridor increases. Whereas when the child will lie in prone position, जब पेट के बल सोता है, when the child lies ulta, okay, when the child lies in prone position, definitely the stridor decreases. Why? So you can see if the child lies in prone position, when the child lies in supine position, जब सीधा सोता है बच्चा, when the child lies in supine position, the epiglottis will close the vocal cords. The epiglottis will close the vocal cords. And that is the reason why the stridor will increase. Because what is the cause of stridor? Cause of stridor is obstruction of the airway. And here you can see as the child is lying supine, the vocal cords or the airway is closed more. It is obstructed more. Therefore, the stridor increases. But when the child lies in prone position, पेट के बल सोएगा, definitely the epiglottis falls back. As the epiglottis falls back, the vocal cords will open up. And as the vocal cords will open up, definitely the obstruction will also decrease, and therefore definitely what will happen, the stridor will also decrease in the patient. Now please let me know which kind of stridor is seen in this condition. All of you are right. Definitely the diagnosis in this condition, all of you are right, the diagnosis in this condition is laryngomalacia. The diagnosis of this condition is definitely laryngomalacia. Okay, diagnosis of this condition is definitely laryngomalacia. Okay, what is malacia? Malacia literally means weakness. Malacia literally means weakness. Please remember that. Okay, so laryngomalacia is nothing but weakness of your larynx, mainly weakness of your supraglottis. Okay, so laryngomalacia is nothing but weakness of your supraglottis mainly. Okay, and it is present since birth. That means it is a congenital condition. And rather you need to remember it is the most common congenital anomaly of larynx. Laryngomalacia is the most common congenital anomaly of larynx. It is the most common congenital anomaly of larynx usually. That you need to remember. And it is also the most common cause of congenital stridor. It is also the most common cause of congenital stridor. Very good. Yes, the stridor which is seen over here is an inspiratory stridor. That means आवाज कब आएगी जब बच्चा सांस ले रहा होगा. Okay, when only the child inspires, then you are able to hear the noise. That is called as an inspiratory stridor. And peculiar feature of these inspiratory stridor are what? First of all, this inspiratory stridor will be present in the first week of life itself. First thing. Second, it will increase when the child lies in supine position or whenever the child cries, and it will decrease when the child goes into the prone position. Okay, so that's the important thing. On examination, this kind of a picture is seen. I've told you what is laryngomalacia. It is nothing but weakness of the supraglottis, and mainly affected part in the supraglottis is what? It is your epiglottis. So definitely there is weakness of the epiglottis, as you can see over here. And here the epiglottis looks like which shape? The epiglottis looks like this. This is what is called as the omega shaped epiglottis, or sometimes in question they can trick you, they can write floppy epiglottis as well. So floppy or omega shaped epiglottis is one and the same thing over here. Okay, just remember they can write either floppy or omega shaped epiglottis, which will be seen. This is a direct diagnosis of laryngomalacia in the patient. Okay, so what should be the treatment now? What should be the treatment now? You have made a diagnosis, you have examined the patient definitely. What is the treatment? Cry sound is absolutely normal in the child. Cry sound में कोई दिक्कत नहीं आती. Very good. So here the treatment should be reassurance to the parents. Okay, treatment should be reassurance to the parents. You will say why? Because this is a self-limiting condition. Okay, it is a self-resolving or a self-limiting condition. It will heal by itself. It will resolve by itself up till 2 years of age. अपने आप चली जाएगी till 2 years of age. So therefore the best answer should be reassurance to the parents, or if that is not an option, you need to answer it as, please remember, you need to answer it as no treatment or conservative management. So whatever there is an option, you need to mark that. Reassurance to the parents was there in one of the options, conservative was there in one of the examinations, and no treatment in one of them. Okay, so you need to remember this. But even after 2 years of age, the patient's condition does not improve. Even after 2 years of age, the child is still having this stridor, inspiratory stridor, then definitely we need to go for a surgery, and that surgery is what is called as supraglottoplasty. Okay, that surgery is what is called as supraglottoplasty, or we can perform a epiglottopexy, or we need to perform a epiglottopexy. That has to be done. Please remember this. Okay? So that was all about your laryngomalacia, guys. That was all about your laryngomalacia. Next condition is this. Okay, the child comes to the emergency. Yes, the child is coming to the emergency and is sitting in this position, characteristic position. The child is having severe respiratory distress. The child is having severe respiratory distress. Along with that, the child is not able to swallow anything, and therefore all the saliva is coming out from his mouth. There is drooling of saliva. Okay, there is drooling of saliva from his mouth. All the saliva is coming out of his mouth. Apart from that, the child is having difficulty in swallowing. That means there will be dysphagia or there will be odinophagia. Dysphagia is difficulty in swallowing. Odinophagia is pain during swallowing. So these will be the features. Along with that, whenever the child speaks, child will speak like this. What is this kind of a voice called as? This kind of a voice is known as a hot potato voice. That means it seems as if somebody has kept a hot potato in his throat or a plum in his throat, and therefore he's having this muffled kind of a voice. This is called as a hot potato voice. What is your diagnosis? So in emergency, a school age child comes to you between 2 to 8 years of age with complaints of respiratory distress, drooling of saliva, dysphagia, odinophagia, hot potato voice, okay, and this characteristic position. What is this characteristic position? Here the child will sit bending forward so that the symptoms will be relieved. Okay, the respiratory distress will somewhat improve. This characteristic position is known as the tripod position. Okay, it is characteristically known as the tripod position. Okay, along with that, definitely the child will have a high grade fever as well. The child will also have a high grade fever. I've written everything about the disease. Yes, very good. It is a case of acute epiglottitis. Very good. So the diagnosis in this condition is definitely a laryngeal infection seen usually in the pediatric age group. That is what is called as acute epiglottitis. So please remember, acute epiglottitis is actually a bacterial infection of the supraglottis, but the most common side affected is the epiglottis. Therefore, it is named as acute epiglottitis. It is का मतलब होता है inflammation. Inflammation of what? To epiglottis. So it is acute epiglottitis. The child is usually a school age going child between 2 to 8 years of age, and the child has all these severe features like respiratory distress, drooling of saliva, dysphagia, hot potato voice, high grade fever, and tripod position. Important is here definitely what will be done for investigation. Okay, once you have seen the symptoms, you are suspecting, okay, the child might be suffering from acute epiglottitis. What is generally done for investigation? Okay, what is generally done for investigation? So for investigation, the first line investigation that we do is definitely the most common causes. I've told you it is a bacterial infection, and this was a previous year question. The most common cause is which bacteria? So now you need to remember the most common cause is strep pneumoniae. Streptococcus pneumoniae is the most common cause of acute epiglottitis. Okay, if this is not an option, or if they ask you which is the most common cause in unimmunized children, that means the children who are not given immunization, then it is your HIB, Haemophilus influenzae type B. Okay, so please remember, yes, it is strep pneumoniae. The most common cause is strep pneumoniae. Please remember that. Only in unimmunized children, more commonly it will be HIB or Haemophilus influenzae type B. This was a previous year question. No mistakes to be done. No controversy in this as such. Okay, yaad rakhna. The first line management is very good, all of you. It is the X-ray soft tissue neck and lateral view we will take. Okay, so on X-ray soft tissue neck lateral view, we are able to see the swollen epiglottis. On X-ray soft tissue neck on a lateral view, we are able to see the swollen epiglottis, and this is what is called as your characteristic thumb sign. This is what is known as your characteristic thumb sign. Very good. Okay, so please remember, on an X-ray soft tissue neck lateral view, definitely you are able to see this thumb sign over here. Please remember that. Okay, so that is what is done. What is the first line management? What is the first line management? What is done as first step in the management of this child? What is a first line management? What is a first line management in this child? What is the first line management, guys? So please remember, the first line management will be what? The child is having respiratory distress. Very good. It is airway, not antibiotics. Okay, if you give antibiotics, the child will leave till that time. Therefore, as I've told you, there will be high chances of edema in the larynx of a child now. Therefore, the child will have difficulty afterwards, more and more difficulty if you keep on postponing the airway management. So first line management is definitely airway management, that is given utmost priority, and that is the reason why the first line management is always early elective intubation. Okay, that is always early elective intubation. Why? Because as I've told you, in a child there will be high chances of laryngeal edema and high chances of subglottic stenosis. That is the reason why if you wait for a longer time, after a certain time you will not be able to even see his vocal cords, because the airway or the larynx has been completely edematous, and that is the reason why you need to intubate the child as early as possible, so that we will prevent the child from respiratory arrest. Okay? No, tracheostomy is only required if intubation is not possible. First try intubation. If that is not possible, go for a tracheostomy. Okay, so that has to be done for airway management. Apart from this, as we know, it is a bacterial infection, so antibiotics are to be given. Along with that, a lot of edema now. So to decrease edema, the drug of choice we always know they are steroids. And apart from this, we know bronchodilators are to be given as well. The bronchodilator which is given, this is important. Remember, it is nebulized epinephrine. Yes, adrenaline or epinephrine is given in the nebulized form. Okay, so nebulized epinephrine is used as a bronchodilator. It is very effective in cases of epiglottitis or any cases of severe laryngeal infections. Okay, in children. That's important. Next condition is this. Here I have a 6 months to 3 year old child. Here I have 6 months to 3 year old child who has been brought to me, and the child has complaints. Here also the child has fever, but the child has a low grade fever usually. Here the child has a low grade fever. Apart from low grade fever, the child also complains of a classic cough. And what is that classic cough? Known as barking or a brassy cough. Okay, the classic cough which is there, it is known as the barking or the brassy cough. Along with that, the child has stridor as well. But here in epiglottitis also the child can have a stridor, but over there it is a inspiratory stridor, because the problem was at the level of the supraglottis. But here the problem is usually at the level of the subglottis. Therefore, the patient has a biphasic stridor. The child has a biphasic stridor because the problem is at the level of the subglottis. Okay, this condition is what? Very good. So here definitely the condition bronchodilators, because there is a lot of edema and the airways are also in spasm. Therefore, we need bronchodilators. Okay, and usually epinephrine will also help in decreasing the edema as well as in bronchodilation. Okay, because it is not only the infection limited up to the upper airway. Sometimes the infection can be till the lower airways as well. That's the reason. Okay. So important is, okay, so very good all of you. It is a case of CROUP. And what is CROUP? CROUP is nothing but acute laryngotracheobronchitis. CROUP is nothing but acute LTB, laryngotracheobronchitis. So you can see there is inflammation of the larynx, the trachea and the bronchus. That means here there is infection or inflammation of the complete airway. But if they ask you the most common site affected, then the most common site affected, as I've already told you, it is the subglottis. The most common site affected is the subglottis. And definitely, is it a viral or bacterial infection? So please let me know what is the most common cause of CROUP or acute LTB. What is the most common cause of CROUP or acute LTB? Okay, so please remember, it is usually a smaller child. Okay, 6 months to 3 years of age, and all of these features, low grade fever, barking or a brassy cough. This is a keyword again. Okay, along with biphasic stridor. So most common cause is usually the para-influenza virus. Okay, so as it is a viral infection, that's the reason why the child has low grade fever and not a high grade fever. Okay, so definitely it is a para-influenza virus, which is the most common cause of acute laryngotracheobronchitis. If I get a X-ray soft tissue neck of this patient done, on this X-ray, what I'm able to see, I'm able to see a lot of, you have answered already. Definitely you are able to see the narrowing of the subglottis. And if the subglottis is narrowed down, this is what is called as, please remember, this is what is known as the steeple sign. Very good. So this is what is known as the steeple sign. So the X-ray soft tissue neck shows you narrowing of subglottis, known as the steeple sign. What is the treatment? If I talk about what is done for management of this patient, here also, as the child can have respiratory distress at times, that is the reason why here also the first line management will always be airway. Here also the first priority will always be given to an airway. Apart from that, we will also give steroids to the patient. Okay, and we will also give bronchodilators. That is the same nebulized epinephrine will be given to the patient to reduce the edema. And whether we will give antibiotics or not. Please let me know, will we give antibiotics to the patient or not? Will we give antibiotics to the patient or not in a case of acute LTB or CROW? जल्दी से बता दो, will we give antibiotics to the patient or not? Are we going to give antibiotics? We will give antibiotics, and the reason is, please remember, okay, there was a previous year question in which antibiotics was also the answer. Please remember that. Okay, so it is antivirals have no role to play. Please remember, antivirals have no role to play in management of acute laryngotracheobronchitis, but antibiotics are given. Why? Because if a patient is suffering from CROW, usually the child is immunocompromised, and if the child is immunocompromised, there will be high risk of secondary bacterial infection. Therefore, to prevent any secondary bacterial infections, we will be giving antibiotics to the patient. Okay, please remember, though it is a viral infection, please remember, because there is a high risk of immunosuppression and secondary bacterial infections ka risk badhta hai, that's the reason why we will give antibiotics to the patient. Now understood why we will give antibiotics? That's the important thing. Okay, chalo. Moving further, next condition, it says a school age child we have a school age child with complaints of hoarseness of voice, and there is stridor again. What is the diagnosis in this child? The laryngoscopy looks something like this. You are able to see some growth over the vocal cord. Okay, you are able to see some kind of growth over the vocal cord. Okay, what is this condition, anybody? A school age child usually having hoarseness of voice. Very classical feature. School age child between 4 to 6 years of age having complaints of hoarseness of voice, and there is stridor, and usually the laryngoscopic examination shows these are overgrowth seen over the vocal cords. What is your likely diagnosis? Very good. So here the likely diagnosis is juvenile papillomatosis of larynx. Please remember, the likely diagnosis is juvenile papillomatosis of larynx. Please remember. Yes. Okay. So papillomatosis. Why? Because there are multiple papillomas which are seen in the larynx. And what is a papilloma? Papilloma is nothing but a benign overgrowth from the squamous epithelium. Okay, if there is a benign tumor of squamous epithelium, that is what is called as a papilloma. Please remember. Okay, so that's important, and we know that the vocal cords are lined by stratified squamous epithelium. Therefore, a benign overgrowth from the stratified squamous epithelium of vocal cord will be called as a papilloma. Why it is called a juvenile papilloma? Because it is common in children less than 18 years of age. That's the reason why it is known as juvenile papillomatosis of larynx. Very good. It is associated with two important viruses, and that virus is nothing else but HPV, human papilloma virus. A papilloma causing virus is HPV. And which strains of HPV? Definitely we know it is the HPV 6 and HPV 11, which are commonly associated with juvenile papilloma of larynx or juvenile papillomatosis of larynx usually. What is the source? Source is nothing usually. It is just the mother who was having genital warts during birth. Okay, as the child was being delivered, at that time the mother was having the genital warts. So from these genital warts, the HPV which was there, the HPV 6 and HPV 11, it has entered into the larynx or the trachea of this child, and now after some time definitely it is causing this papilloma formation. Okay, on examination you are able to see these kind of viral warts. On examination you are able to see these kind of viral warts on the vocal cords. Definitely the complaint, as I've told you already, it is hoarseness of voice. What is the treatment? Please let me know that. What is the treatment? Please remember, this is a pre-malignant condition. What do I mean by this? That means it can further progress into a malignancy. It is a pre-malignant condition. That's the reason why it has to be removed always. It can further progress into a malignancy or a cancer. Okay, we know warts are pre-malignant in nature, so are the laryngeal warts as well. What is the treatment? Treatment which is done on the vocal cords. Vocal cords are very minute now, so we always need to use a microscope. So a surgery which is done on the vocal cords under microscope is called as MLS. What is MLS? Microlaryngeal surgery. So microlaryngeal surgery is done, and we will excise these warts. But with the help of which laser? The one laser that we use in ENT is nothing but the CO2 laser. Okay. So it is microlaryngeal surgery with CO2 laser excision. Microlaryngeal surgery with CO2 laser excision. That is the preferred one nowadays. Please remember that. Okay. So that's the important thing. we will use. Micro debrider was earlier used, but nowadays better one is usually a CO2 laser excision. Micro debrider can also be used in MLS, but the better one is a CO2 laser excision. Less chances of complications, na bleeding वगैरह के. That's the reason. Okay. So that's important thing. Next, two important conditions. Okay, next we have two important conditions. One you can see is this image. The other I'll show you, it is this image. Okay. In both the conditions, please remember, I have a history of vocal abuse in the patient. That means चिल्लाता रहता है इंसान. Okay. I have a history of vocal abuse in the patient. Either the patient who has come to me is a teacher, or he is a singer, okay, or he is a street vendor who is always screaming out. Okay, so there is a history of vocal abuse in the patient. Apart from that, definitely they can also give you a history of smoking or LPR. What is LPR? I have told you, laryngopharyngeal reflux, which is a complication of GERD itself. Okay, so either there is a risk of this. Apart from that, where are these overgrowths seen? There will be overgrowths which will be seen in the patient. The main complaint of the patient, as I've told you, any problem with the vocal cords, main complaint of the patient is always hoarseness of voice. So in both the conditions, the patient is having hoarseness of voice, and the overgrowths which are present, they are usually present at the junction of anterior 1/3 and the posterior 2/3 of vocal cord. They are present at the junction of anterior 1/3 and the posterior 2/3 of vocal cord. Now, one condition which is there, here you can see these overgrowths which are seen, they are very small. They are less than 3 mm in size. Okay, the overgrowths which are seen, they are very small, less than 3 mm in size, and apart from that, they are bilateral in nature. This is my condition A. So make a diagnosis of condition A. Vocal abuse ki history, the patient is having hoarseness of voice. There are overgrowths which are present at the junction of anterior 1/3 and posterior 2/3 of vocal cord, and they are less than 3 mm in size, and they are bilateral. And next condition is this one. Here you can see again there is a overgrowth at the junction of anterior 1/3 and posterior 2/3 of vocal cord. Okay, but this time this growth which is there, it is more than 3 mm in size, and it is usually unilateral. Okay, this is condition number B. So A is what and B is what? Jaldi se bata do. A is what and B is what? Make a diagnosis fat se. A is what? A is what, anybody? Please remember, A is a case of. Yaad rakhna, this is what is the difference. Now, a lot of people made a mistake last time because they were not aware which one is unilateral, which one is bilateral. That's the problem with a lot of people. Yes, some of you have answered it. So please remember, if they say that it is less than 3 mm in size and it is bilateral, definitely it is vocal nodules. Please remember, then definitely it is vocal nodules. Please remember this. Okay? Vocal nodules, as we know, it is also called as teachers nodules, singers nodules, or screamers nodules. Why? Because all of these professions will have definitely a vocal abuse. Okay, they will speak for a longer time, definitely. Okay, that's the important thing usually. But if they say if it is more than 3 mm in size and it is unilateral, then your diagnosis should be a vocal polyp. Then your diagnosis is usually a vocal polyp. I've told you what is polyp. Polyp is nothing but an edematous mucosa which is hanging out. Okay, so जब edema हो जाता है mucosa का, and जब वो hang out करता है, that is what is called as a polyp. Okay, so that's the basic difference, guys. Now I hope all of you are quite aware. Now in one of the examinations, they just gave that the teacher comes to you with hoarseness of voice and definitely unilateral growth is present. So if it is unilateral, it can never be vocal nodules, na? Okay, so that's the important. Teacher ki history bus vocal nodules mein nahi aati. It can be in vocal polyp also, because for both of them, the common cause is vocal abuse itself. That's the important thing. Okay, so these are the differences. Not a teacher. Teacher can be in any case. Teacher can have a vocal nodule also and a vocal polyp also. So that is not the difference. That's the important thing. Okay, so just remember this side is also very much important. Okay, now if I talk about the treatment, in a case of vocal nodule, so please remember, in vocal nodule usually you will recommend the patient for a speech therapy. So the patient will undergo a speech therapy, and along with that the patient needs to take a voice rest. But if they ask you about this, for a vocal polyp, what is the treatment? For vocal polyp, we need to remove the polyp, and that is what is done by MLS, as I've told you. Okay, microlaryngeal surgery. So MLS is usually used. Okay, so MLS with a CO2 laser excision for the polyp. Along with that, definitely what we are trying to do, we are always giving speech therapy to the patient. And voice rest is also recommended over here. Important is one important symptom which can be present in a case of vocal polyp, which will be absent in a case of vocal nodule, is what is called as diplophonia. What is diplophonia? You will be able to hear two different frequencies of sound. Yes, from the same person, you will be able to hear two different frequencies of sound. It is only a symptom which is present in a case of vocal polyp, not in a case of vocal nodule. So these are the important differences. चलो आगे बढ़ते हैं. Next question to you. A patient underwent a major surgery under general anesthesia, and post surgery he complains of hoarseness of voice. What is the likely cause? What is the likely cause? Okay, major surgery under general anesthesia. Okay, and post surgery he complains of hoarseness of voice. What is the likely cause? It is not RLN injury. Let me tell you that it is not a case of RLN injury. ठीक है, RLN injury is not in your options also. चलो, RLN injury post surgery can definitely lead to hoarseness of voice, but here it was not a thyroid surgery. It was some other surgery, some abdominal surgery for which he was operated under general anesthesia. So what is the likely cause of his hoarseness of voice post surgery? जल्दी से बता दो फट से. Very good Faisal. It is a case of intubation granuloma. Very good. It is a case of intubation granuloma. Important is while you're performing a patient, so you will say, sir, intubation की history कहाँ दिया उन्होंने? So they have not told you directly about intubation, but they have told that the patient underwent a surgery under general anesthesia. And we know, as you have done your anesthesia recently, please remember, if a patient needs to be under general anesthesia during the surgery, definitely his all muscles needs to be paralyzed. That is the reason why definitely this person is paralyzed usually under general anesthesia, and that is the reason why usually we need to intubate the patient. Okay, we need to intubate the patient who is operated under general anesthesia. And as we are intubating the patient, the samajh lo, you are intubating for the first time. Okay, you are an intern, you have been given the opportunity to intubate for the first time. Now you don't want to lose the opportunity, so what you will do, your PG is asking you, are you able to see the vocal cord? You are saying yes sir. You're not able to see anything. Okay, you're not able to see anything, but still you don't want to lose the opportunity, so you say no sir, definitely दिख रहा है अच्छे से. So your PG hands over you the ET tube, endotracheal tube, and now you're trying to insert it. You are not able to see the vocal cord, तो तुम जहां मिले वहां रास्ता डाल रहे हो बस. Okay, so if you keep on doing this, what will happen? There will be injury to the vocal cords, and that causes hoarseness of voice in the patient after surgery, and this condition is what is called as intubation granuloma. There was injury to the vocal cords while you were trying to intubate the patient. Okay, so that is intubation granuloma. Treatment is what? Definitely the treatment in this condition in definitely MLS, microlaryngeal surgery. Treatment in this patient is definitely a microlaryngeal surgery that has to be done. Okay, so microlaryngeal surgery is done in this condition as well. Moving further, next we have a question. Here we have a 19-year-old female who complains of loss of voice. Loss of voice is aphonia. I've told you already. On examination, the cough sound appears to be normal and the vocal cord movements are also normal. So the cough sound is also normal and the vocal cord movement is also normal. That should make your diagnosis. What is the next best step in management of this patient? What is the next best step in management of this patient? What is the next best step in management of this patient? Why are you going to operate this patient? Why are you going to operate this patient? So please remember, she's a young female. Okay, she's having a loss of voice or aphonia, and definitely the cough sound of the patient is normal. Everything appears to be normal. What is the next best step in management? What is your provisional diagnosis? What is your likely diagnosis in this condition? Young female who recently had a breakup. ठीक है, तो breakup के बाद definitely she is coming to you and वो थोड़ा नौटंकी कर रही है, or she comes to you in April month. Okay, definitely. Okay, why she is having exam during that time? So okay, so diagnosis is actually a case of functional aphonia or a hysterical aphonia. Nautanki, drama, that is what is hysteria. Okay, so the patient is not having loss of voice actually. She is just pretending the symptom of loss of voice. She is only doing drama. Okay, वो नखरे कर रही है, वो बता रही है कि मेरे को loss of voice हुआ है. Okay, that is what is called as a functional or a hysterical aphonia. And the treatment in this condition, as we know, here the patient should be sent to a psychiatrist. Okay, definitely she should be sent for a psychiatric consultation. Okay, here the patient should be sent for a psychiatric consultation, because we have seen that the cough sound is normal. So if cough sound is normal, definitely the patient is able, okay, the patient is able to produce voice as well, and the vocal cord movements are also normal, so there is no problem in the vocal cord. She is only doing drama. Okay, so that's the important thing. Now, if I talk about this, what is this? A lot of questions in the recent neetpg as well as recent fmge jan examination on this, as they are asking you questions from the clinical points. So therefore, this has become a lot important now. This is what is the case of tracheostomy. So here you can see a tracheostomy has been performed. And when do we perform a tracheostomy in a patient? When the patient is having severe respiratory distress and we are not able to get a proper and we are not able to perform proper intubation in the patient. Okay, so what is tracheostomy? I've told you, ostomy means creating a mouth or creating an opening. Okay, so you are creating a mouth or creating a new opening in the trachea of this patient. That is the reason why it is called as tracheostomy. And why you are creating a new opening in the trachea of this patient? Because the airway of this patient is blocked or the airway of this patient is obstructed, due to which he is not able to respire or is not able to breathe. That is what is the indication. Okay, so tracheostomy. Please tell me, important one, what is the best site for tracheostomy? Okay, between which tracheal rings you are going to give an incision to make an opening? Between which tracheal rings you are going to give an incision? I'll talk about the indications in the meanwhile. So the indications of tracheostomy, when we are going to perform tracheostomy, the most important indication is a prolonged mechanical ventilation. So please remember, tracheostomy is not always an emergency procedure. It can also be an elective procedure. How? Because if a patient is admitted in ICU, he is in coma and he is admitted for months together. Now what will happen if you are keeping the endotracheal tube over there for a longer period of time? What will happen? Definitely the patient will have a lot of laryngeal edema, and due to that, definitely the endotracheal tube will start compressing. That is the reason why if a patient is admitted for a longer time and the patient needs a ventilator for a long time, mechanical ventilation is needed for a longer duration of time, for more than 3 weeks or so. That is what is called as prolonged mechanical ventilation. In that condition, due to the high risk of laryngeal edema, we will shift the patient to tracheostomy. Yes, in that condition, we will shift the patient to tracheostomy. Second condition is KICO. I have told you what is KICO is. Can't intubate, can't oxygenate. That means you are not able to intubate the patient and you are not able to provide oxygen to the patient. Okay, so what were the reasons for that? I've already told you in surgery. A patient who is having a cervical spine fracture. Why? Because if there is a cervical spine fracture, you cannot extend the neck of the patient, otherwise it will cause damage to the medulla oblongata. Okay, so therefore intubation becomes difficult. Or if a patient is having a maxillofacial injury, if there is a maxillofacial injury, definitely intubation will become a lot difficult. Or if the patient is having bilateral abductor palsy, I have shown it to you right now. In cases of bilateral abductor palsy also, after surgery, when the patient was having severe respiratory distress, the vocal cords were completely closed. And that is the condition again where you cannot intubate the patient. So all of these conditions where you are not able to intubate the patient properly, in that condition you will go for a tracheostomy. These have been the questions. Okay, याद रख लो वो indications पूछते हैं tracheostomy के. Okay, so that's important for you to remember. So now best site is what? Best site is between which tracheal rings? Anybody? Nobody has answered it over. Yes, very good, all of you. So it is between the second and the third tracheal ring. It is what is called as the mid tracheostomy. Between the second and the third tracheal ring is the best site to perform a tracheostomy or to give an incision for tracheostomy. Okay? So once you have given an incision between the second and the third tracheal ring, then you will insert this tube. This is what is called as a tracheostomy tube. Earlier days we used to use the metallic tubes, but the problem with metallic tubes were they used to cause ischemic necrosis. That is the reason why nowadays we are using this PVC tubes, polyvinyl chloride or plastic tubes. These PVC tubes can be of two types. Either it can be a cuff tubes, which has this balloon or cuff, or other one can be an uncuffed tube, which has no balloon over there. Now, I've already told you, this was the recent FMG Jan 2023 question, that cuff tubes are used in which patients? Please let me know that. Cuff tubes are used in which patients? That I've already told you in surgery as well. Cuffed ET and cuffed tracheostomy tubes. What is the role of cuffed tubes? Are they used for fixations? Are they used for fixation of the tube? Is the cuff used for fixation of the tube, or there is any other role of the cuff? Please let me know that. What is the role of the cuff? So please remember, better is cuff definitely, but why? What is the reason? Very good. In ICU patients or in comatose patients, very good. In ICU admitted patients or in comatose patients, definitely the patients who are having, okay, diminished reflexes, the cuff reflex will be missing in this patient, and if the cuff reflex is missing in this patient, anything can directly enter into the lungs of this patient, and that is the reason why the patient will have high chances of aspiration. So the important thing is the cuff tubes are generally used to prevent aspiration. The cuff tubes are generally used to prevent aspiration. All of these are previous year question. Cuff tubes are used to prevent aspiration, and they're generally used in ICU admitted or comatose patients. That's the important thing. Very good, very good. Okay, that's important to be remembered. Now, if I talk about the complications of tracheostomy, guys, okay, if I talk about the complications of tracheostomy, usually the most common complication of tracheostomy, just like any other surgical procedure, will be hemorrhage. Okay, most common complication, just like any other surgical procedure, can be hemorrhage. Apart from that, there can be injury to the lungs in children, and that will also cause pneumothorax in the patient. That can also lead to pneumothorax in the patient. Apart from that, there will be injury to important structures. And what are these two important structures in the neck? There will be injury to the recurrent laryngeal nerve, okay, because it lies in close relation to the trachea. Therefore, there can be chances to injury to the recurrent laryngeal nerve, and your which gland? The thyroid gland. If you are not properly retracted the thyroid gland, there can be chances of injury to the thyroid gland as well. Next important is, most important, okay, so here the patient can develop tracheomalacia. What is tracheomalacia? Malacia, I've already told you, malacia means weakness. Now, if you are using a cuff tube for a longer period of time, now that cuff which is there, it is having a lot of pressure, and this will exert a lot of pressure on the tracheal walls, and that will lead to decreased blood supply as well at times to the tracheal walls, and that can lead to tracheomalacia. Okay, so to prevent tracheomalacia or weakness of the tracheal walls, nowadays which kind of cuff we should use? We should use a high volume. Okay, so if there is high volume, aspiration will be prevented, but a low pressure cuff. High volume but a low pressure cuff. So if the pressure is low, definitely the risk of tracheomalacia will be decreased. Okay, so high volume and low pressure cuff can be used, or at times you will just deflate the cuff after every 2 hours for a span of 5 minutes. हर 2 घंटे बाद 5 मिनट के लिए उस cuff को deflate कर दो, उसमें से हवा निकाल लो, so that tracheomalacia will be prevented in the patient. And the most deadly complication in cases of tracheostomy is what is called as tube blockage. Okay, so what was there? A patient was admitted in the ICU, he was in coma, and definitely his saturation started falling in the night. Okay, and you are not even aware ki kya hua hai. You told the sister ki please sister, if he's in intubated also, ET tube also, or tracheostomy also, you have asked your sister that please please suction, okay, please suck all out, please suck out all the secretions which are there in the tube. If you do not properly suction all the secretions, what will happen? All these secretions can cause blockage of the tube. Okay, and if there is blockage of the tube, what will happen? Definitely the patient will have respiratory distress, and due to that the SpO2 or the saturation of the patient will suddenly start falling, and you can lose the patient as well. Therefore, it is a more deadly complication. So tube blockage which is there, please remember, tube blockage, if it is there, definitely in that condition what has to be done in cases of tube blockage? Immediately remove the tube. Okay, immediately remove the tube. Okay, immediately remove the tube and replace the tube. Immediately remove the tube and replace the tube. And if you can, if you think that removal is not required, then only go for proper suctioning of the tube. Only go for proper suctioning of the tube. Okay, but please remember, you immediately need to take care of this patient. Okay, suctioning should be done. Immediate suctioning should be done. Otherwise, you will lose the patient. Okay, so that's the important thing. Now, if I talk about CL larynx, in this patient. Okay, most common type of CL larynx. Please remember, it can be cancer of the supraglottis, it can be cancer of glottis, it can be cancer of the subglottis. Most commonly, it is the glottic cancer. Most commonly, it is the glottic cancer. You need to remember. Please remember. Okay, most commonly, it is the glottic cancer. And what is the lining, normal lining or normal epithelium of your true vocal cord? It is squamous cell carcinoma, squamous epithelium. That is the reason why the most common type of CL larynx is also squamous cell carcinoma. The most common type of CL larynx is also squamous cell carcinoma itself. Please remember. What is the most important risk factor? The important risk factor which are associated with CL larynx is usually smoking, or it can be alcohol intake. So smoking, alcohol, or it can be HPV infections, human papilloma virus infections. Okay? Therefore, they are more commonly seen. As these are the risk factors, they are more commonly seen in males between 40 to 60 years of age. Okay, that's the important thing. Now, important is what is the staging over here, that you need to remember properly. Okay, as I've told you, glottic cancer is the most common one, and as I've told you as well, that glottic cancer will also have the best prognosis. Why the glottic cancer has best prognosis? I've told you, because it does not drain into any lymphatic, and that is the reason why it will not spread via the lymphatic route. That is the reason why glottic cancer will have the best prognosis. Okay, so that's the important thing to be remembered. Second most common type of cancer is the supraglottic cancer. And in supraglottic cancer, definitely the patient will have a feeling of lump inside the throat. Okay, there will be a feeling of lump inside the throat. Patient can also have throat pain at times. And important, the patient will have a hot potato voice. The patient will have a hot potato voice. These will be the features. Okay, and stridor will be there as well. That's important. Okay, important is, yes, high tracheostomy. The only indication for high tracheostomy, that means incision given between the first and the second tracheal ring, is only CA larynx. Yes, only in cases of CA larynx we are going to perform a high tracheostomy. Otherwise, high tracheostomy is usually avoided due to the high risk of subglottic stenosis. Okay, that's the important thing. Now, important is if I talk about the staging of this patient, the TNM staging. At least remember the T staging I've told you: breast cancer, cervical cancer, and usually the laryngeal cancer. These are the three most important, because here the treatment is decided according to the staging, and based on the staging there was a recent question in FMG Jan 2023. Okay, so if I talk about the TNM staging of laryngeal cancer, if I talk about the T staging, which is more important, so please remember, T1 is what? T1 is when only one structure is involved. T1 is when only one structure is involved. They went into depth this time and they asked you T1B and T1A and T1B. So please remember, T1A means only one vocal cord is involved, and T1B means both vocal cords are involved. T1A matlab only one vocal cord is involved, and T1B matlab both the vocal cords are involved. Please remember, in T1 the vocal cords are mobile. That means they are movable. Abhi bhi move kar rahe. In T1 the vocal cords are mobile. Next is T2. Please remember, next is T2 definitely. And what is T2? When more than one structure is involved. When more than one structure is involved, that is T2. Then there is T3. What is T3? Here the vocal cords are fixed or immobile. Here the vocal cords will become fixed or immobile. That is what is T3. Okay? And last is T4. What is T4? When there is an extra laryngeal extension. Okay, when there is an extra laryngeal extension, that means the cancer goes out of the larynx to the muscles of the neck usually, or to the thyroid gland. That is what is T4, extra laryngeal extension. Now, if I talk about the treatment in this patient, definitely for T1 and T2, we will go for a radiotherapy. For T1 and T2, the better treatment is radiotherapy. But for T3 and T4, as the cancer has spread now, for T3 and T4, definitely we need to remove the larynx. And removal of larynx is called as total laryngectomy. Okay, removal of larynx will be called as total laryngectomy. Followed by, we also need to give radiotherapy. Why radiotherapy is given? To prevent any recurrence. Baar baar wapas na aaye. Isiliye, okay? So total laryngectomy followed by radiotherapy, with or without radical neck dissection. With or without radical neck dissection. And what is radical neck dissection? Removal of some structures apart from the larynx from the neck. And what are these structures which are removed in radical neck dissection? Please remember, in radical neck dissection, the structures which are removed are usually, okay, it is level 1 to level 5 lymph nodes. Okay, it is level 1 to level 5 cervical group of lymph nodes. Then we remove two glands. Which are these two glands? One is the submandibular salivary gland, and the second one is actually the tail of parotid gland. The second one is actually a tail of parotid gland. Then we remove two muscles. Which are these two muscles that we generally remove? So we generally remove the sternocleidomastoid muscle, and we remove the omohyoid muscle. So sternocleidomastoid and the omohyoid muscles are to be removed. Then we remove one nerve. And what is that nerve? It is the accessory nerve. The 11th cranial nerve or the accessory nerve has to be removed. And we remove one vein. And what is that vein? Internal jugular vein. So these are the structures which are removed in a case of radical neck dissection. Okay. So that has to be remembered properly. No issues with this, anybody? Chalo. Chalo, आगे बढ़ते हैं. Now, if you have removed the larynx of the patient, definitely, if you have removed the larynx of the patient needs to perform a permanent tracheostomy now. Usually, tracheostomy, as we know, it is a temporary procedure. Na? Once the patient starts breathing normally, we can close the tracheostomy. But only condition where tracheostomy becomes a permanent procedure is a CA larynx, because here you have removed the larynx of the patient. Therefore, we need to perform a permanent tracheostomy. And after that, what should be done for vocal rehabilitation? Now, as the larynx is removed, can the patient speak now? No, the patient is not able to speak. Therefore, for vocal rehabilitation, what should be done? So please remember, for vocal rehabilitation, we have various techniques. One is called as esophageal voice, but problem is esophageal voice is a very difficult technique to learn. Next is this one. What is this? This is what is called as an electrolarynx, also known as an artificial larynx. This is nothing but a battery operated mechanical vibrator device. Okay, you usually keep it on the neck, and it will send vibrations, and then you can convert these vibrations into sound. Okay, so that is the electrolarynx. But the best procedure, if they ask you, the best procedure, the best technique for vocal rehabilitation is usually this one. And what is this? This is a TEP device. What is TEP? Tracheoesophageal puncture device. Yes, surgically we place a device in between the trachea and the esophagus, from which the air from trachea will go inside the esophagus, and then the patient can convert this air into sound. Okay, so that is the tracheoesophageal puncture device, and this had come earlier in your examination. इस वाले को क्या बोलते हैं? This tracheoesophageal puncture device, which is given in the image, is known as Blom-Singer processes. This is what is called as the Blom-Singer processes. Okay, so that's important. Chalo. Moving further now, pharynx. Let me know if you want a break now. If you want a break, then we'll take a break and then we'll start with pharynx. Let me know that. जल्दी से बता दो. अगर ब्रेक चाहिए तो एक ब्रेक लेके फिर we'll start with pharynx. Okay, chalo. Let's take a break. Okay, let's take a break. Okay, 10 to 15 minutes break and then we'll resume. Okay. Welcome back, guys. Hopefully, I'm audible and visible properly, so we can start now. Shall we? Shall we start? Can we start, guys? Just let me know if we can start. Just a minute. Not able to see the. Am I audible? Let me know that once. Am I audible so we can begin? If I'm audible, then we can begin. Okay, great. Chalo. Let's start with pharynx now. So as I've told, as we have spoken about the first part of your throat, that was larynx. Now talking about the second part of your throat, and that is what is your pharynx. So as I've told you, the anterior cylinder which was there, which continues into the trachea and airway, that was your larynx. But the posterior cylinder which is there, which continues into the esophagus, that is what is your pharynx. But it is not only present behind the larynx. Okay, it is longer than that. So please remember, what is the extension of pharynx? So usually pharynx extends from the skull base. Pharynx extends from the skull base till the C6. Okay, that is 6th cervical vertebra. Yes. So pharynx का extension लंबा होता है. The pharynx will start from the skull base and it will end on the 6th cervical vertebra. That is still C6. Okay. Now usually this pharynx which is there, it is a fibromuscular tube. So please remember, it is usually a tube which is made up mainly of muscles. Larynx में क्या क्या था? Larynx में muscles भी थे और cartilages भी थे. But pharynx is usually a fibromuscular tube. It is mainly a fibromuscular tube. If I talk about the pharynx, it has three parts over here. As you can see, the part of the pharynx which lies behind the nasal cavity, the part of the pharynx which lies behind the nasal cavity, it is called as nasopharynx. The part of the pharynx which lies behind the oral cavity, the part of the pharynx which lies behind the oral cavity, this is what is called as your oropharynx. This is what is known as your oropharynx. And the part of the pharynx which lies behind the larynx, the part of the pharynx which lies behind the larynx, this is what is called as your laryngopharynx. This one is what is called as your laryngopharynx. Laryngopharynx is also known as retropharynx. Why? Because it lies behind the larynx. Na? Behind का मतलब होता है retro. So it is also known as retropharynx, or it can also be called as hypopharynx. Hypo means below. So therefore it is also known as hypopharynx. Whereas nasopharynx can also be called as epipharynx. Because it is above, therefore nasopharynx can also be called as epipharynx. Okay? So that's the important thing you need to remember over here. Okay, now if I talk about these parts, definitely, okay, first if I talk about the laryngopharynx, that means the part of the pharynx which lies behind the larynx. Okay, the part of the pharynx which lies behind the larynx. So for example, consider this is your larynx and this is what is your laryngopharynx. Now this is what is your laryngopharynx. Now usually this laryngopharynx has three parts. This laryngopharynx has three parts. These ones which are there, now, these are known as your piriform fossa or your piriform sinus. These are what are called as your piriform fossa or the piriform sinus on both the sides of the larynx. Okay, laterally. This part which is there is called as the postcricoid area. This part which is there is known as the postcricoid area, and this part over here is known as the posterior pharyngeal wall. This part over here is known as the posterior pharyngeal wall. Now if they ask you which is the most common site of hypopharyngeal malignancy, which is the most common site of hypopharyngeal malignancy? So please remember, cancer usually in hypopharynx or in the laryngopharynx, the most common site for it is the piriform fossa or the piriform sinus. Okay, for it the most common site is the piriform fossa or the piriform sinus. That's the important one-liner that you need to remember. But if they ask you guys, this question, what is this question? As you can see, a middle-aged female complains of pallor and fatigue. We know pallor and fatigue are characteristic features of anemia. Pallor and fatigue are definitely features of anemia. Along with that, the patient is also having spoon-shaped nails. And spoon-shaped nails is also called as koilonychia. Spoon-shaped nails is also known as koilonychia. And this is also a feature of anemia. Which type of anemia we can see this koilonychia? Along with that, this patient is also having atrophic glossitis. Glossitis is nothing but inflammation of your tongue. And along with that, the patient is a known case of post-cricoid carcinoma or post-cricoid cancer. What is the appropriate diagnosis in this condition? What is your likely diagnosis? What are you thinking of? So definitely, due to pallor and fatigue, you're thinking of anemia. Koilonychia is also there. So definitely the patient is having iron deficiency anemia. The first thing is definitely iron deficiency anemia in the patient. But along with iron deficiency anemia, she is also having atrophic glossitis and post-cricoid cancer. What is your likely diagnosis, guys? So please remember, in this condition, the likely diagnosis should be a syndrome which is called as Plummer-Vinson syndrome. Okay, the diagnosis in this condition should be a Plummer-Vinson syndrome. Important is, Plummer-Vinson syndrome is also known as Patterson-Kelly-Brown syndrome. Plummer-Vinson syndrome is also known as Patterson-Kelly-Brown syndrome. It is more common in the middle-aged females, and there's a classical triad. One is iron deficiency anemia and koilonychia along with it. Second is atrophic glossitis, and third, the patient will have post-cricoid web. The patient will have post-cricoid or esophageal web, and from these post-cricoid or esophageal web, a cancer might arise, and therefore the patient will have post-cricoid cancer. So if they ask you overall most common site for hypopharyngeal malignancy, you know answer is piriform fossa or piriform sinus. But if they ask you most common site for hypopharyngeal malignancy in a case of Plummer-Vinson syndrome, now you know the answer is post-cricoid area, because here the patient has these post-cricoid webs. Okay, so that's important thing you need to remember. Next question that we have over here, it says a 7-year-old child was brought with complaints of bilateral CHL. What is CHL? Conductive hearing loss. So the child was having bilateral conductive hearing loss. Along with that, the child is having poor school performance. As she is not able to listen anything, she is not attentive in the class, and therefore she is having a poor school performance. This is given in the questions of previous years as well. And the below given characteristic facies. What is the diagnosis? What is this characteristic facies over here? You can see this characteristic facies. Here the child is having a pinched nose. Okay, the nose appears to be pinched off. Along with that, the child is having open mouth. Okay, so the child is breathing with the help of mouth. She is having open mouth. Along with that, there is crowding of teeth which is there, and a high arched palate. This characteristically is known as which facies, anybody? This is known as which facies, anybody? What are you suspecting? Bilateral conductive hearing loss along with these characteristic facies, poor school performance in a school going child. Very good. This is characteristically known as the adenoid facies. Please remember, this is characteristically known as the adenoid facies, and definitely all of these features, adenoid facies, conductive hearing loss, okay, usually these are due to a condition known as adenoid hypertrophy. These are due to a condition known as adenoid hypertrophy. Please remember that. Okay, these are due to a condition known as adenoid hypertrophy. So what are adenoids? Adenoids are nothing else but tonsils itself. You say tonsils? Yes. There are also a variety of tonsil. What is tonsil? Tonsil is nothing but a collection of lymphoid tissue. And what is the function of a lymphoid tissue? It will provide you local immunity. It will act as a watchman or a policeman. Okay. So for example, the tonsils which are present in our oropharynx, okay, that is your palatine tonsils, they will provide local immunity to the oral cavity. The ones which are present in the nasopharynx, they will provide immunity to the nasopharynx. Okay. So the ones which are present in the nasopharynx at the junction of roof and the posterior wall of nasopharynx, these ones are all called as adenoids. These lymphoid tissue which are there, or these tonsils which are there present in the nasopharynx, are called as adenoids. And these adenoids, they are usually present at birth. They grow till size till what age? They grow till size up to 6 years of age. Then they start decreasing in size at around puberty, and they will completely disappear by 20 years of age. So you and me will not have these adenoids usually. Okay? So usually in a school age child, there can be adenoid enlargement. But if there is an excessive enlargement of adenoids, that is what is called as adenoid hypertrophy. It is more common in school age children. And what is the most common cause for it? So the most common cause for it is recurrent upper airway infections. So if a patient is having recurrent upper airway infections, तो मैंने क्या बोला, इन्फेक्शन से लड़ने के लिए, लोकल इम्यूनिटी देने के लिए कौन आता है? टॉन्सिल्स आते हैं या लिम्फॉइड टिश्यू आते हैं. एंड द लिम्फॉइड टिश्यू व्हिच आर प्रेजेंट एट द लेवल ऑफ नेसोफैरिंक्स कौन होते हैं? एडिनॉइड्स. So therefore if a child is having recurrent upper airway infection, that is the reason why his adenoids will be working overtime, and due to that they will have hypertrophy. There will be adenoid hypertrophy. Okay, there will be a characteristic appearance as seen over here. The child will have adenoid faces as well. Along with that, why there will be bilateral conductive hearing loss? So understand this. I hope all of you are quite aware that we have middle ear, and from this middle ear we have a connection with the nasopharynx. This connection which is there with the nasopharynx, okay, it is what is called as your eustachian tube. This connection with the nasopharynx which is there now, this is what is known as your eustachian tube. Important is, please remember, if this eustachian tube is blocked, what will happen? Important is, what is the function of eustachian tube? So one of the important function of eustachian tube is to drain the secretions of the middle ear into the nasopharynx. Why? Because middle ear is a closed cavity. It is like a closed cabin. It only has one opening, one door, and that door is your eustachian tube. And this middle ear, this compartment is lined by mucosa. And what is mucosa? Mucosa secretes mucus. So all this mucus or all these secretions which are there now, they have to be drained somewhere, and therefore they are drained via the eustachian tube into the nasopharynx. But in conditions where there is adenoid hypertrophy, okay, if there is adenoid hypertrophy, both sided eustachian tubes will be blocked. If both sided eustachian tubes are blocked, you will see that the collection, the secretions which are there from the middle ear, they are not able to drain. Therefore, all these secretions will keep on collecting inside the middle ear, and this is what is called as glue ear. As there is glue ear, a lot of glue-like fluid, thick glue-like fluid collected in the middle ear of this child. Therefore, there will be problem in conduction of the sound, and therefore the child will have conductive hearing loss. Okay? So that's the important funda over here. The child has bilateral conductive hearing loss due to bilateral glue ear, and that bilateral glue ear is due to blockage of eustachian tube on both the sides. Okay? So that's the important thing. Important is, guys, over here, what should be the treatment in this child? What should be the treatment in this child? Definitely, if the adenoids are hypertrophied, we need to go for removal, and that is what is called as adenoidectomy. That is what is known as adenoidectomy. But if a child is having hearing loss, definitely we might need to perform. We might need to perform a procedure where we will drain all the fluid which has been collected in his middle ear, and then for certain time, definitely we will insert a middle ear ventilation tube, and that middle ear ventilation tube is what is called as grommet. Okay, so if we need to drain all the fluid, we will give an incision over the myring or the tympanic membrane, that is called as myringotomy. Plus, along with that, we will insert a middle ear ventilation tube, and that is what is called as a grommet. So grommet insertion should be done. Okay. So only if the patient is having hearing loss, we will go for myringotomy along with grommet insertion. No issues today, anybody? So that's the important thing about adenoid hypertrophy you need to remember. If I talk about this, याद रखना है सरकारी क्वेश्चन है तुम्हारे एग्जाम का. This is a endoscopic image of your nasopharynx. This was asked in the recent NEET-PG examination as well, and have been asked in twice or thrice since August 2020 FMG examination. Okay? So this is very easy, guys. This is the endoscopy of your nasopharynx. Important is, if you enter into the nasopharynx, so you will insert the endoscope from your nose. You will go till the posterior opening of your nose. This posterior end of your nose is what is called as choana. And then once your endoscope enters into the nasopharynx, these are the structures you will be able to find. What are these structures? The first opening which is seen laterally, ये जो पहली opening दिख रही है laterally, this is nothing but the eustachian tube opening. The first opening you are able to see laterally, this is your eustachian tube opening. Where the eustachian tube will open, we know this part is made up of cartilage. Therefore, we can see this cartilaginous protrusion, and this is what is called as torus tuberous. Okay, this is called as torus tuberous, the protrusion that you can see. And अगर कोई protrusion है तो उसके पीछे depression भी होगा. So if there is a protrusion, there will be a depression alongside, and therefore behind this torus tuberous, the fossa that we can see over here, okay, behind the torus tuberous, the fossa that we can see over here is known as fossa of Rosenmüller. Why this fossa of Rosenmüller is so much important? Because this fossa of Rosenmüller is the most common site for nasopharyngeal carcinoma. It is the most common site for your nasopharyngeal carcinoma. That's the reason. Okay, so anterior opening, which is seen, the first opening is eustachian tube opening. Then the elevation that you can see is torus tuberous, and behind that, if they mark, then that is what is fossa of Rosenmüller. Okay, so these are the things that they mark usually in the examination, and it's a very easy question. Don't make a mistake now. Okay, chalo. Now sarkari question again. Yes, her exam hai, whether it is NEET-PG or FMG exam, every exam has this question. Okay, so a 14-year-old boy comes with recurrent, that means bar, okay, recurrent profuse epistaxis. Profuse मतलब बहुत ज़्यादा. Okay, so the child, 14-year-old child or boy, he is having recurrent profuse epistaxis along with a nasal mass. What is the most appropriate investigation to make a diagnosis? What is your provisional diagnosis first of all? What are you thinking? Your 14-year-old boy is coming to me with profuse epistaxis and a nasal mass. What is my likely diagnosis? If there is a mass, definitely I need to think in terms of tumor. Where there is a mass, there is a nasal mass. So either the patient is having some nasal tumor or there is some nasopharyngeal tumor. And as the patient is having epistaxis, what is epistaxis? Nose bleeds, खून आ रहा है नाक से. Therefore, the patient is having a vascular tumor. Very good. So the diagnosis over here definitely is a case of JNA. What is JNA? Juvenile nasopharyngeal angiofibroma. It is a case of juvenile nasopharyngeal angiofibroma. Why juvenile? Because it is more common in children less than 18 years of age. That is what is a juvenile age group. So usually it is more common in boys mainly between 12 to 14 or 16 years of age. And it is a nasopharyngeal angiofibroma. So now angiofibroma, that means it is a benign tumor which arises from the blood vessel. Therefore, it is called as a angiofibroma. Rather, you need to remember it is the most common benign tumor of your nasopharynx. It is the most common benign tumor of your nasopharynx. What is the most common complaint in this child? As we know, it is either a nasal mass or recurrent epistaxis will be there. These are the usual complaints of this child. Important is, though it is a benign tumor now, it is locally invasive as well. Okay, though it is a benign tumor, it is locally invasive. That means it will invade the other structures as well. That's the reason why it will also invade the pterygomaxillary fossa. That means it will grow, it will start growing from which side? Now, just answer me. What is the most common site of origin? What is the most common site of origin? This is the previous year question. What is the most common site of origin of juvenile nasopharyngeal angiofibroma? Please let me know that. Most common site of origin for JNA. Okay, so this tumor will start arising behind the nose and then it will grow laterally in the pterygomaxillary fossa and then it will appear as a cheek swelling. Apart from that, as I've told you, it is a locally invasive tumor. Definitely it will grow behind the orbit also. As it grows behind the orbit, it pushes the eyeball forward and that is what is called as proptosis. Okay, that is what is known as proptosis. Along with that, it causes broadening of the nose as well. There will be broadening of the nose, and proptosis along with broadening of the nose, this together leads to a deformity of the face, and that is known as frog face deformity. That is what is called as the frog face deformity. No, it is not the lateral nasal wall. It is the inverted papilloma of nose or Ringer's tumor which arises from the lateral wall of nose. So please remember, here it arises behind the nose from the sphenopalatine foramen. The most common site, very good Karishma, it is the sphenopalatine foramen. So please remember, the most common site for origin of a juvenile nasopharyngeal angiofibroma is the sphenopalatine foramen. That you need to remember for sure. Okay? So that's important. Chalo. Important is now what is done for investigation. What is the investigation of choice or the most appropriate investigation to make a diagnosis of this condition? Let me know what is done for investigation. What is the investigation of choice? Anybody? What is the investigation of choice? The investigation of choice will be so please let me know. For a tumor, we generally go for a biopsy. But can we do a biopsy over here? No. Biopsy cannot be done over here. Why? Because biopsy is contraindicated. The reason is it is a vascular tumor. It is a highly vascular tumor. And if you try to perform a biopsy, the patient will bleed to death. Okay, so the patient will bleed to death if you try to perform a biopsy in this patient. That's the reason we will go for CCT scan as the investigation of choice. Okay, so that's the reason why CCT, contrast enhanced CT scan, is the investigation of choice. And on a CCT, definitely this is the classical sign which is seen. You can see that the posterior wall of the maxillary sinus is pushed forward. So there is anterior bowing of the posterior wall of maxillary sinus. This is what is called as the Holman-Miller sign. This is what is known as the Holman-Miller sign, also known as the antral sign. This is what is called as the Holman-Miller or the antral sign. Okay, that's the important thing you need to remember. Okay, chalo. Now, if I talk about treatment, this was again our question. There were two questions in FMG Jan 2023 on JNA. So please tell me, what is the treatment? They asked you about diagnosis also. You have told me the CCT scan. But what is the treatment? Whether you will go for chemotherapy, radiotherapy, chemoradiation or surgical excision. What is your answer? What is the best treatment for a juvenile nasopharyngeal angiofibroma? Answer that. The treatment of choice will be The treatment of choices. Very good. So treatment of choice is a surgical excision. Very good. The treatment of choice is surgical excision. So you will say, sir, if you are saying that biopsy is not allowed because the tumor can bleed so much and the patient can die, so how are we going to perform a surgery? So please remember, before surgery, we will go for a pre-operative embolization. That means the parent artery which is there of the tumor, usually it is a maxillary artery. We are trying to embolize this maxillary artery, and then the blood supply to this tumor will be reduced, and then we will try to surgically excise this tumor. Okay? So pre-operative embolization should be done as well. Okay? Now talking about the malignancy. We have spoken about the benign tumor. Now talking about the malignancy, and that is what is called as NPC. What is NPC? It is nothing else but nasopharyngeal carcinoma. It is nothing else but nasopharyngeal carcinoma. It is the most common malignancy of nasopharynx. It is the most common malignancy of the nasopharynx that you need to remember. Important is, it is commonly associated with a viral infection. And what is that viral infection? Please let me know. It is commonly associated with a viral infection. And what is that viral infection? Let me know. Apart from that, it is more common in the Chinese or the Mongoloid race. It is more common in the Chinese or the Mongoloid race as well. We are able to see high chances over there due to some genetic mutations. Okay? So that's the important thing. Please remember. Okay? Nasopharyngeal carcinoma, important is, you need to answer me this as well. It is commonly associated with which infection? And second, what is the most common clinical presentation? So a lot of people will feel, okay, it is a nasopharyngeal cancer, na? So definitely the patient can have some nasal mass, nasal obstruction, but no. Please remember, usually, what did I tell you? What is the most common site of origin for this tumor? So the most common site for origin for a nasopharyngeal carcinoma was the fossa of Rosenmuller. And we know if it arises from a fossa of Rosenmuller, initially it might not cause any symptoms. Initially, it might not lead to any symptoms. See, your cancer is over here somewhere. Okay, initially it will not cause any symptoms in the patient, definitely, right? So, पहले तो patient में कोई symptoms नहीं आते. The symptoms are directly when the cancer will metastasize. Yes, when the cancer metastasizes to the cervical group of lymph nodes, then the patient will come to you. That's important. Very good. The most common clinical presentation is usually a painless cervical lymphadenopathy. Very good, Saurabh. Okay, it is painless cervical. It is painless metastatic. It is a painless metastatic cervical lymphadenopathy, which is the most common clinical presentation. And all of you are also right. Yes, the most common cause or the infection which is commonly associated with NPC is definitely EBV, that is your Epstein-Barr virus infection. Okay, so that's important. Apart from this, definitely as it is a cancer or as it is a malignancy, definitely it will keep on spreading and it will keep on involving the other structures as well. Therefore, it involves a lot of other structures. Mainly it spreads to the skull base, and therefore it involves the cranial nerves as well. If they ask you which is the most common cranial nerve involved, what is your answer? Let me know that. Which is the most common cranial nerve involved in cases of most common cranial nerve palsy in cases of nasopharyngeal carcinoma? Then there is a classical triad, and that classical triad we all of us are quite aware of. That is known as the Trotter's triad. So the classical triad of nasopharyngeal carcinoma is known as the Trotter's triad, and this Trotter's triad can be remembered with the same mnemonic, that is NPC. The Trotter's triad can be remembered with the same mnemonic of nasopharyngeal carcinoma, that is NPC. So where N stands for what? So please remember, N stands for neuralgia. Neuralgia is what? Severe pain due to nerve irritation. And which nerve is irritated over here? The trigeminal nerve is irritated. And therefore the patient has severe pain or neuralgia in this temporoparietal region usually. Okay. So there is severe neuralgia due to fifth nerve involvement, definitely. Okay, that is trigeminal nerve involvement. Then the patient will have palatal palsy. Okay, the patient will have palatal palsy, and palate is supplied by which nerve? It is supplied by the 10th cranial nerve. Therefore, due to 10th cranial nerve or due to vagus nerve injury, the patient will have palatal palsy as well. And definitely C stands for what? C stands for unilateral conductive hearing loss. C stands for unilateral conductive hearing loss. So why here there is a unilateral conductive hearing loss? Because we know adenoids were present in the center. Therefore, when they were hypertrophied, they were blocking both the openings of the eustachian tube, right as well as left. But usually, this cancer will arise from only one side, and therefore it will only block one of the eustachian tube opening, causing unilateral glue. As there is a unilateral glue here, the patient will develop unilateral conductive hearing loss. Okay? So that's the important thing you need to remember. This is a very important triad that has to be remembered multiple times asked. Okay. So very good. It is the most common one is the fifth cranial nerve to be involved. Most common is the fifth cranial nerve to be involved in cases of nasopharyngeal carcinoma. That is your trigeminal nerve. Okay. That's important to be remembered over here. कोई दिक्कत नहीं है इसमें. चलो, now once if I talk about nasopharyngeal carcinoma, I've spoken everything about it. Let me know the treatment. जल्दी से बताओ. Let me know the treatment. Let me know the treatment. Again, the same 4 options: surgical excision, chemotherapy, radiotherapy, chemoradiation. What is the best answer? What is the best answer? So please remember here the treatment of choice in cases of nasopharyngeal carcinoma, the treatment of choice is usually chemoradiation. Okay, here it is concurrent chemoradiation, chemo plus radiotherapy. Okay, very good, very good. Okay, so very good. So it is chemoradiation definitely, which is the treatment of choice in cases of nasopharyngeal carcinoma. That's important. Next, if I talk about the oropharynx now. In oropharynx, if I talk about the basic anatomy, all of us are quite aware usually. The roof of the oropharynx which is there is formed by the hard palate anteriorly and the soft palate posteriorly. So mainly it is the soft palate which forms the roof of oropharynx. The floor which is there is formed by the base of tongue. The floor which is there, it is formed by base of tongue. Then definitely we have this posterior pharyngeal wall over here. Then we have this extension of the soft palate, and this extension of the soft palate is known as the uvula. Okay, laterally if I talk about, laterally we have this anterior tonsillar pillar. This anterior tonsillar pillar is also known as palatoglossal arc, whereas we have this posterior tonsillar pillar, and this posterior tonsillar pillar is known as the palatopharyngeal arc. In between both of them, we have this palatine tonsils over here. In between both of them, we have a tonsillar fossa, and in that tonsillar fossa, you have your palatine tonsils, which you commonly refer to as only the tonsils as well. Okay? So that's the important thing usually over here. If I talk about the tonsils, okay, just a minute. So if I talk about the tonsils over here, as I've told you, they are present over here, okay, between the anterior and the posterior tonsillar fossa. So on the lower aspect of the tonsils, we have a capsule. Yes, tonsils usually, the palatine tonsils have a capsule. Other tonsils do not have a capsule. Okay, we have the capsule. It is partial only. Okay, half में ही होती है बस on the base, and then definitely the bed of the tonsil is there. This bed of the tonsil which is there now, this bed of tonsil is usually formed by the superior constrictor muscle. The bed of the tonsil which is there is formed by the superior constrictor muscle. Over here in the bed of the tonsil, we have the styloid process, and we have our 9th cranial nerve. Which is your 9th cranial nerve? Glossopharyngeal nerve. But at times what will happen? The styloid process can be too long, and therefore this long styloid process can irritate. The long styloid process can irritate this glossopharyngeal nerve, and glossopharyngeal nerve will get irritated, and glossopharyngeal nerve supplies two sides. One is the throat and second is the middle ear. Therefore, the patient will not only have throat pain, but the patient will also have a referred ear ache or a ear pain as well. And that is called as a referred otalgia. So please remember, if a nerve is irritated, it will not only cause pain at the site of irritation, but it will cause pain at every site it is innervating or it is supplying. ठीक है, तो ये बात याद रखनी है. ठीक है, and that condition is what is called as styalgia. So what is styalgia? Styalgia is also known as Eagle syndrome. Please remember, styalgia is also known as Eagle syndrome. And what happens over here? There is a too long styloid process. Okay, there is a too long styloid process, and this long styloid process, as we know, definitely it irritates the glossopharyngeal nerve. It irritates the 9th cranial nerve or your glossopharyngeal nerve. Therefore, the patient complains of what? Therefore, the patient complains of throat pain with a referred otalgia. Patient complains of throat pain with referred otalgia. Okay, so that is what is seen. Treatment क्या है? Just काट दो extra जो भी है. Okay, the long styloid process ना, just remove that. That is treatment is styloidectomy. Treatment for this condition is what is called as styloidectomy. Just remove the excess length of the styloid process. That is what is done over here. Now, if I talk about this condition, what is this? You are able to see that on the tonsils, you are able to see this whitish appearance. Okay, this whitish membrane is formed over the tonsils. The tonsils are also enlarged in size, you can see, and there's a whitish membrane on the tonsils. So now there are multiple causes for whitish membrane on the tonsil. What is the most common cause for whitish membrane on tonsil? जल्दी से बता दो. What is the most common cause of whitish membrane over tonsils? What is the most common cause for whitish membrane over the tonsils? The most common cause for whitish membrane over the tonsils is So please remember, the most common cause for whitish membrane over tonsils is acute membranous tonsillitis. And this acute membranous tonsillitis is what? It is infection or inflammation of the tonsils, and in which infection there will be a membrane, whitish membrane, which will be formed over the tonsils. What is the most common cause for this acute membranous tonsillitis? The most common cause for this acute membranous tonsillitis is group A beta hemolytic streptococci. It is known as group A beta hemolytic streptococci, also known as streptococcus pyogenes. It is also known as streptococcus pyogenes. Now, another question to you, and which has been asked multiple number of times in the examination, and the question is usually, we have a patient who is a known case of bronchial asthma. Recent NEET-PG also there was a question, okay, who is a known case of bronchial asthma, and he is currently taking some treatment. He is currently on his treatment, okay. He is taking his inhalers, and now this patient develops whitish patch. This patient develops a whitish patch all over the oral cavity. This patient develops a whitish patch in the oral cavity. It is not only present over the tonsil, but also the tongue, the palate, okay, everywhere. Okay, there is a whitish patch over the in the oral cavity or over the buccal mucosa. What is the likely diagnosis? And this patch bleeds on removal. And this patch bleeds on removal. What is the likely diagnosis? What is the likely diagnosis? Let me know faster. What is your answer, guys? So let me know. What is your answer to this question? What is your answer? Please let me know. So here the patient is taking some treatment, and that is nothing but the inhalers. So that's the problem. As soon as you hear bleeds on removal, you tend to mark it as diphtheria. No, guys, in other conditions also, the membrane can bleed on removal as well, okay. And here definitely the membrane is not only extending up to the palate, but it is also present all over the oral cavity. Here the patient is on treatment, and what is the drug of choice for bronchial asthma maintenance? It is inhaled corticosteroids, na. So the patient is taking corticosteroid inhalers, and if a patient is taking corticosteroid inhalers, what will happen? His local immunity which is there will be suppressed, due to which there will be a high risk of fungal infection. And the most common fungal infection which occurs is the Candida albicans. So this is a case of oral candidiasis or oral thrush. This is a case of oral candidiasis or oral thrush. Okay, so very good, Subhan. Okay, so it is a case of oral candidiasis or oral thrush. Please remember. Okay, so either they will give you an immunocompromised patient like HIV positive patient, or they will give you a bronchial asthma patient currently taking inhaled corticosteroids, due to which a patient develops this curd-like or a cottage cheese-like patch in the oral cavity which bleeds on removal. That is a case of candidiasis, and the drug of choice is fluconazole for that condition. In diphtheria, you will be able to see a whitish membrane or a pseudo-white membrane, pseudo-grayish-white membrane. This membrane will start from the tonsils. It will extend up to the palate. So this membrane which is there, definitely it extends up to the palate. It is not only limited up to the tonsil. Second, it also bleeds on removal. This also bleeds on removal. But here the patient will also have other features like fever will be there. Along with that, there will be this bilateral cervical lymphadenopathy. And due to this bilateral cervical lymphadenopathy, as you can see, the child is having diffuse neck swelling. And this was the previous year question. Here the child will have this classical appearance known as the bull's neck. Okay, there will be a characteristic bull's neck appearance. This is a case of diphtheria, definitely. This will be a case of diphtheria. Small child presenting to you with this bilateral cervical lymphadenopathy or bull's neck, along with a whitish membrane or a grayish membrane extending up to the palate and which bleeds on removal. This is a case of diphtheria caused by Corynebacterium diphtheria. Okay? That's the important thing. Other causes of whitish membrane over the tonsils can be multiple. It can be an infectious mononucleosis due to Epstein-Barr virus. It can be a Vincent's angina due to Borrelia vincenti, which is usually after a dental caries or a dental infection. It can be after a leukemia or usually malignancy of a tonsil, agranulocytosis. Okay, multiple other conditions. Chalo. Moving further, next question. We have over here a child who presents to us with complaints of fever, neck swelling, dysphagia, trismus. Trismus is a lockjaw. That means the child is not able to open up his mouth properly. Examination findings are given below. What is the diagnosis? What is seen on the examination finding? You are able to see a neck swelling definitely in the child. You are able to see a neck swelling in the child. Along with that, you can see there is an abscess or a pus formation over here, and due to which you can see the tonsil is pushed somewhat forward, okay, and the uvula can be pushed towards the opposite side, okay. So that is the classical finding over here. What is your likely diagnosis? Child, neck swelling, and all of these features like dysphagia, trismus, tonsil push towards the midline, and uvula push towards the opposite side. What is your likely diagnosis in this condition? What is your likely diagnosis? What are you suspecting? जल्दी से बता दो. This is an abscess, definitely. It is a pus collection. But whether it is quinsy, it is a case of retropharyngeal abscess, parapharyngeal abscess, or a prevertebral abscess. You have 4 options with you. First say. What is your diagnosis more likely? Please answer it. So please remember, it is a case of parapharyngeal abscess, guys. It is a case of parapharyngeal abscess. Why not it can be quinsy? So please remember, okay, please remember why it cannot be quinsy or peritonsillar abscess is, in cases of quinsy or in cases of peritonsillar abscess, definitely the patient does not have any neck swelling, okay, and it is usually an adult who is affected, okay. So it is a case of parapharyngeal abscess. So 2 important things to differentiate between quinsy and parapharyngeal abscesses. Here, more common age group which is affected is a child. In quinsy it is an adult. Second, in quinsy there is no neck swelling, but in parapharyngeal abscess definitely the neck swelling will be present, okay. So here all of the other features will be similar like quinsy. Only because of swelling and the age group, we are most likely thinking in terms of parapharyngeal abscess. Treatment: as the swelling is externally visible, we are going for external incision and drainage along with antibiotics. Here, this is a condition which can be called as a quinsy or peritonsillar abscess. This is a condition which is known as quinsy or a peritonsillar abscess, okay. So what is the peritonsillar space? As I have told you, so please remember, quinsy also known as peritonsillar abscess. This is what is your peritonsillar space over here, okay, in between the bed of the tonsil and the tonsillar capsule. If over here there is a pus collection, that is what is quinsy, peritonsillar abscess. As we know that quinsy or peritonsillar abscess, yes, right, it is more commonly seen in adults, okay, it is more commonly seen in adults, and here there is no neck swelling. All other features will be similar. The patient can have fever, definitely. Along with that, the patient can also have difficulty in swallowing, that is dysphagia can be there, okay. The tonsils will be pushed medially, as you can see, and the uvula, the tonsil is pushed medially and the uvula is pushed towards the opposite side. All the other features will be same, but the only important thing is there will be no neck swelling in cases of quinsy, okay. Most common cause for quinsy will be Streptococcus pneumoniae. Please remember, the most common cause of quinsy will be Streptococcus pneumoniae. That you need to remember. It is not Streptococcus pyogenes over here. It is Streptococcus pneumoniae. And the treatment for this condition, as the swelling is inside the oral cavity, you are not able to see any swelling from outside. Therefore, you cannot go for an external IND. You need to go for a per-oral incision and drainage along with antibiotics. You will go for a per-oral incision and drainage through the oral cavity along with antibiotics. Okay? That is what is quinsy for all of you. Okay? Moving further, here also in quinsy we know all the other features. There will be a hot potato voice as well, no? There will be a characteristic hot potato voice. Okay, so there will be trismus, there will be hot potato voice. Important is, just let me know a previous year question. The trismus or the lockjaw which occurs in quinsy, it is due to spasm of which muscle? That was a previous year question of FMG. So the trismus or the lockjaw in quinsy which is there, it is due to spasm of which muscle? Which masticatory muscle? Is it temporalis, masseter, medial pterygoid, lateral pterygoid? It is due to spasm of which muscle? Let me know that once. Okay. Then if I talk about the next question, here a child is brought to the emergency room with respiratory distress. There is fever, there is muffled voice, and there is dysphagia in the patient as well. X-ray soft tissue neck has been given below. What is the next best step in the management of this child? Okay, so here the provisional diagnosis, as you can see over here. So very good, Jitendra. It is the medial pterygoid muscle. Very good. So trismus which is there in a case of quinsy, it is due to spasm of the medial pterygoid muscle. It is due to spasm of the medial pterygoid muscle. That was a previous year question that you need to remember. Okay, it is not the lateral pterygoid, because in most of the cases it is lateral. So you might answer it as lateral over here. It is the medial pterygoid over here. Okay. So now the next question that we have, what I've read out, a child brought to the emergency room, complaints of respiratory distress, fever, muffled voice. Muffled is nothing but the hot potato voice or the plummy voice. Along with dysphagia, X-ray soft tissue neck has been given below. What is the next best step in management? Now this condition resembles, okay, this condition looks like acute epiglottitis. But is it acute epiglottitis? So for that we have taken as X-ray soft tissue neck, okay, to differentiate whether it is acute epiglottitis or not. So on X-ray soft tissue neck, as you can see, in cases of acute epiglottitis, we are able to see the characteristic thumb sign. Is any characteristic thumb sign seen over here? No. So therefore, it is not a case of acute epiglottitis. It is a close differential diagnosis of acute epiglottitis, where you can see in front of the vertebrae, there is collection of pus over here. The black appearance that you can see now, it is nothing but the pus which has been collected over here. So this prevertebral shadow which is there now, it has widened up. And if we confirm it further by other radiological investigations, you can see that the pus is collected actually in the retropharyngeal space. Okay, the pus is collected over here in the retropharyngeal space. Okay, so definitely if I talk about the diagnosis over here, it is a case of acute retropharyngeal abscess. So if you feel that the condition definitely looks like acute epiglottitis, but the child is not having any kind of thumb sign, then definitely you need to think in terms of acute retropharyngeal abscess. Why? Because acute retropharyngeal abscess is a close differential diagnosis of acute epiglottitis. As I've told you, this is your larynx, then is your laryngopharynx. The posterior wall of the laryngopharynx is your buccopharyngeal fascia. Okay, behind buccopharyngeal fascia, the space that we have is what is called as the retropharyngeal space, which is divided into two halves by the midline septum. Then we have the alar fascia which is there. Then we have the dangerous phase. Then we have the prevertebral fascia. Then we have the prevertebral space finally, and then we have the cervical vertebra. So this is what is the arrangement. Okay? So this is what is your retropharyngeal space in which there is collection of pus over here. That is what is the abscess formation. Why? Because the lymph nodes which are present over here, these are infected. The retropharyngeal group of lymph nodes are infected over here. These spaces which are there, this is the retropharyngeal space as you can see, and it is divided into two halves by a midline septum. These spaces are known as spaces of Gillette, and the lymph nodes which are present in the spaces of Gillette are known as lymph nodes of Rovio. And when these lymph nodes of Rovio, the retropharyngeal lymph nodes get infected, that leads to collection of pus in the retropharyngeal space, and that is what is the case of retropharyngeal abscess. All the features will look like acute epiglottitis. Okay, it will be a close differential diagnosis of acute epiglottitis in the patient. What is the first line of management or next best management? Answer the question. What is the next best management in this condition? What is the next best step in management of this patient? What is the next best step in management of this patient? The next best step in the management of this patient, you need to remember, guys, definitely, as it is a close differential of acute epiglottitis, here also, no, again not. The first line management or the main next best step in management, child is having respiratory distress. Why are we giving antibiotics to the child first? Why it is our first priority? First priority is always the airway. First priority is always the airway management. Here also we will go for airway management as our first priority. Very good, Amruta. It is the airway management which is the first priority in every condition of respiratory distress. That's the important thing. Please remember, okay? So we will try to go for an intubation. If not possible, then go for a tracheostomy. Then after that, definitely, as it is an abscess, we will go for a incision and drainage in the patient. Per oral incision and drainage has to be done along with antibiotics. Okay? But first line management is always and always, please remember, it is always and always the airway. And that is how they trick you in the exam. They always ask you about the next best step in management. They don't ask you about the definitive management. Okay? So that's the important thing. Always read the last line twice. Okay? So that's the important thing. On X-ray, what are we able to see? As I've told you, on X-ray, you are able to see widening of the prevertebral shadow, and the cervical spine looks absolutely normal. But along with widening of the prevertebral shadow, if you see destruction of the cervical spine, if you see that there is destruction of the cervical spine, then definitely it is not a case of retropharyngeal abscess. The collection is actually in the prevertebral space. It is a case of prevertebral abscess then. And the cause of prevertebral abscess is usually TB spine or Pott spine. And the treatment for that usually will be incision and drainage again for all the pus which has been collected. But along with that, as the cervical spine has been destroyed, we also need to go for a decompression of the cervical spine. Okay? Next, talking about your oral cavity now. If I talk about oral cavity, please remember, if I talk about some pre-malignant lesions of your oral cavity, there are three most important pre-malignant lesions of oral cavity. All the other are not pre-malignant conditions. A lot of people get confused. So if they ask you what is this, you can see there is a white patch in the oral cavity. Okay, so white is what is called as leuco, and patch is what is called as plakia. So this is what is a case of leukoplakia. And please remember that leukoplakia is the most common pre-malignant oral cavity lesion. It is the most common pre-malignant oral cavity lesion. Next, what you can see over here, there is a red patch. Red is what is called as erythroplakia, is what is called as plakia. Sorry, patch is what is called as plakia. So this is a case of erythroplakia. And please remember that erythroplakia will be having highest chances of malignancy. Erythroplakia will be having highest chances of malignancy. It will be the most malignant lesion. Please remember that. No issues with this, anybody? And the third pre-malignant lesion in oral cavity is known as oral submucous fibrosis. Yes, the third pre-malignant is known as oral submucous fibrosis. Okay, oral thrush or candidiasis is not a pre-malignant lesion. That's the important thing you need to remember. Now, if a patient develops oral cavity cancer, as I've told you in surgery also, except the oral cavity, esophagus and anal canal, everywhere it is adenocarcinoma in the GIT. But in oral cavity, esophagus and anal canal, the most common type of cancer is always a squamous cell carcinoma. So in oral cavity, the most common type of cancer is squamous cell carcinoma. Worldwide, if they ask you what is the most common site, so the most common site worldwide, guys, okay, if they ask you what is the most common site worldwide, the most common site worldwide, as you can see over here, there are these ulcerative lesions on the lateral border of the tongue. So worldwide, the most common site is the lateral border of tongue. Most commonly, worldwide, the most common site is lateral border of tongue. But if they ask you in India, we know our people are having the habit of what? It is usually tobacco chewing. That is why usually they keep this tobacco in the gingivobuccal sulcus. And that's the reason why in India, the most common site for oral cavity cancer will be the gingivobuccal sulcus or the buccogingival sulcus, whatever you call it. Okay. And if they ask you, among gingivobuccal sulcus, which is more common? Is it the gingiva or the buccal mucosa? Then you know the answer, it is the buccal mucosa commonly. Okay, it is the buccal mucosa. Chalo. If they ask you what is the investigation of choice for oral cavity cancer, you can easily take a biopsy. So investigation of choice is biopsy. And what is the treatment in this condition? So please remember the treatment in this condition, usually with a oromandibular dissection. And this oromandibular dissection is a huge operation. It takes a lot of time. So this oromandibular dissection which is there, we remove the maxilla, the mandible, okay, till we neck we dissect and then we create a flap. That is what is called as the commandos operation. That is what is known as the commandos operation. And smoking is an important risk factor for oral cavity cancer. So chhod do. Okay? Otherwise, there will be such a huge operation starting from here till here. Okay? So that's the important thing. So moving further now, talking about this condition. Now make a diagnosis. I am giving you a case. Okay? This patient had a history of some dental infection. This child had a history of some dental caries or dental infection. Now the child has been brought to us in emergency. And the complaints of the child are respiratory distress. Along with respiratory distress, as you can see, that the mouth of the child is completely closed. There is a neck swelling which is seen in the child. Okay, there is respiratory distress. There is a neck swelling which is seen in the child. The child is not able to open the mouth. The tongue is pushed upwards. Definitely. Very good. Very good. Okay. So it is a case of Ludwig's angina. Very good. So the diagnosis in this condition is a case of Ludwig's angina. Definitely. Okay. So Ludwig's angina is what? Ludwig's angina is infection of the floor of mouth. Okay, so please remember Ludwig's angina is nothing but infection of floor of mouth. And this floor of mouth which is there, it is formed by which space? So this floor of mouth is mainly formed by the submandibular space. Okay, the floor of mouth is what is formed by the submandibular space. Okay, so that's the important thing usually. Please remember, so it is actually infection of the submandibular space or the floor of mouth. There will be history of dental caries. The organisms which are responsible are usually mixed organisms. That is Streptococcus viridans along with anaerobes. All of these together are responsible for causing Ludwig's angina in a patient. What is done for emergency management? As the child is having respiratory distress, what is done for emergency management? Please tell me answer. What is the first line management in this child? And now don't tell me the airway. I know it is airway, but how are you going to establish an airway? What is the first line management in this child? Definitely, as the child is having respiratory distress, airway is our first priority, but how are you going to establish an alternative airway? Jaldi se. Let me know first. Yes, very good. It is airway management, but airway management will be done by what? Nasotracheal intubation is very difficult, first of all. Okay, nasotracheal intubation is very difficult, and even in children, it becomes more difficult. Okay, so nasotracheal intubation can be tried, but the problem is usually the floor of mouth is having a lot of swelling. Okay, that is the reason why nasotracheal intubation is not usually done. So very good, it is tracheostomy which is preferred. Yes, very good. So it is tracheostomy which is preferred. Please remember, it is the preferred one is tracheostomy to establish an airway in this child. Apart from that, as you can see, a chin swelling in this child externally only. So for treatment, definitely we'll go for external incision and drainage along with antibiotics. We'll go for external incision and drainage along with antibiotics. Very good. Chalo. So now foreign body I've covered already in surgery. So you can watch that video. Okay. The first video for surgery, sorry, the second video for surgery where I've completed esophagus, and that I've talked about the foreign body in GID also and in trachea and larynx as well. Okay. So I'm not repeating it over here. Next is nose and paranasal sinuses if I talk about. If I talk about nose and paranasal sinuses, guys. So first of all, if I talk about the nose, okay, this appearance of the nose that we get, this is what is called as your external nose. This is what is known as your external nose. And this external nose now, the basic framework of this external nose, it is made up of bones as well as cartilages. And the question has been in the June 2022 examination of FMG, the question was that how much part is bony and how much part is cartilaginous. A lot of people were confused with that. So please remember the upper 1/3 which is there. The upper 1/3 of the external nose is bony in nature. The upper 1/3 of the external nose is bony, which is made up by one pair of nasal bones. Definitely. Whereas the lower 2/3 which is there, the lower 2/3 of the external nose which is there, the lower 2/3 of external nose, it is made up of 6 paired cartilages. And what are these 6 paired 3 paired cartilages? So totally there are 6 cartilages over here. There are 3 paired cartilages. Totally there will be 6 cartilages. The first one that you can see over here, these ones that I'm highlighting, these ones are what are your upper lateral cartilages. These ones are known as your upper lateral cartilages. Then the next one that you can see, which appears like wing, and wing are called as ala in Latin. Therefore, these are known as lower lateral cartilages or alar cartilages. And the third pair is this one, which are present over here at the junction of upper lateral and lower lateral cartilages. These are what are called as your sesamoid cartilages. And these sesamoid cartilages are also known as lesser alar cartilages. Okay. So the sesamoid cartilages are also known as lesser alar cartilages. That you need to remember. Okay. So that's the important thing about the anatomy of your external nose. Please remember. Very good. Now, if I talk about the narrowest portion of your nasal cavity. So this is my nasal cavity. If they ask you what is the narrowest portion of the nasal cavity, it is this portion where the lower lateral cartilage and the upper lateral cartilage meet at the junction. So if you go from inside, this will be my narrowest portion of the nasal cavity. And this narrowest portion of nasal cavity is called as nasal valve. Okay, the narrowest portion of the nasal cavity is what is called as nasal valve. And if there is a blockage in the nose, if there is obstruction or if there is congestion of the nose, highest chances will be that the obstruction or the blockage will occur at the level of nasal valve only. So the question was, this image was given and you already know the maneuver now. So definitely to check the patency or to check the blockage at the level of nasal valve. What is patency? Patency matlab open hai ya nahi. Okay? So to check the patency or to check the blockage at the level of nasal valve, definitely the maneuver that we perform or the test that we perform is known as the Cottel's maneuver or the Cottel's test. Okay. So what is the function of Cottel's test? It is nothing else but to check the patency or blockage. It is used to check the patency or blockage at nasal valve. That is what is the basic function of the Cottel's maneuver or the Cottel's test. Very good. Chalo. Now diagnose this condition over here. Om Puri. All of you might be aware of him. Okay. What is this condition? Okay. Just answer me one important condition. Here there is hypertrophy of which glands? Here it is due to hypertrophy of which glands of skin of external nose? On the skin of external nose, definitely which glands have hypertrophied and that has caused this condition? Are these eccrine sweat glands? Are these apocrine sweat glands? Or these or are these sebaceous glands? Please let me know. Very good. The diagnosis is clear with all of you. This condition is definitely a case of rhinophyma. Okay, this is the case of rhinophyma. Rhino means nose, phyma means potato. Therefore, rhinophyma is also known as a potato nose. Rhinophyma is also known as a potato nose. Very good, all of you. Important is very good, very good. It is due to hypertrophy of the sebaceous glands of skin. Very good. It is due to hypertrophy of the sebaceous glands of skin of the external nose. That's the most important thing you need to remember. A lot of time people tend to forget this. What is the treatment in this condition now? So the treatment will be important is the treatment is usually laser excision should be done, and once we have excised this skin with laser, then definitely we also need to go for skin grafting. So laser excision with skin grafting is the treatment of choice for this condition. Important is, please let me know, it is a subtype of which dermatological condition? Derma में ऐसी कौन सी condition पढ़ी है? Rhinophyma is a subtype of which dermatological condition, and that has been asked prior in your examination. Please tell me, it is a subtype of which dermatological condition? It is a subtype of which dermatological condition? Rhinophyma is a subtype of which dermatological condition? Let me know that fast. Very good, Shubham. It is a subtype of acne rosacea. Very good. Okay, so it is a subtype of acne rosacea. So please remember, so usually in derma you will find that only if it is limited to the nose, they call it rhinophyma or potato nose. But when this hypertrophy starts spreading onto the cheeks and other parts of the face or the skin, then it is referred to as the acne rosacea. So in option, if you could not find, so please remember in options, if you could not find rhinophyma, don't get confused. Sometimes they might ask you as acne rosacea also. Okay, so that's the important thing. It is a subtype only. Okay, yaad rakhna. Next is this. Here you are able to see a depression over the external nose. Here you are able to see depression over the external nose, and that is what is called as a saddle nose. Okay, that is what is known as the saddle nose. Answer me the treatment of saddle nose. Rest I'll tell you. Answer me the treatment of saddle nose. Okay, so this is what is a saddle nose, where there is depression over the external nose. And why there is a depression over the external nose? Because the external nose is formed by either the bone or the cartilages. So these bones or the cartilages of the external nose have been damaged. Okay, so what is the cause? So the most common cause of saddle nose is definitely trauma. The most common cause of saddle nose is definitely trauma. But it can also be due to some granulomatous infections or some granulomatous conditions which can cause damage of the cartilages or the bones. And these granulomatous conditions are nothing else but leprosy or syphilis. These granulomatous conditions are nothing else but leprosy, lupus, syphilis. Okay, all of this. Very good, all of you. Okay, so very good. It is a case of rhinoplasty. Now, as there is deformity on the nose now, therefore we will try to correct the deformity or correct the nose. And correction, as I've told you, correction is what is called as repair. Correction is known as plasty of what? Nose. So rhinoplasty is repair of the nose or reconstruction of the nose. And now here we need something to elevate the nose. Therefore, this is called as an augmentation rhinoplasty. And like what do we need? Usually it is the iliac crest which is used as the graft. Okay, so the iliac crest is used as the graft. Okay, so iliac crest is used as a graft for this augmentation rhinoplasty. Very good, all of you. Chalo. Now next is this condition. What is this? Make a spot diagnosis. Chalo. I want, because this is a sarkari question of your exam, what is the spot diagnosis in this condition? This is a common appearance which is usually seen on the face of the patient, mainly on the skin of the face. It can be seen usually at this side. What is this? The medial canthus of the eye. Or it can be seen on the lateral wall of the nose, externally, on the external nose. Very good. It is a case of BCC, basal cell carcinoma. Very good. It is a case of basal cell carcinoma, which is the most common malignancy or most common cancer of the skin of face usually. Okay, of face. Okay, so that's the important thing. So usually it is basal cell carcinoma, also known as the rodent ulcer. We have discussed this. Which kind of edges? Let me know. Surgery mein bataya tha maine. Which kind of edges it has? So here you can see there is an ulcerative or a necrotic base. Either there will be ulceration at the base or there will be necrosis at the base. But which kind of edges will help us to diagnose a BCC? Which kind of edges should be there? It should be, chalo, मैं options दे रहा हूँ. Either it should be sloping edges, or it should be punched out edges, or it should be rolled out edges, or it should be undermined edges. Okay, which kind of edges will help us? Very good, Jitendra. It will never metastasize. There are very rare chances of metastasis. So two cancers in the body which cannot metastasize to different sides. First is the basal cell carcinoma. Second is the brain tumors known as gliomas. These are the two important ones which never metastasize. Very good. So here you will be able to see these kind of rolled out margins. बाहर की तरफ होंगी, ऐसी होगी margins. ठीक है? So you will be able to see rolled out edges or rolled out margins. Why I'm stressing on this point? Because in question they mention this, and this can be your keyword. Rolled out edges, as they mention. So you need to think in terms of BCC. That's important. Okay. Now important is, as I've told you, there will be no chances of distant metastasis in this condition. And if I talk about the treatment will be a wide local excision. Yes. Okay. Treatment will only be a wide local excision, or sometimes the one that we do for biopsy is also enough. Okay. So now that means excisional biopsy is also used for diagnosis as well as also used for treatment of this patient. What is excisional biopsy? Remove all the thing. Okay, don't take a small part of this ulcer. Okay, remove all the ulcer together. That is what is called as excisional biopsy. So excisional biopsy can be diagnostic as well as therapeutic as well. Next, what is this condition? You are able to see that this is the anterior rhinoscopic examination which has been performed in this patient, and on that you are able to see these yellow color stones. Okay, so if there are stones present in the nasal cavity, this is a case of rhinolith. Okay, this is a case of rhinolith. And usually the rhinoliths which are formed, or the nasal stones which are formed, they are mainly made up of calcium carbonate crystals. They can be made up of calcium phosphate, magnesium carbonate, magnesium phosphate as well. But more commonly they are calcium carbonate crystals. How is the patient going to present to you? Definitely the patient will have nasal blockage. Along with that the patient will have, इसका ट्रीटमेंट बता देना मुझे, ठीक है? The patient will have nasal blockage. The patient will have a lot of foul smell coming from him. There can be a nasal discharge as well. Okay, so these will be the problems. Or the patient will have decreased sense of smell, and decreased sense of smell is called as hyposmia. The patient can also have hyposmia as well. Okay, very good. Epistaxis can also be very common if it has a sharp edge. Treatment is very good. Endoscopic removal. So treatment for a rhinolith is definitely a endoscopic removal. Merciful anosmia is not a feature over here. Okay, merciful anosmia is usually a feature seen in cases of atrophic rhinitis that we'll discuss. Okay, that's important. Next is this. What is seen? You are able to see these small organisms, cute organisms, usually in the nasal cavity of the patient. Usually it is a homeless person who is coming to you with poor hygiene. Okay, so these are the usual patients coming to you. This is a case of nasal myiasis. And what is myiasis? Okay, so nasal myiasis is nothing but presence of maggots. And what are maggots? Maggots are nothing but larvae or the immature forms of housefly. Okay, so maggots are nothing but immature forms of housefly or larvae of the Cryosomia species. Okay, so this is what is called as nasal myiasis. It is due to poor hygiene in the patient. What is the treatment now? Here also the patient will have a lot of foul smell. 10 कोस दूर तुम्हें गंदी बदबू आएगी इस patient की, ठीक है? So that you will not even go close to this patient. Treatment is usually what? There will be foul smell coming from this patient. There will be hyposmia, there will be anosmia, there will be nasal blockage, all of these features. But what will be the treatment? We will instill what? We are going to instill what? We are going to instill maggot oil. What does that maggot oil contain? We are going to instill maggot oil. Okay, so definitely maggot oil. But maggot oil contains chloroform. Nowadays chloroform is not at all available most of the places pe. Therefore if they give you one thing, okay, chloroform is not there, definitely it should be turpentine oil. Okay, if maggot oil is not there in option, you need to mark single best as turpentine oil. You need to mark single best as turpentine oil, because nowadays we mainly use turpentine oil only, because chloroform is not available everywhere. That's the problem. Okay, so important is that. Yes, mosquito nets should be used to prevent further exposure. Okay, so that's the important thing. So please remember, the basic or the definitive treatment is turpentine or maggot oil instillation. These maggots will suffocate inside and then they will run out of the nasal cavity then. Okay. Next, if I talk about trauma to the nose now, nasal trauma. If I talk about nasal trauma, facial trauma as a whole, which is the most common fractured facial bone? The most common fractured facial bone is what? The most common fractured facial bone is which one? The most commonly fractured facial bone. The most commonly fractured facial bone. So please remember, the most commonly fractured facial bone is what is your nasal bone itself. Okay, it is your nasal bone because it is most prominent now. Therefore, the most commonly fractured nasal bone, most commonly fractured facial bone is definitely the nasal bone. So it is a case of nasal bone fracture. And if I talk about nasal bone fracture, definitely what can be the most common cause? So no need to tell, definitely the most common cause will be trauma, usually a fall. Okay, the most common cause will be trauma. And definitely if there is a fracture, definitely there will be a lot of swelling, there will be a lot of edema as well at the site. Okay, so what is the treatment? Investigation will be x-ray only. On the x-ray you can clearly see there is a fracture line in the nasal bone over here. Okay, so what will be the treatment? Treatment should be an immediate reduction, immediate close reduction should be done. And for close reduction, which type of forceps are used usually? So for immediate close reduction of the fracture, we generally use these forceps, the straight forceps, and these are called as the Walsham forceps. Okay, so immediate close reduction should be done in a case of nasal bone fracture, and that is done with the help of these Walsham forceps usually. But okay, why immediate should be done? Before the edema should start. If edema is there, then it will become a lot difficult. It will become difficult to reduce this fracture then. Okay, if they say that immediate close reduction was not possible, or the patient has presented to you late and now there is edema usually. Now there's a lot of edema in a case of nasal bone fracture. What should be done in this condition? Let me know that. If they say that the patient has presented to you late with a nasal bone fracture, there's a lot of edema, there's a lot of swelling, then what should be done? Will you still go for immediate close reduction or you will wait for some time? Very good. So definitely if there is edema, wait for 7 days at least, 7 to 10 days maximum. So wait for 7 days and let the edema subside usually, and then definitely go for reduction, and then definitely go for a close reduction. Okay? So that should be done. That is important to be remembered. Next is the nasal septum fracture. Next is important is the nasal septum fracture. So now nasal septum is this medial wall of the nose now. This medial wall of the nose is what is called as the nasal septum. Okay, तो अगर उसके fracture की बात करते हैं, nasal septum fracture can be of two types. If there is a force from front, there is a horizontal fracture, and this horizontal fracture which is there is known as the Jarjavi fracture. Okay, so if there is a force from front, the horizontal fracture is known as the Jarjavi fracture. Whereas if there is a force from below, there is a vertical fracture. Okay, if there is a force from below, there is a vertical fracture. Like in boxing, there is a force from below that causes a vertical fracture, and that is known as the chevalate fracture. That is what is known as the chevalate fracture. Important, the treatment for both of them is same. The treatment for both of them is same. Trauma is the cause. Definitely we are talking about nasal trauma. So treatment is definitely here also we will go for a close reduction. But here the close reduction which is done now, it is not done with the straight Worsham forceps. Here it is done with this angulated forceps. So A for angulated, A for ash. Okay, if you get confused, so please remember A for angulated, A for ash. So usually here the close reduction is done with the help of these ash septum forceps. Okay, the angulated forceps. Okay, so that is important. Then if they ask you what is this condition, which is the second most commonly fractured facial bone, which is the second most commonly fractured facial bone, and they give you this image, what is your answer? Which is the second most commonly fractured facial bone? Which is the second most commonly fractured facial bone? Let me know that. Which is the second most commonly fractured facial bone? So please remember it is the zygomatic bone. Okay, it is the zygomatic bone because it is prominent again. It forms this malar prominence as well, malar eminence. That's the reason why it is the second most commonly fractured bone. And the zygoma bone, okay, this zygomatic bone has three pods. It has this one spine which connects with the temporal bone, the other which connects with the frontal bone, and the third one which connects with the maxillary bone. So these three bony pods are there. Therefore, if the zygoma bone gets fractured, it is also known as a tripod fracture. It is also known as a tripod fracture. Here definitely the patient will have what? Here definitely the patient will have loss of this infraorbital margin, because the zygomatic bone forms this infraorbital margin. There will be loss of infraorbital margin. There will be flattening of this malar eminence. ये जो malar eminence दिख रहा है ना, this will not be seen. There will be flattening of malar eminence. Then here we have a hole. What is that foramen called as? Infraorbital foramen. And what arises? Which nerve arises from the infraorbital foramen? It is the infraorbital nerve. So therefore, in this condition, the patient will also have infraorbital nerve injury. And if there is infraorbital nerve injury, this infraorbital nerve gives sensory innervation, or it carries sensation from the cheek. Therefore, if the infraorbital nerve will be injured, there will be loss of sensation from the cheek. That will cause anesthesia of cheek as well. Okay, so the patient will have anesthesia of cheek. There will be anesthesia of cheek as well over here. So this infraorbital nerve injury is not only seen in cases of zygomatic or tripod fracture, but it can also be seen in cases of maxillary bone fracture, as well as it can also be seen in cases of maxillary sinus carcinoma. So three conditions where you will find cheek anesthesia are these. Okay, so maxillary sinus cancer, maxillary fracture, and zygomatic fracture. So that's the important thing you need to remember. Treatment over here is ORIF. Okay, treatment over here is open reduction and internal fixation. ORIF should be done. Okay. Next important, talking about the internal part of the nose. If I talk about the internal part of the nose, I have spoken about the external nose. Now let's go inside the nose. If I go inside the nose, usually on the lateral wall of the nose, these are my lateral walls of the nose. On the lateral wall of the nose from inside, I'll be able to see three bony projections. And these three bony projections which are there now, these are usually called as concha. The three bony projections are called as concha. Okay, it is the superior concha, the middle concha, and the inferior concha. Okay, superior, middle and the inferior concha. Okay, so important is the superior and the middle concha, they are a part of this bone. And what is this bone over here? It is the ethmoid bone. So please remember, the superior and the middle concha are a part of ethmoid bone, but the inferior concha is a separate bone or an independent bone. The inferior concha is a separate or an independent bone. Okay, it is a different bone. Then when these concha, they will be covered with mucosa. When these concha, they are covered with mucosa, Now, as you can see in the image, they are called as turbinates. Okay, when this concha is covered with mucosa, these will be called as turbinates now. Okay, and the space beneath the turbinates, the space which is there beneath the turbinates, this is what is called as a meatus. Okay, so the space below this turbinates, the space below this turbinates is what is known as the meatus. So again, there will be three turbinates. There will be the superior turbinate, middle turbinate, and the inferior turbinate, and therefore by default there will be three meatuses. There will be a superior meatus, middle meatus, and the inferior meatus. So you will say, so this space which is there, this space which is there above the superior meatus, the space which lies above the superior meatus, this is also called as a meatus itself. And what is this meatus called as? So the space which lies above the superior meatus, superior turbinate, is what is called as sphenoethmoidal recess. Okay, so please remember, the space which lies above the superior turbinate is called as sphenoethmoidal recess, or sometimes it is also referred to as the supreme meatus, or sometimes it can also be referred to as the supreme meatus. Okay, so as you can see, why it is called as sphenoethmoidal recess? Because it is present in between two bones, the sphenoid bone and the ethmoid bone over here. Okay, therefore it is known as sphenoethmoidal recess. Okay, sure. Now talking about drainage of sinuses. Yes, so usually the paranasal sinuses which are there, no, these paranasal sinuses, the maxillary sinus, the frontal sinus, the ethmoid sinus, and behind this the sphenoid sinus. All of these sinuses usually drain into the nose. And which part of the nose? So they drain into the meatuses itself. Okay, so let's discuss now. So first of all, the longest meatus which is there, the longest meatus is the inferior meatus. Please remember one thing, the longest meatus is the inferior meatus. And which structure drains into the inferior meatus? Start answering for the next also, B, C, D. Okay, so for this I am telling you, for the others please answer in the chat box. The inferior meatus is the longest meatus, and what drains into the inferior meatus? Please remember, it is the nasolacrimal duct. I hope all of you are quite aware. Usually we have the lacrimal apparatus. You might have studied it in ophtha as well, right? This time also there was a question, so let me tell you that. Please remember, on the lateral canthus or on the lateral wall of the orbit, we have the lacrimal gland. Okay, so this lacrimal gland produces tears. These tears will pass via your eye, and then they are usually going into the canaliculi. If you evert your eyelids on or these eyelids, you will be able to see small holes or punctums. Why these punctums? These tears will go into the upper canaliculi and the lower canaliculi, and then they will go into the lacrimal sac over here. And the question was, which structure of the lacrimal apparatus is present in the medial wall of the orbit? So please remember, this is the medial wall of the orbit, and we have the lacrimal sac, not the lacrimal gland. Gland is present in the lateral wall and sac is present in the medial wall. So it is the lacrimal sac which is present over here. It continues into the nasolacrimal duct, and that nasolacrimal duct finally opens up into the nose. And which part of the nose? It is the inferior meatus of the nose. Important is the direction has been asked for nasolacrimal duct. It is downwards, outwards, and backwards. Okay, the direction has been asked. It is DOB, date of birth is the mnemonic. So it is downwards, outwards, and backwards. Outwards can also be written as laterally. Whereas the valve which is there was also a question on valve. So the valve which is there at the nasolacrimal duct, it is known as valve of Hasner. So these are two important one-liners. Okay, very good. So in the middle meatus, this is the largest meatus because most of the sinuses or paranasal sinuses will open up into the middle meatus itself. And which part of the middle meatus exactly? So they mostly open up into the ethmoidal infundibulum. Okay, they mainly open up into the ethmoidal infundibulum. So they open up into the ethmoidal infundibulum. And what are these three important sinuses? One is definitely the frontal sinus. The next is what is called as the ethmoidal. Okay, so first is the frontal sinus. Second is the maxillary sinus. Okay, so first is the ethmoidal sinus. Second is the maxillary sinus. And the third one are the anterior ethmoidal air cells. Yes, the ethmoidal air cells which are there now, they are divided into anterior ethmoidal air cells and posterior ethmoidal air cells. Therefore, the anterior ethmoidal air cells will drain into the middle meatus. Whereas if I talk about the superior meatus, now anterior are draining into middle, therefore the posterior will drain into the superior meatus. Okay, so the posterior ethmoidal air cells which are there. What are air cells? Small sinuses are called as air cells. That's it. Okay, so posterior ethmoidal air cells will drain into the superior meatus. And finally, what will drain into the supreme meatus? Supreme meatus is another name used for sphenoethmoidal recess as well. So what will drain? By the name itself, you can remember it is the sphenoid sinus. So the sphenoid sinus finally opens up into the supreme meatus or the sphenoethmoidal recess. That's the important thing you need to remember. Okay? Sure. Now if I talk about some ectopic ethmoidal air cells, normally, first of all, normal ones. So if I talk about the anterior ethmoidal air cells, normally these anterior ethmoidal air cells can vary in number. They are minimum 2 to maximum 8 they can be there. Okay, so if they ask you which is the most constant and the largest anterior ethmoidal air cell, which is the most constant and the largest anterior ethmoidal air cell, these are previous year questions, so I'm asking you. And second question is, which is the anterior most anterior ethmoidal air cell, which is the anterior most anterior ethmoidal air cell. फट से आंसर करो दोनों. Which is the most constant and the largest anterior ethmoidal air cell? The most constant and the largest anterior ethmoidal air cell will be, please answer both these questions. Very good. So please remember, yes, very good. Yeah, yes. Okay, so please remember the most constant and the largest anterior ethmoidal air cell which is there, it is called as bulla ethmoidalis. Okay, the most constant and the largest anterior ethmoidal air cell is known as bulla ethmoidalis. That's important. And the anterior most, that is सबसे आगे कौन होगा? Agar nasal. Okay, so please remember the anterior most is what is called as agar nasal. It is सबसे आगे, so it is known as agar nasal. If I talk about the ectopic ethmoidal air cells on which questions have been asked commonly, so the ectopic ethmoidal air cells, the most common ectopic ethmoidal air cell is known as concha bullosa. And please tell me, concha bullosa is the ectopic ethmoidal air cell which is present where exactly? Okay, so most common ectopic ethmoidal air cell is known as concha bullosa, and where is it present? Let me know that. The other ones are called as Haller cell. This Haller cell is usually present in the orbital floor. Okay, the Haller cell which is there, it is present in the orbital floor. And the third one is known as Onodi cell. Third one is known as the Onodi cell. Okay, and where is this Onodi cell present? So this Onodi cell is present along the optic nerve. This Onodi cell is present along the optic nerve. Okay, that's important. So please tell me, where is this concha bullosa present? This concha bullosa, please remember, it is an ectopic ethmoidal air cell which is present inside the middle turbinate. This is a ectopic ethmoidal air cell which is present inside the middle turbinate. Okay, so that's important. Very good, very good. Okay, chalo. So all of these are the important things to be remembered about your ectopic ethmoidal air cells. Okay. Now next question is, this was a previous year question again. Here we have a question which states a neonate was born preterm. Okay, the neonate was born preterm, that is usually less than 37 weeks of gestation, or sometimes even less than 34 weeks. That is a premature preterm. He appears cyanotic at birth. What is cyanotic? He appears blue at birth. Okay, so it appears blue or cyanotic at birth. And why there is cyanosis? Because there is decreased oxygen in his blood. Why there is decreased oxygen in his blood? Because the exchange of oxygen is not proper. Therefore, he is cyanotic at birth, and then he turns pink. He turns pink as soon as he starts crying. He turns pink as soon as he starts crying. What is the next line of management? First of all, what is your provisional diagnosis in this condition? Okay, what is your provisional diagnosis in this condition? What is your provisional diagnosis in this condition? So please remember, I hope all of you are quite aware. This is your nasal cavity and this is your nasopharynx. Okay, the posterior end of the nasal cavity or the posterior opening of the nasal cavity is what is called as choana. The posterior end of the nasal cavity is what is called as choana in the patient. Okay, it is what is called as choana. Okay, so usually you can see this opening is formed usually. Okay, this opening is formed, and therefore the air can go from the nose to the nasopharynx and finally to the trachea and to the airway. But in case if this is not formed, if this choanal atresia is not formed, okay, the choana is not formed. Why? Because before birth there is a bucconasal septum which is present over here, which separates the nasal cavity and the oral cavity. This bucconasal septum which is there now, it separates the oral cavity and the nasal cavity. This bucconasal septum usually disappears or it obliterates at birth, and then a choana is formed. But if this bucconasal septum does not disappear, it stays over there. So क्या हो जाएगा? As you can see in this image, you can see that the choana, both the choana are not formed. There is a bilateral choanal atresia in this patient. That's the reason why air could not go from his nose to his trachea, and therefore the exchange could not occur. You will say, sir, इस बच्चे को इतना नहीं समझता क्या कि मुंह खोल के सांस ले ले? Okay, the child does not understand what that he can open his mouth and breathe. So important is, tell me why. What is the reason behind this? Okay, why the child is not able to open his mouth and breathe? Let me know that. Okay, so this, all of you are right. This is a case of bilateral choanal atresia. Okay, atresia is absence, and what is absent? The choana is absent actually. The choana is not formed. And why the choana is not formed? Because the bucconasal septum which was there, it is persisting. Okay, there is persistence of the bucconasal septum over here. Persistence of the bucconasal septum is there. Okay, So definitely it is a classical case of bilateral choanal atresia. What is the reason for that? So please remember, this was also a previous year question. Neonates are obligate nasal breathers. Neonates are obligate nasal breathers. That was the previous year question. That means they can breathe by mouth, but problem is they are not able to understand. They don't have that capacity to understand that they can open their mouth and breathe. Okay, that's the problem. So please remember, neonates are considered as obligate nasal breathers because they are not having that capacity to understand that if they are having respiratory distress, they could open their mouth and breathe. That's the reason. This was a previous year answer. Very good, very good. Okay, so that's the important thing. So usually what happens, as the child is having respiratory distress, he is cyanotic at birth. That means he's having severe respiratory distress. Therefore, the child opens mouth for crying. He is not opening the mouth for breathing. He's opening the mouth for crying. But as soon as he starts crying, the mouth opens. Some air goes into his airway, and therefore the exchange occurs, and therefore the child turns pink again because now the oxygen is present in his blood. Okay? So that's the important thing usually that you need to remember. If they ask you what is the first line management in this condition, so definitely they have asked what is the next line of management, the first line of management. The one which is shown over here. What is shown? You can see a wide bore nipple is inserted into his mouth. Why? Because if you insert this wide bore nipple in his mouth, his oral cavity will always be open and therefore he can breathe freely. And that is what is called as the McGovern's technique. This is what is known as the McGovern's technique. Okay. But if you do not have this wide bore nipple, or this McGovern's technique is not an option. The another option which was given to you in the previous year FMG examination was this one. What is this? Insert a Goodell's airway. Goodell's is nothing but a oropharyngeal airway. Okay? So definitely to keep the mouth open, you can also insert a oropharyngeal airway. So insert a oropharyngeal or a Goodell's airway in the child's mouth if you do not have that wide bore nipple for a McGovern's technique. Okay? So that should be remembered. Chalo. If they ask you definitive management, definitely definitive management is resection of the bucconasal septum. Definitive management is surgical resection of that bucconasal septum, because until and unless that bucconasal septum goes, the child will not improve. Okay? So that's the important thing. Chalo. Now here we have these 4 paranasal sinuses. One is called as the frontal sinus. You can see it is an irregular sinus. The shape and the size of frontal sinus is not fixed. The most irregular sinus. Next you can see is the maxillary sinus, which is the largest sinus out of all. The volume of maxillary sinus is around 15 ml and it is also called as antrum of Highmore. Okay? The next one is the ethmoid sinus. You can see it is present in between the orbits. This is your ethmoid sinus, the small sinuses. Therefore ethmoid sinuses, as I've told you, they can also be called as air cells because they are very small in size. And behind the ethmoid sinus or behind the orbit, in the body of sphenoid bone, we have this sphenoid sinus as well. These are the 4 paranasal sinuses. What are sinuses? Sinuses are nothing but hollow cavities inside a bone. What is the role for that? First important, they will make the bone lighter. Okay, they will make the bone lightweight, and along with that, when the sound goes into these sinuses, you will get that resonance of your sound. Jo resonance aata hai na, that is due to the sinuses only. Okay? So that's the important thing. Now if I talk about this condition, what is this condition over here? Here we have a patient who comes to us with nasal congestion. What is nasal congestion? Nothing but blockage or obstruction. ठीक है? तो जब नाक भर जाती है, ठीक है? That is what is nasal congestion. A patient comes to you with nasal congestion, rhinorrhea. What is rhinorrhea again? Nothing but nasal discharge. Something coming out of the nose, leaking out of the nose. That is rhinorrhea. ठीक है? So a patient comes with nasal congestion, rhinorrhea, a post-nasal drip. What is a post-nasal drip? The nasal discharge is there, but that is going inside the throat of the patient. That is not coming out from the nose. Throat में तुम्हें discharge मिल रहा है. And the patient is having headache. What is the best investigation? What are you suspecting? So nasal congestion, rhinorrhea, post-nasal drip and headache. What is your likely diagnosis in this condition? क्या सोच रहे हो? क्या हो सकता है patient में तुम्हारे? What is your likely diagnosis? What is your likely diagnosis, guys? Very good. It is a case of sinusitis. Very good. And we know now these sinuses which are there now, these sinuses, they are hollow cavities, but they are lined by mucosa. And wherever there is mucosa, there will be mucus secretions as well. So now these mucus secretions which are there, they should be drained. And where are the sinuses drained? All of you are quite aware. We have discussed it right now. They drain into the nose. Which part of the nose? In the myiasis. But if the sinuses, the opening of the sinuses gets blocked at the level of myiasis, if the opening of the sinus gets blocked at the level of the myiasis, definitely, what will happen? The secretions of the sinuses will not be able to drain. Therefore, all the secretion will remain in the sinus. And if this fluid keeps on collecting, पानी भी अगर जमा रखो तो वो भी गंदा हो जाता है. In the same manner, if the secretion is usually not flowing, okay, if there is stasis of the secretion, that will increase the risk of infections usually, and that causes sinusitis in the patient. Okay, so blockage of myitis is usually an important risk factor for sinusitis in a patient. It is infection of the sinuses. Okay, sure. Now usual these are the symptoms, and important is it can be any sinusitis because we are not sure which kind of headache is it. Okay, depending on the headache, definitely if a patient is having cheek pain, if we can suspect there is maxillary sinusitis. If the patient is having pain in between the orbits, we can suspect it can be a ethmoidal sinusitis. If the patient is having a retroorbital pain, we can suspect it can be sphenoidal sinusitis. Or if the patient is having this that is vertex or occipital headache, we can suspect it is a case of sphenoid sinusitis. Or if the patient is having a frontal headache, usually in the office hours, that is called as a periodic or office headache, that is a case of frontal sinusitis. Okay? So depending on headache, you can definitely make a diagnosis as well. Now, it is a case of sinusitis. We know most common cause is streptococcus pneumonia again. What is the best investigation for this? Let me know that. What is the best investigation? So till that time, I'll talk about the first line investigation. And this is a Sarkari question of your exam. The first line investigation is definitely a X-ray paranasal sinuses. The first line investigation is definitely a X-ray paranasal sinuses. On X-ray paranasal sinuses, we have various views. The first view that is seen over here. What is seen in the first view? Definitely, you can see the sphenoids. You can see the sphenoid sinus. You are able to see the ethmoid sinus. You are able to see the maxillary sinus. You are able to see the frontal sinus. So all sinuses are visible on this view. And what is this view? This view of X-ray is called as the X-ray skull lateral view. This view of X-ray is known as the X-ray skull lateral view. So definitely X-ray skull lateral view is the one where all sinuses are visible definitely. Okay? And it is the best view for which sinus? So this one is the best view for the sphenoid sinus. You can see the sphenoid sinus very clearly. So this is the best view for the sphenoid sinus. That's the important thing to be remembered. Next one is this one. You can see as the patient is looking upwards as if he is drinking water. Okay? ऐसे याद रख लो. So this is what is called as your water's view. Okay? So if you see that the X-ray में लगता है कि the patient is looking upwards, definitely this is called as a water's view. Water's view can be of two types. Either it can be a closed mouth water's view, okay, and this one which is given in the image is an open mouth water's view. Why open mouth water's view is performed? To see this extra sinus. What is this sinus over here? This is the sphenoid sinus. To see this extra sphenoid sinus, we are performing an open mouth water's view. And this open mouth water's view has a specific name. It is also known as a Pierce view. So open mouth water's view is also known as the Pierce view. Okay, so that's the important thing. Open mouth waters is also known as Pierce view. Okay, so that's the important thing. And we know water's view can also be called as occipito-mental view. Water's view can also be called as occipito-mental view. That's the important thing. And open mouth water's view is definitely called as Pierce view. Okay, so that's the important thing. Okay. According to Rajiv sir, also I confirm it. Please remember, first line is always you will send the patient if you do not have a nasal endoscopy available. Endoscopy is not available in every center, no? Tertiary care centers mein it is available usually. Endoscopy is not so easily available. It can be available at a ENT clinic, but not available at every place, no? So that's the reason. Diagnostic nasal endoscopy is definitely the best one, but it is not the first line always. Okay, so first line easily available is the X-ray. So you can usually get an X-ray done. Even at tertiary care centers in our hospitals also, we do not have this endoscopy. That's the problem. Okay? So that's usually, you need to remember that. Okay? No issues with this, anybody? So usually you can see, now frontal, if they say water's view is the best view for which sinus? So please remember the water's view is the best view for, you can see this sinus is clearly visible. So water's view is the best view for maxillary sinus. Water's view is best view for maxillary sinus. Okay? Water's view is best view for maxillary sinus. Next is this one. What is this? You can see this is called as a Caldwell's view. This is what is known as a Caldwell's view, also known as occipito-frontal view. It is also known as the occipito-frontal view. Here it seems as if the patient is looking in front. Usually he is having a deviation or he is looking downwards at 15 to 20 degrees. But on an X-ray it seems that if the patient is looking downwards usually. Okay? And this is what is the Caldwell's view. And we know Caldwell's view is the best view for frontal and the ethmoid sinus. Caldwell's view is the best view for the frontal and the ethmoid sinus. Please remember that. Okay? So for frontal and ethmoid sinus, the best view is the Caldwell's view. No issues today, anybody? So best investigation, as all of you have answered, it is diagnostic nasal endoscopy. Okay, it is definitely a diagnostic nasal endoscopy which is done. Okay, and on nasal endoscopy, definitely we will use the same flexible laryngoscope as well. Okay, on that nasal endoscopy, if you go through the meatuses, you will see that the meatuses are full of pus. They are blocked, and that is what is diagnostic of sinusitis. Definitely, if they ask you what is the best radiological investigation, now X-ray could not be the best one, because on X-ray definitely expertise is needed. So the best radiological investigation to make a diagnosis of sinusitis is definitely a CT paranasal sinuses. It is definitely a CT of paranasal sinuses. Okay? Now on CT, whether it is a CT scan as you can see over here, or it is a X-ray, please tell me what is seen. How are you going to make a diagnosis of sinusitis in the patient? I have told you on endoscopy, though, you will see pus and blockage of meatuses. That will make your diagnosis. Okay. But on a CT scan or on a X-ray, what will make your diagnosis of sinusitis in the patient? Here, definitely the patient is having maxillary sinusitis. But why? So please remember, what you can see in the lower part of the sinus, there is fluid or the pus which has been collected, and in the upper part of the sinus you can see air. So that is what is seen. That is, air fluid levels are generally seen. Okay, so that is what is to be seen. Air fluid levels are usually seen on an X-ray or a CT paranasal sinuses to make a diagnosis of sinusitis in the patient. That's important. Chalo. Okay, so that is important. Now, if I talk about what is the treatment of sinusitis, so please remember, if I talk about what is the treatment of sinusitis. Okay, so usually the treatment of sinusitis, as I told you, it is usually a bacterial infection. Definitely for that reason, we should give antibiotics to the patient, and antibiotics are generally continued for a span of 3 weeks. Antibiotics are continued for a span of at least 3 weeks. Along with antibiotics, definitely we might need to give nasal decongestant, but nasal decongestants are not given for a longer time because they will cause a rebound congestion that we will discuss later. Okay, that we will discuss later definitely. So that's the reason why you can either give nasal decongestants like 1 week, take a gap, 1 week, take a gap, like that, or you can give steroid nasal spray. Okay, so that can be given usually. So that's the important thing. And if the patient does not respond, okay, if the patient does not respond even after 3 weeks of antibiotic therapy, then you can go for a surgical management, and that is called as FES. What is FES? Functional endoscopic sinus surgery. FES is nothing but functional endoscopic sinus surgery. Problem with FES is what? You are scraping out all of the sinus mucosa. As you are scraping out all of the mucosa of the sinuses, what will happen? Definitely there will be adhesions, right? There will be adhesions which will be formed within the sinuses. And if these adhesions are formed usually within the sinuses, what is the problem? It is usually due to the fibroblastic action. What should have been done for prevention? That was the question. If synechiae are formed after FES surgery, if synechiae or adhesion are formed after surgery, what is done for prevention? What should have been done for prevention? That was a previous year question. We should have applied some drug. What is the drug which we topically apply after a FES surgery? What is your answer for that? Okay, what is your answer for that? And also answer these two questions over here. All sinuses are visible on which view of X-ray? All sinuses are visible on which view of X-ray? All sinuses are visible on which view of X-ray? Please let me know that once. Both the question. Synechiae prevent करने के लिए which drug that we use? Which is the drug that we use for synechiae? Very good, Saichand. It is mitomycin C. Okay, so definitely it is mitomycin C, which has an anti-fibroblastic action. So mitomycin C will help you preventing synechiae. This was a previous year question, you need to remember. Okay, so that's the important one. Very good. Yes, Saurabh. So important is all sinuses are visible on which view of X-ray? That is my next question. Answer it. And also answer best view for all sinuses. Best view for all sinuses. No, all sinuses are not visible on a, please remember, Waters view. Yaad rakhna, very good Saurabh, it is the X-ray skull lateral view. All sinuses are visible only on X-ray skull lateral view. Abhi to bataya maine. On X-ray skull lateral view, definitely you saw all the sinuses which were visible, right? So X-ray skull lateral view is the one where all the sinuses are visible. Definitely if they ask you best view for all sinuses, definitely it is the Waters view. Why? But I did not answer Waters view as the first answer. Because on Waters view, which is not at all visible, the posterior ethmoidal air cells are never visible. The posterior ethmoidal air cells are never visible on a Waters view. Whether it is an open mouth or a closed mouth Waters view, posterior ethmoidal air cells are never visible on a Waters view. That's the important thing. Okay, so please remember that. Okay, so yaad rakhna ye baat. So this is also important to be remembered. Now next, if I talk about complications of sinusitis, guys, That was complication of fess surgery, synechial formation. But if I talk about complications of sinusitis, one complication can be there will be pain, there will be redness, there will be swelling all around the eyes. That is periorbital redness, swelling, and pain. This is what is called as orbital cellulitis or periorbital cellulitis. This condition is what is, or this complication is what is known as orbital cellulitis. Now you will be answering orbital cellulitis is associated with which sinusitis? Orbital cellulitis can be a complication of which sinusitis? That I need an answer for. The next one is over here. Definitely this is a classic one. You can see that beneath the frontal bone or beneath the periosteum or the covering of the frontal bone, you are able to see pus collection. Okay, this is what is called as a subperiosteal abscess in the frontal bone or in the frontal sinus. So the subperiosteal abscess which is there in the frontal sinus, subperiosteal abscess in the frontal sinus, along with there is damage to the frontal bone also, and infection of the frontal bone or any bone is called as osteomyelitis. So subperiosteal abscess in frontal sinus along with osteomyelitis of frontal bone, this is what is called as a complication known as Potts-Puffy tumor. This is also a Sarkari question. This is known as the Potts-Puffy tumor, which is a common complication associated with frontal sinusitis. That I've told you already. Okay? So it is subperiosteal abscess along with osteomyelitis of frontal bone. So very good, it is ethmoidal sinusitis. Very good. Orbital cellulitis is a common complication associated with ethmoidal sinusitis. Now one last complication, please tell me that this time there was a question on mucocele. So mucocele is a complication of which sinusitis, and second is aspergilloma is a complication of which sinusitis. I hope all of you are quite aware that most common cause of fungal sinusitis is Aspergillus fumigatus. And therefore, if the fungal hyphae combine together, they can form a ball as well. And that ball is called as aspergilloma usually. Okay? That aspergilloma is commonly seen as a complication of which sinusitis, and mucocele is a complication of which sinusitis. Please tell me that. First say. So please remember, mucocele is a complication associated with frontal sinusitis. Okay, mucocele is a complication associated with frontal sinusitis, and definitely aspergilloma is a complication associated with maxillary sinusitis. Very good. Okay, aspergilloma is a common complication associated with maxillary sinusitis. That's the important thing. Okay, so usually that you need to remember. Most common sinusitis in adults, I hope all of you are quite aware, it is maxillary sinusitis. Most common sinusitis in children, it is ethmoidal sinusitis. Okay, so that's the important thing. Now, please tell me the sequence of development of sinuses. That I'll tell you. Sequence of development of paranasal sinuses, it is MESF. That is, the first sinus to develop is the maxillary sinus, the first sinus to begin the development. Then it is the ethmoid sinus, then the sphenoid sinus, and then the frontal sinus. Maxillary and ethmoid are even present at birth. The two sinuses which are present at birth are the maxillary and ethmoid sinus. My one question is, which is the most developed sinus at birth? Which is the most developed sinus at birth? What is your answer? Which is the most developed sinus at birth? Answer this question. Which is the most developed sinus at birth? Okay. Next, I'll be talking about the tumors of the paranasal sinuses. We know that the most common benign tumor of sinuses, if I talk about, okay, if I talk about the most common benign tumor of sinuses, it is a osteoma. Okay, the most common benign tumor of sinuses is definitely osteoma. Osteoma is nothing but a benign tumor arising from the bone. Okay, so it is osteoma. And osteomas, I hope all of you are quite aware that usually osteomas are present in the frontal sinus. The most common site for the osteomas are usually the frontal sinus. Okay, so the most common benign tumor of paranasal sinuses is definitely osteoma, which is more common in the frontal sinus. Please remember, no, it is not the sphenoid, no, it will be ethmoid. Very good. Okay, so it should be ethmoid. The most developed sinus at birth, we have two of them, maxillary and ethmoid, which are present at birth, but the most developed sinus at birth is the ethmoid sinus. Okay, so that you need to remember. Now, if I talk about the malignancy of the sinuses, definitely the malignancy of paranasal sinuses. Which is the most common sinus involved with malignancy? Which is the most common sinus where malignancy can be seen? Which is the most common sinus where malignancy can be seen? That's a question to you. Which is the most common sinus where malignancy can be seen? Which is the most common sinus where malignancy is seen, guys? So M for M, malignancy is common in maxillary sinus. That's important. Okay, maxillary sinus में ज़्यादा common होती है malignancy. Okay, so that's important. Maxillary sinus में we have commonly malignancy. Okay, and how the patient will present to us? The patient can present to us with a cheek swelling. There can be weight loss. The patient can have other nasal obstruction wala features. Apart from that, I told you there will be involvement of the infraorbital nerve causing anesthesia, loss of sensations from the cheek, all of these features. Okay, important is maxillary sinus carcinoma. Okay, maxillary sinus carcinoma is associated with two important risk factors. One is definitely nickel exposure, which causes squamous cell carcinoma of maxillary sinus, and second is definitely the hardwood dust or the furniture dust. Okay, hardwood dust or the furniture dust exposure, which causes adenocarcinoma of the maxillary sinus. It causes adenocarcinoma of the maxillary sinus. Important is now what is done for investigation. We don't go for a biopsy. Usually we go for a CT scan, and on that you can see that this is a cancer. Okay, you can see a mass throughout the maxillary sinus. How to differentiate it from sinusitis? I've told you in sinusitis there will be an air fluid level. Here you have no air fluid level, rather in whole sinus you have a mass. And apart from that, important is you can see that this mass is also eroding, or it is also damaging the floor or the inferior wall of the orbit. So definitely it cannot be a benign tumor which can damage the inferior wall. Now it can only be a cancer or a malignancy which can damage the floor. Okay, so that is what is seen over here. If I talk about this line, okay, this is what is called as this line which extends from the imaginary line which extends from the medial canthus of eye till the jaw of mandible or till the angle of mandible. This is what is called as the Ongren's line. And if I talk about the Ongren's line, what is the role of the Ongren's line? Please tell me that. What is the role of Ongren's line? This divides the maxillary sinus into two halves. If the cancer lies in the lower half, the patient will have better outcome. But if the cancer lies in the upper half, in the suprastructure, the patient will have a poor outcome. So what is the answer? What is the role of Ongren's line? That was a previous year question. Definitely, which has been asked. What is the role of Ongren's line? The image was given and they asked you what is the role or what is the purpose of this line. It is used for prognostic evaluation. Please remember, it is used for prognostic evaluation of maxillary sinus cancer. It is used for prognostic evaluation of maxillary sinus cancer. What is prognosis? Prognosis is nothing but outcome. Okay, so if the cancer lies above the line, definitely there will be early orbital involvement, and if there is early orbital involvement, definitely the outcome or the prognosis of the patient will be poor or bad. So definitely that will help you assess the prognosis or the outcome of the patient in a case of maxillary sinus carcinoma. It helps in prognostic evaluation. Treatment, we know now, treatment is nothing but a total maxillectomy. But that total maxillectomy is usually done via this approach. And what is this approach? Let me know in the chat box. What is this approach known as? The total maxillectomy is done via this approach. You can see the maxilla is removed completely. The upper lip is also removed at times. And if the orbit is involved, we also need to remove the orbit at times. Okay? What is this approach called as? They usually mark it with a pen prior to surgery. They mark it prior to they mark it prior to the OT, usually before cutting that. What is this? Yeah, radiotherapy will be given, but what is this approach? Very good. It is the Weber-Ferguson approach. So important is this is what is known as the Weber-Ferguson approach. Okay? So total maxillectomy with the maxillectomy with the Weber-Ferguson approach, followed by radiotherapy should be given to the patient. Okay? Followed by radiotherapy to prevent any recurrence. Okay? So that has to be done. No issues till anybody. Next one is, I'll not complete notes today. Okay? I'll just talk about some important things, and then I'll continue it tomorrow with ear. Okay? So just bear me for a while. Next is inverted papilloma of nose, guys. Inverted papilloma of nose, there was a question in the recent FMG examination. Inverted papilloma of nose is also known as Ringer's tumor. Please remember, the inverted papilloma of nose is also known as a Ringer's tumor. Definitely, as I've told you earlier, somebody said that usually what is the most common site of origin? So it is here, it is the lateral wall of nose. Please remember, it arises from the lateral wall of the nose. Okay? The most common site of origin for a Ringer's tumor is definitely, or inverted papilloma of nose, is the lateral wall of the nose. And important is, it does not grow into the nasal cavity. Rather, it grows inside the wall. That means it grows from mucosa towards the submucosa. It does not grow outward, it grows inwards. Okay, it grows inwards. This is a tumor which grows inwards definitely. and that's important to be remembered. It grows towards the submucosa. Important is, guys, please let me know whether this is a benign tumor or a malignant tumor, and whether this is an aggressive tumor or a non-aggressive tumor. That is important. Aggressive का मतलब होता है which will grow in size rapidly and which will destroy or invade the other structures in the vicinity. Okay, that is what is meant by aggressive. So whether it is a benign or malignant tumor, that was a question in recent fmge examination. So there were various options: benign but aggressive, benign but non-aggressive, malignant but aggressive, malignant but non-aggressive. These were the various options. So please let me know. So important is, yes, Sai, you are right. It is locally invasive. So definitely it should be aggressive in nature, na? But it is benign. Okay. So usually benign tumors we find they are non-aggressive, but this is a benign tumor and it is aggressive in nature. So benign but aggressive in nature. So this is a benign but aggressive tumor. That has to be remembered. Okay. So this is a benign but aggressive tumor. That has to be remembered. This was a recent FMG question. Okay. Chalo. Moving further, what is the treatment? Treatment is nothing but a surgical excision. Treatment is nothing but a surgical excision should be done. Okay. Chalo. Now here we have a question. Let me know the answer for this question now. Okay. A patient was suffering from sinusitis. Therefore, he was prescribed nasal decongestant drops. Usually your Otrivin, that is xylometazoline, oxymetazoline drops. He was prescribed. He was taking it for a longer time. That is for a span of almost 3 months now. Okay. The doctor did not tell him that you need to stop it in between. So definitely he is taking it for a longer time. And now as he stops taking the drops, definitely he develops rebound congestion. जैसे ही वो drop लेना बंद करता है, वापस से उसका nose block हो जाता है. Okay. As soon as he stops taking the drops, definitely he develops congestion. What is the diagnosis and treatment? What is the diagnosis in this condition? It is not a case of azena. Azena though is a foul smell coming from a patient, merciful anosmia, nasal cavity full of crust. Atrophic rhinitis is what is azena, right? So here, as soon as the patient stops taking the drops, he develops rebound congestion. This is a case of rhinitis medicamentosa. Okay. So in the name only you can find everything. This is a case of rhinitis medicamentosa. That means the patient is having inflammation of the nose definitely, or there is congestion of the nose, and due to what? Due to the medications. Therefore, this is a case known as rhinitis medicamentosa. Treatment, yes, you're right. Definitely you need to stop taking the nasal decongestant. Stop the nasal decongestants of the patient, and along with that start steroid nasal spray as the patient is having congestion now. So for that, to relieve the congestion, to decrease the edema in the nasal cavity, start steroid nasal spray. Okay, so that has to be done. No issues with that, anybody? Important. Next is allergic rhinitis. Now allergic rhinitis, that is, what is rhinitis? First of all, it is का मतलब होता है infection या inflammation. So this patient is having inflammation of what? Rhino means nose. So this patient is having inflammation of your nose. Due to what reason? Due to some allergy. So he's having allergy to some of the particular substances or some allergens. Now this allergic rhinitis which is there, when the patient develops allergic rhinitis, usually whenever he is exposed to the allergen, he'll have multiple episodes of sneezing. छींकता रहेगा, and the patient will have an excessive watery nasal discharge. The patient will have a lot of watery nasal discharge. Okay? So these are the usual complaints of the patient. But this allergic rhinitis can be of two types. Either it can be a seasonal or a perennial allergic rhinitis. Seasonal allergic rhinitis, very good. It is due to pollen grains. So the most common cause of seasonal allergic rhinitis is usually pollen grains, whereas the perennial allergic rhinitis is usually due to the house dust mite. Okay, so you might have heard a lot of times कि मेरे घर में धूल की एलर्जी है, डस्ट की एलर्जी है. What is dust की एलर्जी? Dust की एलर्जी is nothing else, but usually they have allergy to this house dust mite, after which they develop allergic rhinitis. समझ गए अभी? So that's the important thing that you need to remember. Perennial means throughout the year. Season, that means only in specific season. Usually it is seen during spring season. ठीक है? Treatment is what? Definitely. So please remember, for investigations, what will be seen? As it is an allergic condition, it is which type of hypersensitivity? It is a type 1 hypersensitivity, that is anaphylaxis, right? So investigations which are there usually. So please remember, investigations will show that there will be increased levels of eosinophils, because we know in all allergic condition there will be eosinophilia which will be seen. Along with that, the patient will have increased levels of IgE levels, immunoglobulin E levels. Treatment will be definitely during the episode, we need to give patient antihistaminics. Okay, because the problem is there is degranulation of the mast cells, and that causes a lot of release of histamine. That leads to vasodilation in the nasal mucosa, and that causes a lot of nasal discharge in the patient. Okay? So usually we give antihistaminics to the patient like cetirizine, levocetirizine, like drugs can be given. And definitely the second thing that you need to tell the patient is avoid the allergen. Avoid the allergen. Okay? Chalo. Moving further is vasomotor rhinitis. In vasomotor rhinitis is what? Here also the patient will have same complaint. There will be excessive nasal discharge. Usually a excessive nasal watery discharge will be there. But here the patient does not have the excessive watery nasal discharge on exposure to allergen. Here the patient has this complaint on cold exposure. Here the patient has this complaint on cold exposure. Tell me the treatment of this condition. I'm telling you rest of the things. Tell me the treatment of this condition. Very good. Okay, on cold exposure, what will happen? Definitely there will be increased parasympathetic activity. Okay, on cold exposure, there is increased parasympathetic activity of the nasal mucosa, and the parasympathetic innervation to the nasal mucosa is given by the median nerve, also known as nerve of pterygoid canal. So on cold exposure, when this median nerve is stimulated, more parasympathetic activity, therefore more and more watery nasal discharge is produced in the patient. Treatment for this condition is what is called as median nervectomy. Treatment for this condition is what is called as median nervectomy. That you need to remember. Okay? Hello. Next important is this one. This is nothing but a polyp. Now we know what is a polyp. Polyp is nothing but the edematous mucosa. Polyp is nothing but a edematous mucosa definitely. Okay? So that's the important thing. Please remember edematous hanging mucosa. So prolapsed pedunculated edematous mucosa is a polyp. Now this polyps in the nose can be of two types. Either it is called as an antrochoanal polyp or it can be a ethmoidal nasal polyp. If I talk about the antrochoanal polyp, it is also known as the Killian's polyp. Okay, antrochoanal polyp is also known as the Killian's polyp, and ethmoidal nasal polyp can also be referred to as the only nasal polyp. Okay, so that's the important thing. Important is, okay, so please remember antrochoanal or Killian's polyp. It is more common in children. So you can remember Killian is more common in kids. Okay, so antrochoanal or Killian's polyp is more common in children. Why it is called as antrochoanal? Because it starts growing from the antrum or the maxillary sinus and it grows towards the choana. Okay, so it is known as the antrochoanal polyp, which is more common in children, whereas ethmoidal nasal polyp is more common in adults. Next important is, usually most common cause for antrochoanal polyp is a chronic infection. So what did I tell you? That infections will cause inflammation, and inflammation will cause edema. And if there is edema of the mucosa, and if the mucosa starts hanging out, that is what is a polyp. So therefore, recurrent chronic infection in a child will cause antrochoanal polyp. But ethmoidal nasal polyp may the cause is chronic allergy, because allergy also causes inflammation, and inflammation again leads to edema, and that leads to again a prolapsed edematous mucosa known as polyp. Type usually, please remember, antrochoanal polyp which is there now, it is unilateral and it is single. It is usually unilateral and single, but the ethmoidal nasal polyp is usually bilateral. It is usually bilateral and it is multiple. Okay, the ethmoidal nasal polyp, it is bilateral and multiple. If I talk about the treatment in this patient, antrochoanal polyp may, the first line management is a surgery. So therefore we will go for a FES. Okay, therefore we will go for a FES, that is functional endoscopic sinus surgery. If that is not an option, you can mark it as an endoscopic polypectomy. Okay? Whereas ethmoidal nasal polyps may, in an adult, the cause is mainly allergy. So here definitely you will try medical management first. And medical management is tried usually with the help of a steroid nasal spray. That is a fluticasone spray vagara can be tried. But if the steroid nasal spray fails, then definitely you will go for a surgery, and that is what is FES, functional endoscopic sinus surgery. Okay, this is what is the ethmoidal nasal polyp which can be seen on a nasal endoscopy in the patient. Okay, now answer this question. Here we have a patient. This was twice asked in your examination. Here we have a patient with a known case of bronchial asthma who develops ethmoidal nasal polyps. He will be allergic to which drugs? Okay, he will be allergic to which drugs? It's a known case of bronchial asthma. He has developed ethmoidal nasal polyps. Why? Because we know that bronchial asthma patients are atopic. That means at a higher risk of developing multiple allergies. So here the patient might have developed like the dust allergy. Okay, due to that, definitely the patient has developed this ethmoidal nasal polyps also. Okay, so therefore, now he will be allergic to which of the drugs? Please let me know that. He will be allergic to which drugs? What is this triad called as? What is this Sarkari triad called as? अरे म्यूकर पे कहा जा रहे हो, पहले ये आंसर कर दो. What is this triad called as? This is the classical previous year question है, अभी का आया हुआ है. This is the classical Samter's triad. Please remember, this is the classical Samter's triad. Okay, so this is the classical Samter's triad, and Samter's triad, the mnemonic can be either BAN or BAP, whatever you find easy. Okay, it can be either BAN or BAP. That is the mnemonic to remember the three features of the Samter stride. And what are the three features of Samter stride? B goes for bronchial asthma. A goes for allergy to which drugs? A goes for allergy to NSAIDs. Okay, non-steroidal anti-inflammatory drugs. Okay, A goes for allergy to NSAIDs. Mainly it is aspirin. Mainly it is aspirin. And N goes for what? N goes for ethmoidal nasal polyps. Okay, N goes for ethmoidal nasal polyps. Okay, so definitely they are talking about the Samter stride in the question. He's a known case of asthma and he has ethmoidal nasal polyps. So he'll be allergic to which drugs? He will be allergic to NSAIDs mainly, or specifically the one which was there in the option was your aspirin. Okay, so that's the important thing you need to remember. Next is this one. What is this? You can see over here, you can see everything black. Okay, you can see a black eschar which has been formed over here. So if you can see a black eschar on the nose, around the eyes of the patient, or there will be black spots on the palate of this patient, this, no need to tell, everybody is quite aware of this disease, and this is what is called as mucormycosis. This is what is known as mucormycosis. Mucormycosis, we know it is also called as rhino-oculocerebral mucormycosis. Why? Because it does not only involve the nose, but it also involves the orbit. Therefore, it is also called as rhino-orbital cerebral. Okay, why? Because it also involves the brain or the central nervous system. Therefore, it is also known as rhino-orbital cerebral mucormycosis as well. Okay, so that's the important thing you need to remember. We know it is a life-threatening infection, fungal infection, which is life-threatening. Okay, and it is usually caused by a fungus known as the Zygomycetes species. And in Zygomycetes species, the more common one which is responsible is not the mucor, it is the rhizopus. Okay, more common one is the rhizopus followed by mucor. Okay, and it is commonly seen in which patients? Usually it is more commonly seen in immunocompromised patient. Who are the immunocompromised patient? Like an elderly diabetic patient, or a HIV positive patient, or a patient who is taking corticosteroids for a very long duration of time. All of these immunocompromised patient. Even a COVID-19 patient who is taking high dose corticosteroids. Okay, so obviously all of these patients are at high risk of developing mucormycosis. Now, why this black eschar is formed? Because we know that mucor is an angioinvasive fungus. What do I mean by angioinvasive? That means this fungus will damage the blood vessels as well. As it causes damage to the blood vessel, there will be decreased blood supply, and that causes ischemia, and finally ischemia leads to necrosis. And if there is necrosis, everything appears black. So that's the reason you will find everything black in a case of mucormycosis. Everything will be black in a case of mucormycosis. Okay, definitely that's important to be remembered. Yes, very good all of you. What is done for investigation? First line, tell me that. Okay, very good. All of you are right. Drug of choice is definitely LAMB. That is liposomal amphotericin B. We don't use the conventional amphotericin B. If LAMB is an option, mark LAMB as the best answer. If LAMB is not there, then you can mark it as amphotericin B. Okay. Investigation. What is the first line investigation? Is it a MRI head or it is a nasal swab for mucor? This was a previous year NEET-PG 2022 question. What is the first line investigation for a case of mucormycosis? Is it a MRI head or is it a nasal swab for mucor? But if this talk about treatment of choice cannot be LAMB, because it can be the drug of choice, because it will not eliminate this eschar. Na eschar to हमें निकालना ही पड़ेगा. And if we are trying to remove the necrotic tissue, the dead necrotic tissue, that is what is called as debridement. So all the dead necrotic tissue will be removed, that is debridement. And if the orbit is removed, you are also telling me that answer. So yes, black turbinate sign will be seen. So first line will be a MRI head. Please remember, first line is always a MRI head. The reason is, first we will try to rule out any cerebral involvement. हमें क्या देखना है कि brain involve हुआ है या नहीं हुआ है, because our management will change accordingly. That's the reason why the first line is always MRI head. Please remember. Okay, the first line is always MRI head. Then definitely you will also take a nasal swab for mucor, but the first line will always be a MRI head. Okay, so that is to be remembered. That was the question in the recent NEET-PG examination. So debridement, with or without. If the orbit is involved, then we will also remove the orbit. What is that procedure called as? What is that surgery called as when we are removing the orbit? Okay, if the orbit is involved, we will also remove the orbit. What is that procedure called as, guys? What is that procedure called as? If the orbit is involved, definitely we will also remove the orbit. What is that procedure known as? Jaldi se. What is that procedure called as? Anybody? So please remember, a lot of you make mistake over there, and that's the reason why I'm asking you. It is not evisceration, it is not enucleation, it is exenteration. Please remember, it is exenteration. Yes, it is not enucleation, that I knew. Okay, enucleation is removal of the eyeball. Here the orbit is involved, therefore we will also remove the walls of the orbit, the bones of the orbit. That is the reason why it is called as exenteration. Okay, so it's different. Then next, here this is the malignancy of the olfactory nerve. Please tell me, what is the malignancy of olfactory nerve called as? So this is the malignancy of the olfactory nerve. We know olfactory nerve is the first cranial nerve, as well as it is the smallest cranial nerve as well, and it is responsible for the sense of smell. Usually in the upper part, or the upper 1/3 of the nasal cavity from inside, we have the olfactory epithelium, which will sense the smells, various smells. And this olfactory epithelium will have these olfactory neurons attached to it, which will cross the cribriform plate of the ethmoid bone, and then they will enter into the cranial cavity. In the cranial cavity, all these olfactory neurons will combine together, form the olfactory bulb. This olfactory bulb will continue into the olfactory nerve, which will go till the olfactory cortex in the temporal lobe, and there the processing of the smell will occur. Okay, which kind of smell it is, you will get to know over there. Okay, so malignancy of this olfactory nerve is what is called as, in the image as you can see on the MRI, because it is a malignancy of the nerve, therefore the investigation of choice will definitely be a MRI. Okay, for any neural tissue. This is what is called as esthesioneuroblastoma. This is what is known as a esthesioneuroblastoma. Esthesio का मतलब होता है sensations, and neuro का मतलब होता है nerve. So the nerve which carries sensation, a tumor arising from that, or a malignancy arising from that, it is a esthesioneuroblastoma. Yes, the patient will have complete loss of sense of smell, that is anosmia will be there. And you can see this is a malignancy or a cancer, therefore the orbit or the brain, all of them can be involved as well. Treatment is surgical excision definitely. Okay, that's important. Just make the diagnosis and then we will call off the session for today. Okay, then I'll be starting tomorrow with nasal septum, and then 2 or 3 diseases of the nose, CSF rhinorrhea, epistaxis, and finally I'll be taking up over with ear finally. Okay. So a person comes with complaints of infertility and gives history of anosmia. Anosmia is complete loss of sense of smell. What is the diagnosis? Straight one liner. Infertility with anosmia. And this infertility which is there now, I will also tell you that here the patient is having decreased FSH and LH values. That is, this is a case of hypogonadotropic hypogonadism. It is a case of hypogonadotropic hypogonadism. So infertility with anosmia. Answer this faster. What is the diagnosis in this condition? Hopefully some of you will be able to answer. Which syndrome it is? Which syndrome it is, anybody? So infertility with anosmia, which is the syndrome that is commonly seen? That is classically known as the Kallmann syndrome. Please remember, it is known as the Kallmann syndrome. Please remember, it is known as the Kallmann syndrome. This was a previous year question. Don't forget that. Okay? That's important. Kallmann syndrome is a previous year question. Infertility along with anosmia. That is what is seen. Thank you so much for today. So let's continue with the remaining part of the nose, and then we'll continue with ear tomorrow. Okay? Chalo. Hopefully you enjoyed the session, and thank you for being there. Thank you for answering all the questions, and take care. Good night. And tomorrow it will be in the afternoon at 12 p.m. Okay, so be updated. Thank you so much.